Good morning, everyone. My name is Kathy Wynn. I'm one of the athletic trainers with Memorial Hermann. I'll be the MC for the first half of the day. Our first presenter is Dr. Raj Shani. He's an orthopedic surgeon and assistant professor with the Department of Orthopedic Surgery and the McGovern Medical School at the University of Texas Health Science Center at Houston. He's affiliated with Memorial Hermann Rocket Sports Medicine Institute. He received his bachelor's from Washington University in St. Louis and his medical degree from Baylor College of Medicine. He completed his orthopedic residency at University of Texas Medical Branch at Galveston and his sports medicine orthopedic fellowship at the Emory Orthopedic and Sports Medicine Center in Atlanta. He is a team physician with the University of St. Thomas, St. Pius X, and Lutheran North High Schools, River Oaks Clay Court Championships, and various Ironman events. Today, Dr. Shani will be presenting on current cartilage repair and preservation techniques.
Thank you, Kathy, for that warm introduction, and I'm honored to be here to speak on this important topic. This topic is an interesting one because you blink and it'll change in 2 minutes. Cartilage techniques are rapidly changing, and in 5 years from now, this may be a completely outdated talk, but I'm very excited to talk to you about this important topic. I have no disclosures, and some of the objectives of this will be to discuss epidemiology and basic science. I'll try not to bore you too much with the basic science. Then we'll look at some of the therapeutic approaches, some treatment outcomes, and discuss some cases. We have time. And I put these pictures up here because I wanted to show that cartilage injuries can occur to any athlete, any type of recreational or high-level athlete. It affects all of us. So it's important to think about that when we discuss treatment options. And why are we here today? These lesions are common in athletes. This was a study done looking at the prevalence of chondral defects in athletes in these, just a straight MRI study of all athletes, and they found that there was 36% of athletes that just had cartilage injuries, whether they knew it or not. 14% of these were asymptomatic at the time. 37% occurred on the patellofemoral joint. The medial femoral condyle was involved more than the lateral femoral condyle. And 7% were associated with meniscus tears, and they're highly associated with ACL and especially patellofemoral dislocations, up to 90%, which is a pretty significant amount when you see these patellofemoral dislocations, that they likely do have some sort of cartilage injury that occurred with it. So just to review basic science of cartilage, it's broken down into the superficial, transitional, deep, and the tide mark. Each of these zones have their particular mechanical function, but the important part is to know that the tide mark is the distinction between avascular and aneural that occurs in the cartilage area and into the bone, which is very vascular, which is very neural. And when the injury goes past the tide mark, that's typically when athletes have more pain and more dysfunction and can feel the injury. So here's what I mean, the tide mark right here. This is all the superficial and transitional zones of cartilage, and it goes typically below the tide mark when it's a full thickness lesion. So again, here's a cartilage classification from grade 1 to a very minor lesion, grade 2 being fissures, grade 3 being a partial thickness lesion, and then grade 4 being a full thickness lesion. As you can see, it's greater than 1.5 centimeters in depth-wise usually. So the real question and the art, I think, in medicine and taking care of these athletes is trying to understand what do we do when we see these cartilage injuries? As you can see from the previous study, these cartilage injuries are common, but do all of them need treatment? This was a quote from Voltaire. He says, "The art of medicine consists in amusing the patient while sometimes nature cures the disease." So skillful neglect is sometimes acceptable in these athletes. Sometimes given with time, they're able to cure and able to actually play. Their symptoms may oscillate and they may be able to cope throughout the season until something else can be addressed. So just because we see a cartilage injury on an MRI for a patient doesn't mean that's what's causing their pain, or does it need to be addressed with surgery. When we look at non-operative treatment options of cartilage, it starts with physical therapy, weight reduction, non-steroidal anti-inflammatories, activity modifications, brace, injections of which can be simple as steroid, hyaluronic acid, platelet-rich plasma, stem cells, and growth factors. So these are a series of tools we have in our bag before we move towards surgical treatments and getting to what we're going to talk about the rest of our lecture today. So I had a mentor when I was training in fellowship that used to tell me that cartilage is the end game. The whole knee is designed to protect the cartilage. Obviously, there's some form and function that's involved with some of the other things that are in the knee, but the end game and the way things are designed as far as your ligaments, your meniscus, and your bone are designed to protect the cartilage. And when those things are not working correctly, that's when the cartilage gets damaged. And since we are in sports medicine, I decided to make a little analogy between the quarterback and his lineman. And so the quarterback right here is the cartilage, and all these structures, the meniscus, the ligaments, the bone, the joint fluid, and the fat pad are all there to protect the cartilage. And when one of these are not in alignment, or none of these are torn or not present, that's when this defender can go in and sack the quarterback, and you have a cartilage injury. So when we think about this, the medial and lateral meniscus, the ACL, the bone, whether it's alignment issues, and our next speaker is going to be talking about alignment issues, these are all very important to correct prior to correcting any cartilage injury. So specifically, when we look at the meniscus, if there's a damage to the meniscus, it must be repaired or transplanted. So if you have a deficient meniscus, a patient maybe have a previous meniscectomy, that's a cartilage injury, and you're thinking of doing a cartilage restoration procedure, you can't address it until you do meniscus transplant or repair. Ligaments, if there's an ACL, MCL, or any type of ligaments instability, that would also need to be addressed along with any osteotomy or joint capsule or rheumatological issue that may be addressing attacking the cartilage prior to any cartilage restoration procedure. These would need to be addressed before moving on to the techniques we'll be discussing later. So again, this is a kind of a generic treatment algorithm, and you can see right here we start off with chondral defects. But the first thing that it goes into, it says identifying modifiable risk factors. So these risk factors, the BMI, the meniscal deficiency, the limb alignment must be addressed. Then you can go in and talk about, okay, where's the lesion? Is it on the femoral condyle, patella? What's the size of the lesion? Greater than 2 centimeters, less than 2 centimeters? How active is the athlete? And then based off of that, you can go in and find the appropriate treatment measures. But first, it ends up, you have to look at these modifiable risk factors. Then you look where the lesion is. Then you look at the size. And then you look at how active the patient is. And if you can follow that, then you can pretty much treat any cartilage injury. So when we look at cartilage restoration technique, I like to break it down into 3 main categories. The palliative, which is the chondroplasty and debridement. Reparative, which is subchondral drilling, abrasion, arthroplasty, and microfracture. And with reparative, we're trying to use the body's own machinery to regrow cartilage. Whereas reconstructive, we're using live cartilage cells or transferring cartilage and bone together as a unit into the defect to have immediate cartilage, hyaline cartilage available. So in palliative, this is typically the chondroplasty. So this is typically the athlete who's complaining of mechanical symptoms, mild pain, is in season, and wants a quick treatment measure to get back to play. These have, in this case, you can see a chondral flap. This was debrided with a shaving device. Allows for fast recovery, and best to alleviate mechanical symptoms. And usually for the in-season athlete who wants to get back and doesn't have too much pain. And it actually works. Arthroscopic mechanical chondroplasty has been studied Here's a study out of Orthopedic Journal of Sports Medicine that shows that it had success rate, very high success rates. Even in NFL players return to play after chondroplasty with knee and football athletes, A67 return to play within 8 months. So there is a portion of patients that would benefit from a chondroplasty, even though it's not really fixing the underlying cartilage disease. It's getting rid of some of the mechanical symptoms and allowing them to return to play. When we think about doing reparative techniques in our younger athletes, especially our skeletally mature, sometimes they get an osteochondral lesion or OCD lesion. Typically, this lesion leads to a cartilage deficit kind of right next to the mediofemoral condyle, and it can be within the area where it's considered stable. By stable, meaning that it's not flapped off, it's just causing pain, and there is a chance for it to heal from within. So typically, if we don't see fluid on an MRI, what we can do is we can drill below the cartilage surface to try to stimulate vascular channels, and these vascular channels will then help regrow, reconnect the cartilage. This is very minimally invasive. It can be done X-ray guided. Now, what happens when the lesion is unstable, when it's flapped off, but still partially connected, and you have a patient who's open growth plates, a young teenager with an unstable lesion? Well, we can fix this typically with screws. These can be bioabsorbable metal screws. And in this case, we use metal screws to stabilize the lesion. This can be done open or arthroscopic, but usually requires hardware removal after 6 weeks, and we keep them non-weight bearing during the 6-week period of time. So now what happens when there is no cartilage or there's a complete loss or it's detached? Well, in the early 90s, Stedman came up with microfracture. The microfracture idea behind that is to remove the calcified cartilage lesion and that tide mark, poke holes in the bone, and allow new cartilage to kind of grow, or new cells to kind of grow into this area. Typically, it's good indicated for less than 2 centimeter square lesions. It's done arthroscopically. It can be done with an awl, as you can see here, or drilling. Drilling has been done in recent studies to have better results. The problem with microfracture is that the cartilage that is created is fibrocartilage, which is biomechanically inferior to your native hyaline cartilage. Afterwards, you're non-weight bearing for 6 weeks, and typically you involve doing some part of rehab with the CPM. Initially, the results have been very favorable in high-level athletes, but they tend to decline after 2 to 5 years because the fibrocartilage isn't durable, and the return to play can be very variable from only 44 to 83%. And it's usually multifactorial. It's age, type of sport, and the size of the lesion. So because of the shortcomings of microfracture, we do now microfracture plus. And what we do is we add something to the microfracture to get more hyaline-like cartilage. And in this case, this is one of the options. We have biocartilage, which we use the extracellular cartilage matrix of cartilage with all its growth factors and add that into the defect. So instead of just leaving microfracture and do that, we add the biocartilage you can see here in this trochlear defect to increase the cartilage quality. And then in this study, it showed that it actually increased the cartilage quality of tissue up to threefold compared to microfracture alone. And you can mix it with platelet-rich plasma, bone marrow, or even whole blood. Another technique is when we use particulated juvenile allograft cartilage. That's an allograft cartilage that's prepackaged and added to the microfracture. So in this technique, we've added the cartilage-like cells into the cartilage defect along with doing a microfracture. We stabilize it with fibrin glue, and it can be actually used for lesions up to 4 centimeters squared. So when we look at now, we've talked about palliative, reparative, then we look at reconstructive, or what we call restorative cartilage. And I really consider this the gold standard. Everything else is in my mind something you can do, but not as good as doing one of these techniques if your goal is to try to recreate hyaline cartilage. And this includes autologous chondrocyte implantation, osteochondral autograft transfer, or OAT, or osteochondral allograft transfer, or OCA. So this technique was developed in the 90s, and it continued to be refined over the years. Basic premise behind this is it's a 2-stage procedure. You identify the cartilage lesion, you biopsy it, and you take about 2 Tic Tacs size of cartilage, and you send that off to the lab. The lab grows the cartilage, and then 6 weeks later, you reinsert the cartilage. And typically, it was initially done with a tibial periosteal flap, but later techniques, as you'll see later, as you'll see in the next slide, that has been continually refined. And as I said, this has gone through different generations. The first generation was in the 90s, where we took a periosteal flap and placed it into the lesion. Now we use a collagen membrane. That was further designed, further refined. We use a collagen matrix along with fibrin glue. And what the fourth generation here is, which is the most exciting, is when we started using some of the biology, when we used chondrocytes, specifically stem cells, other scaffolds to help with the recreation of cartilage. The ACI has been very successful, 82% successful outcomes. Larger lesions are more at risk of failures, but this can typically be in your tool bag for larger lesions up to 2 to 4 centimeters. So with ACI, while it is great for restoring cartilage, sometimes there is more of a bone deficit. And this is when we do more of the restorative techniques, including OATS, OCA, or even biouni. And the great thing about these is that on day one, the athlete has hyaline cartilage. It's not like the reparative where we're waiting for cartilage to kind of grow in. This is a day one, they have native hyaline cartilage. So in the first technique, we use osteochondral autograft transplantation, OATS, where we harvest cartilage from part of the knee and insert it into the defect. This is typically done for high demand athletes and younger patients, and focal lesions less than 2 centimeters. Because we're basically Robert Peter to pay Paul, we usually try to avoid weight-bearing areas of cartilage and do it for smaller lesions. OATS have a very good and successful outcomes. They're typically used for, in this study, they were used for competitive athletes with traumatic chondral defects. They had 13 out of 20 patients with a 4-year follow-up. The mean return to play for all 20 was 83 days, which is very fast, and all returned to the previous level of sports. Most of the chondral lesions were on the lateral femoral condyle, with 40% being on the medial femoral condyle. So now what happens if it's larger lesions and it involves the bone and OATS is not really an option for you because of the size of the lesion? Well, that's when we do an osteochondral allograft transplantation. We have either pre-fashioned plugs or we use a part of the femoral condyle and harvest a piece of bone and cartilage to insert into the area, generally for lesions greater than 2 centimeters squared. What are the advantages? Single stage, it can accommodate a large defect. It can take care of uncontained lesions. By what I mean by uncontained is that with reparative, you're relying for like a window or basically a area where normal cartilage is around it. And uncontained lesions is usually on the side, and that's very difficult with microfracture or reparative techniques to stabilize those lesions. There's no donor site morbidity, and it can be used for primary revisions, and their favorable outcomes over the last 10 years because it's been widely studied. The return to play data is pretty good. The downside is the cost. It's over $12,000, and then the availability. So when you order it, you got to use it pretty quickly, and if you don't use it, it's a complete waste to the hospital, and it's caused to be a considerable cost. There is a slight concern of possible immunogenic response, but I think that's very minimal. It's an open technique as opposed to an arthroscopic technique, and generally involves a long rehab up to over a year. Here's a meta-analysis looking at 5 studies with long-term follow-up. 291 patients, 67% had femoral condyle, 29% had tibial plateau, and 4% had patellofemoral. The mean failure rate over the 12-year period, which is 25%, 75% success rate. And patellofemoral lesions had a higher rate of revision, up to 83%. So in my mind, I usually use the OCAs and OATS for chondral lesions, but for patellofemoral joints, I like the ACIs better. When you do have a larger lesions, more oblong lesions, this is when you can use a biouni, which is almost like doing a partial knee replacement, but doing it with cartilage and allograft. They're pre-packaged grafts, so you'll get like this hemicondyle that will allow you to cut an oblong hole and allow you to insert it with precise cutting jigs. So this was an emerging technique that I wanted to kind of point out. It's called Cartilage. And so the idea behind this is that because OATS and OCA have their limits and deficiencies, This group of scientists discovered that coral has a very high similar biomechanics as bone. So they harvested all these coral and they inserted it into rats and mice, and they saw that this had good cartilage ability to heal. And so now we translated this to humans, and so they harvested this coral from out in I believe, the Mediterranean Sea, and they have this large amount, and they fashioned it into a bone-like substitute that can be inserted into the chondral defect and allow for a combination of reconstructive, because it's allowing to reconstruct the bone, but also reparative, because the cartilage can grow from within and you can augment with other reparative techniques. The main benefit of this is that it avoids the cost of osteochondral allograft. You miss the cost of being $12,000 and $15,000, and it's off the shelf. So if I'm in surgery and I see this lesion and I haven't ordered a osteochondral allograft, well, this is a great technique it can use and be a one-stage technique to allow the patient to heal. So now when we open up our algorithm, some of the emerging techniques, on this side of the diagram, we had our surgical techniques, manufacturers, biological scaffolds, but newer techniques that are still coming about that still need a lot more research are the exosome-based therapies, gene therapies, cell-based therapies. All of these can work in conjunction with these techniques. And two of the ones I want to touch on are exosomes, which are small extracellular vesicles that can be inserted that have mesenchymal mesenchymal stem cells, and gene therapy, which can use a therapeutic nuclease to modify the cartilage repair. But honestly, it still confused me, and it still confuses a lot of doctors how well this works. I think longer-term studies need to be done to see where this is going to be going. And as I said at the beginning of this talk, 5 years later, this may be the headline talking about exosomes and gene therapy when it comes to cartilage regrowth. So when we look at rehabilitation guidelines, the best thing about chondroplasty is that it can get the patient back to return to play quickly. As opposed to reparative and restorative, usually these involve a period of non-weight bearing to allow the lesion to heal. CPM for augmentation, when we use some sort of fibrin glue, we want to limit their range of motion for the first 48 hours. Trochlear lesions are a little bit easier to rehab because you can weight bear them immediately as long as they're in extension. Generally, we want to get back to squats by 3 months. Return to play, usually 6 months and beyond. And then similar return to play criteria as we look at ACL reconstruction. So I have a few case studies of my own. This was a 21-year-old collegiate baseball player who presented to me as a pitcher. His primary complaint was swelling, and after playing, he had pain with deep flexion. He had no mechanical symptoms and localized pain. So we can see here's his lesion. You can see it clearly on X-ray right here, the change in cartilage and bone. And you can see right here on this lesion where the cartilage and bone are involved, there's significant bone marrow edema. On the sagittal view, you can see significantly on the weight-bearing surface of the medial femoral condyle that significant bone and cartilage were involved. We performed an arthroscopy, and on the arthroscopy, we saw this cartilage lesion that was flapped off. On probing, it was delaminated and unsalvageable. We measured it and removed it and measured about 2.5 by 2 centimeters. And we elected to proceed with an OCA on him. We harvested the graft and placed it in this plot. You can see how it fills the defect quite nicely. And he was able to return to sports and has been playing sports for the last 2 years without any complications. Our second case today is a 27-year-old male who actually injured his knee while bowling. Don't ask me how. But he reported catching and swelling. He had an inability to return to activities. And in this MRI, you can see a full-thickness cartilage lesion. And in this case, because the bone wasn't involved, and he wanted a quicker recovery, we went into a microfracture. We microfractured, and we augmented with biocartilage. So you can see the biocartilage was mixed with bone marrow aspirate concentration. And he's done quite well over the last 2 years as well. Our final case was a 40-year-old had a traumatic injury after skiing. You can see the lesion right here on the X-ray. You can see that discontinuity of bone right there. He had medial joint line tenderness, pain with deep flexion, and stable ligaments. On the arthroscopic image, you can see he had this full-thickness cartilage lesion. And we ended up using a hybrid mosaic technique where we put a couple of plugs, and then we augmented the area here with biocartilage to fill in the areas where the graft didn't fit well. And he's done quite well. He's about 3 months out of surgery and just continuing with the rehab process. With that, are there any questions or concerns? Okay. Well, thank you for your time. You're
Our next presenter is Dr. Brennan Roper. He's a pediatric orthopedic surgeon and assistant professor with the Department of Orthopedic Surgery and the McGovern Medical School at the University of Texas Health Science Center at Houston. He's affiliated with Memorial Hermann Rocket Sports Medicine Institute. He has a combined total of 3 bachelor's degrees from West Texas A&M University and the University of Texas at Austin. He received his medical degree and completed his orthopedic residency at University of Texas Health Science Center at Houston. He completed his pediatric orthopedic surgery fellowship at Children's Hospital of Colorado. Today, Dr. Roper will be discussing limb alignment and leg length discrepancies.
All right. Good morning. As I said, I'm Dr. Roper. I'm a pediatric orthopedic surgeon. We're going to talk a little bit about limb length alignment, mostly in the adolescent athlete, but we'll start from birth and go all the way through. As you interact more with patients and patients' parents, you realize that number one, everybody is an athlete regardless of their age. And if you watch the Nike commercials about Rory and Tiger, if you're not trained them by age 1, you're already behind. So we'll make sure we know what to be looking for. Most importantly, we don't know abnormal if we don't know normal. So we'll talk about what normal development looks like. I'll use a phrase of physiological malalignment. That is the first decade of life where we all look funny, we walk funny, we run funny. That is the normal, the expectation. When we fall outside of that normal is when we should be concerned. And then really as we get into the second decade of life, there are some things that we can correct or should be looking to correct. We'll touch on a couple physical exam pros. I know y'all are experts in that and probably could teach me a couple things about the physical exam, but we'll touch on the things that are most important to be looking for these deformities. And we'll go through 3 major discrepancies or deformities that we're seeing commonly in these athletes. This is not all encompassing. This doesn't include everything. That could be a full day just looking at limb length alignment. But these are the big hitters. So first things first, can't have abnormal without normal. And so understanding all children progress through a varying stage of what I call physiologic malalignment. And so we'll see knees in funky positions. We'll see rotation in funky positions. Again, that's expected during the first decade, but we should see that progress and become more quote unquote normal or consistent with the adult population. This does correct spontaneously. And so commonly we'll have patients coming in who are looking for braces, looking for therapy, looking for surgeries when they're 5 years old. And We all know that every 5-year-old is destined to be a superstar, and so people want to take care of their kids early on and make sure that they are right. Sometimes, as Dr. Shani was talking about, the best treatment is no treatment and watching and observing and letting the body do what they can do much better than we can. We'll talk a little bit about limb length, inversion, bow-leggedness, torsion. We'll get through all those here in a second. First being limb length discrepancy, and I say there is expected abnormalities or expected variations. Limb length discrepancy is not normal. So if you're noticing 1 or 2 millimeters, number one, you have a great eye to measure that much clinically. But number two, that's not a big deal. But if we are noticing a very noticeable or significant difference, that is usually abnormal. In the early stages, that can be a hip dislocation. And so picking that up and seeing somebody and getting that actually measured or looked at can change their outcome significantly. As we're getting a little bit older, it can represent other pathologies, whether that's what we see here with a congenital femoral focal deficiency, a hemihypertrophy, or here we're seeing a blounce, which is more of a coronal plane angular deformity than a limb length. But all of these are things that if we're seeing them in early childhood, we check them out and we can address them. Femoral version is probably one of the most common reasons that I'm seeing the young patient come through my office. Again, athletes at age 5 who are destined to be superstars, and we're looking to cash in on the NIL money early. We want to make sure that their in-towing is not going to prevent that from happening. So commonly we're having parents come through saying that ever since they started walking at 10 months of age, pretty advanced, we know, they've been in-towing. And so they want to know, how do we fix that? How do we make that better? Usually there's nothing to do. So when we're born, our version of our femoral neck is about 40 to 45 degrees, much more significant than any of us sitting here in this room today. And we do see that decline rather rapidly during the first half decade, and then a little slower progression, but still progression towards normal during the second half of that decade. That continues through pre-puberty, puberty, and into the teenage years until we should all settle around that 10 to 15 degrees, but certainly something that we watch progressively change. This is probably the most variable in the deformity correction or the malalignment that we see. Some people may be correcting, or some infants, children may be corrected by 5, 6 years of age to a normal. Some may take all the way till they're 18, 19, 20 years of age. And so most commonly we need some reassurance, but showing parents the chart, showing parents the normal expectation, and knowing that for yourselves when you're treating younger athletes is helpful knowledge. Similarly, we have a lot of patients coming in who parents are concerned that they're bow-legged. Again, we don't want to limit their athletic career, and so when they're 2 and they remain bow-legged, there's a concern. That is normal. So usually we see a progression from 0 to 2. As we start weight bearing from 12 to 18 months, the body's not used to that. We've been sitting, crawling, laying on our belly, and now we're upright and we're bipedal. And so the stresses going through the bones will induce a varus deformity, both in the femurs and in the tibias. And as long as we're not seeing focal deformities in one of those and it's a more global deformity, that is the expected norm. As the body starts to be more bipedal and we're putting weight through the extremities, we start to see it actually overcorrect and become a little bit of a valgus deformity from 2 to 5. Around 5 to 8 is when we should correct into a more neutral stance. Again, this is variable. So if you haven't corrected perfectly by 8 years of age, that doesn't mean that you are behind. We just need to continue to watch. And if it creeps into the double digits or into the teenage years, that's when we talk about addressing it. Torsion is something else that will show up in the clinic. That's, again, contributing to the in-towing early on, but something that we'll see correct itself within the first half decade of life. Most commonly, we're born with about 10 to 15 degrees of internal tibial torsion, and over the first decade, we'll progress to being externally rotated. We'll see about a little bit later talking about the prone thigh-foot angle exam, which helps determine what torsion we're seeing. So when is it not normal? Those are the normalities. That's what we expect. That's what we can tell parents, reassure parents. Those are things that we will see correct. When it's not normal, what do we need to do and how do we intervene? So for the longest time, orthopedic surgeons have been really good at dismissing these. You'll come in and they say, hey, not a big deal. It'll correct. Most specifically, limb length discrepancy, where we see patients come in with one leg longer than the other. Parents are concerned and they've been told, hey, it's not that big of a deal. You can use a shoe lift, you cannot, but there's nothing to do. The problem with that is most of that's been anecdotal. It's been surgeons or other offices telling them that we don't really see a difference. We don't have a lot of people come back. So it's probably not a problem, but we didn't have data to back that up. And so in the past couple of decades, there have been multiple studies looking at what do we do? When is it relevant? When does it matter? And we'll talk about some of that data today. So again, let's look at the normal population. Of all of us sitting in this room, over half of us have at least a 5 millimeter difference. So asymmetry is the norm. It just should not be a dramatic asymmetry. Again, if you're picking up less than a 5 millimeter difference on your clinical exam, kudos to you. That's pretty impressive. But most of the time, we're not going to notice a difference less than 5 millimeters, really less than 1 centimeter. About 1 in 5 of us in this room have up to a 1 centimeter discrepancy, so one leg 1 centimeter longer than the other. Again, we accommodate this well, and it does not cause significant differences in our gait pattern, our running pattern, or increased injuries or risk of injuries. About 1 in 1,000 will have a 2 centimeter difference, and that's when we're talking about seeing intervention or needing to do something. And anecdotally, that's where we were telling people as orthopedic surgeons where we should start addressing it. It just happens, spoiler alert, to bore out in the literature that about 2 centimeters is the threshold when we should start talking about doing something. It's also important to notice the difference in a true versus a functional limb length discrepancy. So true discrepancy is radiographically measured that one leg is longer or shorter than the other, whereas functional is related to muscular or soft tissue balance, something that we're accommodating for, whether it's spasticity, tightness, contractures, injury, where we're actually inducing our own leg length discrepancy. That's where y'all come in, because y'all can correct that without us ever having to do anything surgically or interventionally. So if we look through systematic reviews, for a long time we've been trying to define, again, what is the actual data? Where do we see actual results, or where do we see actual differences that cause clinical and functional differences? If you look through this chart, there's some that go as low as 6 millimeters difference causes differences. There's some that go as high as 6 centimeters is when we start to see differences, and everywhere in between. Kind of the consistent theme going through this, though, is it always comes back to that 2 centimeter difference, hovering around 2 centimeters. Above that, we're starting to see significant differences. Below that, most of the time, we compensate well. So because this is such a hot topic, and commonly patients coming in with a 5 millimeter difference, a 7 millimeter difference, and parents are very worried that this is going to cause a problem. I've kind of broken this down into many different areas of where we can see either functional or associated differences. So when it comes to standing or posture, have you seen me up here shifting my weight? We all shift a little bit. We all have a little bit of lean back and forth, but what they have seen in papers is that greater than a 10 millimeter difference or greater than a centimeter, we are seeing a little bit more of that postural sway, so transitioning back and forth, and that's used as a surrogate for some sort of functional difference when we're standing and when we are stationary. The one caveat to that is you have to break this into people with true limb length discrepancies and those who have an induced limb length discrepancy. So in this first study that looked at those with a centimeter difference showing some functional difference or increased postural sway, those are in patients who have normal limb lengths, who are symmetric, and then they gave them a shoe insert, so induced a difference. It goes to reason that if you are walking your whole life with symmetric limbs and now somebody gives you a shoe lift and makes you asymmetrical, you're going to accommodate that a little bit differently than someone who has had an existent limb length discrepancy. So looking at populations of patients with a limb length discrepancy at baseline, they've seen that those all the way up to 2 centimeters have no difference in postural sway and have no compensatory mechanisms. And so those with natural limb length discrepancies probably tolerate this a little bit better. When we talk about walking, there's certainly a decreased stance time and a decreased step length on the shorter leg that's been replicated in multiple studies. And there are compensatory mechanisms that we see, obviously more compensatory as we get to a higher limb length discrepancy. So on the longer leg, we're going to be more prone to flex through the hip and flex through the knee, or more prone to a circumduction gait just to try to clear that foot in the swing phase. Whereas the shorter leg, we're going to try to hyperextend or extend fully during our contact phase of the short leg. And we also will at times tiptoe or walk on our toes to try to accommodate the difference. They have shown biomechanically increased ground reaction forces through the long leg most consistently. Here's where some of the controversy comes in this. There have been studies showing increased ground reaction forces in long legs. There's been studies showing increased ground reaction forces in short legs. For me, when you have differing studies and they're all well-done studies showing different outcomes, that means we probably don't have a true definitive answer, and it varies from patient to patient how they're accommodating. But more consistently, we're seeing in the long leg increased ground reaction forces through that extremity. We try to look at muscle recruitment, so getting EMG studies at patients standing, walking, and running. And really, there's not been a huge difference until you're getting into that higher limb length discrepancy, the 3-4 centimeter differences. We're really starting to see noticeable EMG changes in those patients. Running, obviously, we know there's a higher stress placed on the extremity during running versus walking. And really here, you have replication of the same differences. So the ground reaction forces, the compensatory mechanisms. They're also starting to see, as you get a higher limb length discrepancy, you'll have a higher oxygen intake level for those with the discrepancy, as well as increased energy expenditure. So certainly there is something to the compensatory mechanisms that you're working harder. In a high-level athlete where 1/1000% difference is the difference between gold medal or silver medal or bronze medal or not even making the team, this is when that really comes into play. Certainly, there needs to be a little bit more study looking at this, but as you become more advanced in the techniques or the skills you're performing, this probably becomes a little bit more relevant. There's also some associated symptoms that go along with the limb length discrepancy. So lower back pain most commonly reported. Again, it depends on the study based determining what the threshold is, but commonly greater than a centimeter, you can see some increased instance of lower back pain. And in all studies, regardless of the amount of limb length discrepancy. If you correct it either with a shoe lift or for the greater limb length discrepancies with surgical correction, you do see that symptom go away. Interestingly, though, in this realm, they did look at specific college athletes and only college athletes, and they noticed no association between those with a discrepancy and the lower back pain. You can see increased hip pain. As we talked about increased ground reaction forces, it makes sense that the hip in the longer leg is more likely to have some pain. You can have some hip pathology of labral tears and or cartilaginous lesions. And there are studies that are looking at how much matters. So for every centimeter increase, you're having 5% uncoverage of that femoral head, which can lead to asymmetric loading of the femoral head. Stress fractures, kind of the last thing that people have looked at, and certainly there is a reproducible increased rate of stress fractures in the long leg compared to the short leg, and the greater the limb length discrepancy, the greater the risk of those stress fractures. So when you're in the field or when you're in the office, how do you measure this clinically? So two most defined ways. So one is taking the ASIS, using that as your landmark and measuring down to the medial malleolus. This is a little more reproducible because it's trying to replicate what a bone measurement would be. Most consistently, the bony structures on the body are consistent side to side. And so as long as we have hip fully extended, knee fully extended, sitting in a neutral position, you should be able to get a reliable measurement. A surrogate for this in the past has been using the umbilicus, but the problem with this is if you have any pelvic tilt, you can be unnecessarily getting a false read of a limb length discrepancy. So if we're doing this clinically, probably best to measure from ASIS bony landmark down to the medial malleolus. Certainly that's not as reliable as sometimes in our larger athletes, it's harder to find. Sometimes you're not perfectly symmetrical on the ASIS or the medial malleolus, and so there's some built-in discrepancy there. Probably the gold standard is using radiographs. And so radiographs, again, we have to make sure we obtain good radiographs, but once we have them, we can get a more realistic and more reproducible measurement. Keys to this, again, is the same as if we're doing a clinical exam. So we need a neutral pelvis. We need the knees straight, the hips straight, the ankles straight, no contractures, no deformities. Patellas should be straightforward. That's reproducible across all of what we'll talk about today to have a standardized image. You do need to use calibration. So on these images here, you can see that small ball that's measuring 25 millimeters. We insert that knowing exactly how large that sphere is so that we can calibrate our measurements. Far too often, patients come through the clinic and they've been told elsewhere that they have a 3.5 centimeter leg length discrepancy. You look at the x-rays they were given and there's no calibration. When you get an actual calibration, it's something closer to 1.5 or 1. And they were told they need invasive surgery or a major surgery with an osteotomy, when in fact, they've had no symptoms. They need maybe a shoe lift, if anything. And so having calibration there is super important. And then we can use blocks to try to validate what we're seeing on radiographs. Certainly with a calibration ball, we feel confident in our measurements, but if we can verify that with a physical finding by inserting a block equal to the leg length discrepancy that we've seen, if that levels out the pelvis, then we can feel comfortable that that's the true limb length discrepancy we're seeing. So in the middle image here, you can see about a 17 millimeter difference, the right leg longer than the left. When you insert that 1.8 centimeter block underneath, the pelvis neutralizes. So how do we treat this? Again, for a less than 2 centimeter difference, it seems like the old heads were right in their gestalt, and really there's not a whole lot to do interventionally if we have a limb length discrepancy less than 2 centimeters. We can use insoles, we can use orthotics, we can use a small lift. That should be all that we need, and you don't need a full correction. So for patients with a 18 millimeter difference, we don't have to get an 18 millimeter shoe lift. That's uncomfortable. Usually we're not fitting well in the shoes. If we can get a 1 centimeter lift so that we have a less than 1 centimeter difference, that's going to be adequate to get them pain-free, asymptomatic, and all of those things that we're seeing as far as symptomology and biomechanical changes seem to disappear from the previous section. The other thing to talk about here is I would be a proponent, or I'd be a recommending to you to recommend to patients. You do not need custom insoles or custom orthotics. Those can run $600 to $800, and apologies to any orthotists in the room, but over-the-counter has been shown to be just as effective. And so spending $40 to $50 on one on Amazon, especially in a kid who's going to change their shoe size every 6 months, way more affordable and way more reasonable than paying $800 for an orthotic that does the same thing. Now, when we get greater than 2 centimeter differences, that's when we're looking at having a little bit more intervention. And here it says greater than 2 or expected greater than 2. Again, pediatric orthopedic surgeon, so I'm dealing with open growth plates in patients who are growing still. So we can predict if we have a 1.5 centimeter difference at age 11, with remaining growth, it may be greater than 2. And if we can intervene at that point and not need to do major invasive surgery in the future, that's always a win for patients. So speaking of that, that's when guided growth comes into play. And so the way that we do this is we actually tether or we slow down growth on the longer leg to allow the shorter leg to catch up. Now, again, understanding athletes and most importantly, athletes' parents, we never want to decrease their maximal total height. But if we're talking about less than a centimeter difference, we're talking about less than half an inch, that will not be the difference between you making the team or not. And so really going through what we need to do to change this or to correct this in the least invasive way possible is really helpful with parents. So we utilize the growing of the patient on the one side that is shorter to maximize that while we slow down the other side. It's important to know what type of growth and what rate of growth we have so that we know where to target and what's going to be most fruitful for us. The proximal femoral physis does not do much. It's about 3 millimeters per year, so you will rarely see guided growth there. Really, the meat is around the knee. So the distal femoral physis grows 9 millimeters to a centimeter per year, and the proximal tibia grows about 6 millimeters per year. Distal tibia is about 5. These are averages, and so we know that sometimes that will be greater, sometimes that will be slower. Our peak height velocity of growth happens just before puberty onset, and so you may see greater numbers at that point and may see better correction during those years. And on average, women are growing until 14 years and men towards 16. In these images here, you can see a patient with a hemihypertrophy. She has about a 5.5 centimeter difference. We have started guided growth on her with the expectation that within 2 years, we'll have 18 millimeters improvement. We'll give her a break. We'll restart. And ultimately, just by using the distal femoral physis, we should be able to neutralize or make these femurs a little bit more symmetrical. When we miss the boat and we're now dealing with skeleton mature individuals, there are multiple ways to do this. We can shorten a side with an acute osteotomy and compress that. That does well for small differences, but in larger differences, it's usually helpful to try to grow the shorter bone. How we can do this is through a multitude of ways. Previously, this was through a large frame that performed distraction osteogenesis. That's now performed through magnetized growing rods, either intramedullary or extramedullary, which provide new regenerate bone in an extended position. So here you can see a patient with a obviously shorter left femur. We make a small osteotomy and this nail is inserted. Then over time, each day, a magnet on the level of the skin will actually turn the gears inside the magnet and it expands at that osteotomy site to grow new bone in a lengthened position. You can see the difference between the third and fifth picture, where that nail is very close to the screws distally, and then you can see the expansion of the nail. That's how much growth we've achieved in that femur. And then the last photo shows near symmetric femoral lengths there. When we talked about anaversion, so femoral version and then tibial version, we talked about how different it is early childhood, but once we're getting to the teenage years, if we're still seeing significant anaversion, that can become a problem and symptomatic for patients. Again, the normal population is about 10 to 15 degrees of anaversion, and the average tibial version a little more variable, anywhere from 0 to 30 degrees external rotation. We do see differences in gait, and so with increased femoral anaversion, there's dynamic internal rotation of the femur and in the hip, and that can lead to a functional valgus of the knee. Certainly with increased tibial torsion in the external position, that can modify the tracking of the patella and lead to patellar instability as well. With our athletes, this can result in hip pain. So whether it's labral pathology, impingement, or progression to osteoarthritis through cartilaginous injuries, more commonly what we're seeing is patellar instability with that increased rotation, as well as the functional valgus moment on the knee. We're seeing maltracking the patella, lateralization of the patella, and increased lateral forces. And we can't have a sports medicine talk without talking about ACLs. And so with increased femoral eversion, there is a risk of increased ACL stress and ACL rupture due to that functional valgus deformity at the knee. Classically, there has been talk about, does some version of in-toeing actually make you faster? And that originates from studies who have looked at patients who had a neutral or somewhat in-toe rotated foot progression angle actually had increased success in the sprinting world. That does not mean that we should be trying to induce that in patients to make them faster and make the team. How we measure this, so clinically, we should be measuring this with the hip both in flexion and extension. So we'll have the patient supine with the knee and the hip flexed to 90 degrees, measuring how much internal and external rotation we have. We'll also have them prone with the knee extended and the hip still flexed, measuring internal and external rotation. Measuring both gives you a little bit better indication of what the true rotation is, eliminating some of the pelvic tilt and some of the pelvic influence in the supine position, and also will help you understand if there's asymmetry between the two sides. Patients can unconsciously compensate a little bit and change your measurements, especially in the supine position, so prone is a little bit more reliable. You can get a rough estimate of the eversion as well as you're palpating the greater trochanter laterally as it is on profile or parallel to the floor. Whatever version you're seeing there, internal rotation you're seeing there is the expected version. When we're looking at tibial version or tibial torsion, you're doing a prone thigh foot angle test, measuring the bisector line of the thigh and the bisector angle of the foot. When we're looking at this radiographically, plain film radiographs don't show us rotation great. You can start to pick up on small differences. So the profile of the lesser trochanters, you can see the modality or the profile of the knee with the kneecap straight forward. And you can look at what the profile of the mortise looks like at the ankle. But a lot of this is gestalt and this is more of a feel. To really get measurements, we're looking at a CT scan version study to look at the true anaversion and the rotation of the tibia. The way this is performed is singular cuts at the pelvis level, at the level of the femoral neck, at the knee, and at the ankle. We're trying to get measurements up the femoral neck. We're trying to get measurements of the posterior condyles of both the femur and the tibia, and then we'll get a bisector line of the medial and lateral malleolus at the level of the incisura. We'll then add those together, again, with the goal, as we stated in our radiographs, of the patella always facing straight forward. So here you can see this patient has internally rotated knees with the patellas facing inward. If you neutralize that for the patella to be facing straight forward, we're going to rotate outwards 30 degrees. So we'll add that to the already existent femoral version, and we're showing this patient with 40 degrees anaversion of the femoral neck on the right and 34 degrees on the left. Similarly down below, because we're rotating the knee externally to get the kneecap straight up and down, we would externally rotate those ankles, and you can see how excessive the external rotation would be there. How do we correct this? It's usually through derotational osteotomies. Those can be fixed with either nails or plates and screws. We're measuring how much we need to correct based on our CT scan. Intraoperatively, we're fine-tuning and dialing that in, and then locking that in place with either the nail or the plates and screws. This is a patient similar to the CT scan we saw earlier, where she had both increased femoral anaversion as well as external tibial torsion. And so we're first making an osteotomy in the subtrochanteric region of the femur. We're passing a nail down. We rotate that femur and then lock that in place to achieve a more neutral or 10 to 15 degree anaversion. And then the tibia, we're making a straight cut, rotating, and then securing that with plate and screws. Angular deformities is the last big one we'll talk about today. These are the obvious varus valgus that you see with patients walking in. Certainly everybody has seen the large football player who has a significant varus deformity, and we've seen some kids running around with valgus deformities. Every time they run, they knock their knees together. During that first decade, again, some of that is normal, but as we start to reach the teenage years, that's not as normal and can really start to create problems. The more valgus you are, the more you overload the lateral compartment. We start to notice lateral meniscus tears, cartilage injuries, and certainly you can have more stress or laxity on the MCL. And conversely, with a varus knee, you're going to have more stress through the medial compartment and stress on the LCL. So in athletes, this is a little shorter because this is pretty obvious and straightforward and well borne out in the literature. We know with valgus mechanics about the knee, we're going to have increased risk of patellar instability, and we know we're going to have increased risk of ACL rupture. Certainly there is the overloading of the respective compartments, and so you may be seeing Dr. Shani for your cartilaginous reconstruction procedures if we don't correct this appropriately. One thing just to pitch out there, be aware of what's called miserable malalignment syndrome. This is something that may present as a very mild valgus deformity, but in effect is actually 3 deformities all in one. This is similar to the patient we saw the CT scan of before with increased femoral version, very mild valgus, and external tibial rotation. The reason this is missed often is the feet actually point straight forward because there's compensation between internal rotation of the femur and external rotation of the tibia. And so we don't see a blatant or obvious deformity. But these patients usually have vague pain, multiple episodes of patellar instability, and just continue to have recurrent injuries until this is identified and corrected. Clinical measurements for varus and valgus are not super reproducible. You can measure in the varus deformity the space between the knees, and in the valgus deformity, space between the medial malleolus. Some papers will tell you that greater than 10 centimeters between the medial malleolus is indicative of a significant or meaningful valgus deformity, but really we should be looking at radiographic measures to determine that. It's important to know what your normal is, and so we do measure all angles at all joints, and so we have a proximal femoral, distal femoral, proximal tibia, and distal tibial angle that is normal, and then standard deviations from there. There's the anatomical and mechanical measurements. I prefer mechanical because that's really the stress that the extremity is seeing, and so tend to use those for my measurements. Certainly there are situations where we should be using anatomic. There's similar norms for the sagittal plane, and then the infamous Q angle comes into play. That is just a representation of the tibiofemoral angle. So how do we measure these? A couple different ways. You can see the tibiofemoral angle, and we're just measuring the mechanical axis or the anatomic axes here in this varus patient. For specific deformities such as Blount's disease here, we can look at metaphyseal diaphyseal angle. And in the patient on the right of the screen with the valgus deformity, we're measuring number 1, mechanical axis, seeing that's not crossing through the knee at all. We're seeing the tibiofemoral angle difference there, and then the acute measurements of the specific lateral distal femoral angles. We can correct these in different ways. Again, if we catch them early enough, we can use guided growth. This is slightly different in that we're tethering one side of the growth plate, and so we're allowing either on this patient, the medial side to grow more aggressively, or on the patient on the left, the lateral side to grow more aggressively to correct that varus or valgus deformity that we've noted. Once we correct that, the implants come out and normal growth resumes. If we don't catch it during early childhood, then we are left with using osteotomy, so performing a large acute correction and fixing that with plates and screws. Again, our patient from earlier where we had mechanical access not even passing through the knee at all, corrected to passing through the center of the knee with plate and screw fixation. So what about a patient with all the deformities? We have a 13-year-old female. She plays multiple sports. She's a high-level athlete. She comes in with significant deformity, significant pain, limiting her abilities. She's had previous injuries. She's had growth plate arrest. She has a limb length discrepancy, having difficulty getting back to the level she was at before. With radiographs here, you can see she's shortened, she's valgus, and she has an anterior tibial slope on the sagittal profile. And so we talked about different options. For here, we've talked multiple ways to do this. In the young age, we may leave it alone. We may use guided growth. We may perform acute osteotomies, and then we may use a frame. So a frame's a great option for multiplanar correction. In this patient, we create an osteotomy at the proximal tibia. We're correcting her anterior tibial slope. We're correcting her valgus deformity at the tibia, and we are slightly correcting her limb length discrepancy by lengthening. You can see progressively that osteotomy first opens up. In the coronal plane, you're seeing it open up laterally to correct the valgus deformity. And ultimately, we get a well-healed osteotomy site with improved overall alignment. So she goes from shortened valgus and anterior tibial slope to less shortened, near resolution of the valgus, and then a normal tibial slope. She still has a slight discrepancy left, but again, we talked about what is the functionality of this, what is the utility of this. Her limb length discrepancy at this age is now 1.7 centimeters. So if I touch anything, hopefully we can use a small shoe lift and we don't need additional surgery for that. The valgus deformity we will correct here in the future. So quickly to recap, some expected deformity is normal. The physiologic malalignment is a real thing, and the first decade of life commonly we are watching. As we get a little bit older, some of these deformities persist, and we'll address them. If we catch them early enough, guided growth is a great option. If we don't, acute correction or frame correction is a great option as well. Questions? Yeah, so we're out for a period of time as that bone regenerate remodels into native normal bone. But once it is healed all the way, they can do all activities just as they would before.
Dr. Roper, can you repeat that question for the people on Zoom?
Yeah, sorry. So the question was for the magnetic lengthening procedures, are those patients able to get back into full high impact activities or high risk activities? Yes, there's a period of time where we're waiting for that bone regenerate to form into normal native bone, but once it is healed completely, they can do all activities.
Okay, we have a couple of questions from Zoom also. So are you open to patients bringing in their own imaging from previous doctors for second opinions?
Yeah, always. So I think if they've had imaging before, if it's adequate, we'll run with that and we don't need to irradiate them again. Commonly, if they don't have a calibrated image or if they don't have good imaging, we'll repeat it. But absolutely, if they have it before, they should bring it in.
Okay, the second one was with the radiographs, are they still taken supine only or is there a different position?
So most commonly, if we can, we do those standing. So we're seeing the true mechanical load. A lot of times supine, we're going to hide some deformities. We're going to have some flexion, some discrepancy. We want them to be standing if they can.
Okay, and then the last one is if they only need a small lift unilaterally for walking and running, should it be full foot or just the heel? And then same question in regards to cycling.
So my preference would be full foot. I think it gives us a little bit more native biomechanics. When we're starting to do heel only, then we're starting to push them into a little bit of equinus, can lead to some contractures or tightness. And for cycling, I would do full foot and try to just get that normal biomechanics back.
Thank you.
Our next presenter is Brian Duncan. He's a physical therapist and director of Shepherd Square Performance Lab and Division I Sports Fellowship Program at the Memorial Hermann Houston Rockets Sports Medicine Institute. He previously served as faculty at Texas Women's University School of Physical Therapy and University of Houston's Master of Athletic Training program. He is a fellow of the American Academy of Orthopedic and Manual Physical Therapists. He's board certified in orthopedic physical therapy and sports physical therapy. He has a bachelor's degree from Texas A&M University, and he did his master's and clinical doctorate in physical therapy from Texas Women's University. He also completed his fellowship training with the Manual Therapy Institute. Today, Brian will be presenting on From Strain to Strength, Optimizing Hamstring Recovery for Peak Performance.
All right, good morning. Can everybody hear me? We good? All right. Anybody need a stand-up break, or did we already get it? All right, we'll keep rolling. All right, so we're going to talk a little bit about hamstring injuries. We're going to race through the front part, diagnosis and epidemiology, so we can spend a little more time on the rehab components of it. So, unfortunately, I don't have disclosures, but I'm always looking for them. So, all right, so we're going to talk about kind of the epidemiology of hamstring injuries. We're going to discuss a little bit, nerd out a little bit with the pathology, and then we're going to talk about rehab and kind of the process of getting people ready. And then are there things from a maintenance perspective that you want to do with your athletes to help reduce the risk of re-injury? All right, so it's a common injury. You know this more than I do. Significant time loss from competition. And there's a big re-injury risk, especially in the first 6 to 8 weeks after the initial injury, right? And there's a lot of things that we think about and we attempt to measure. And there's a couple things that stick out, but these are only really weak predictors. So age is a predictor. And then, of course, like most orthopedic injuries, is a prior hamstring injury is a risk factor. And age, y'all enjoy this. So the age older than anywhere between 23 and 25 puts you at an increased risk for a hamstring injury. I think most of us in this room fit in that category. So, all right, screening, can we do it? Actually, there's not a lot of literature that says that we can. There's a lot of effort to do so, but there's not a lot of literature supporting that we've figured it out yet. Probably like knee injuries, multifactorial, and so we're looking for the silver bullet, and we're probably not going to find one. Risk factors for recurrence, like I said, age, prior injury, prior ACL or calf injury, shorter fascicle length. So if you look at a muscle on ultrasound or MRI, shorter fascicle lengths are associated with hamstring injury risk and re-injury risk, obviously positional demands. And those people, you also often see them in the 100-meter dash or the 200 meters have an anterior pelvic tilt. When the leg gets out in front of you, that is going to put the hamstring at an increased strain. And so that's going to probably increase your injury risk. So be sure to check for hip flexor tightness and rectus tightness. And there's limited evidence on hamstring strength mattering. There's some degree we need, but more isn't necessarily better. Hydration and nutrition don't seem to matter. Fatigue and loading seem to all be in the limited evidence category. All right, so I said 23 to 25 is when your injury risk starts to increase, but just from the number of people playing sports, the most common time to have this injury is in your teenage and young adult years. Like we said, it's going to be associated with things that involve sprinting. has to do with the rapid increase in loading and sprinting, and you're trying to make the team. There's a lot of money on the line. The other thing is that usually there's been a period of rest prior to training camp, and the architecture of the hamstrings change with a week to 2 weeks off with regards to fascicle length. So strength doesn't change in those 2 weeks off, but fascicle length does, and there's probably some maintenance things we can do to address that. All right, and then I guess I'd say that the average time loss is 21 days. It can be as short as 14.
That's saturated the mechanisms next, so they're going to stretching out the wall. That's a bit of all so that's so one thing I stretch related on the other. I believe that what here from there, it's
Pose change, stretching movement on P, and then we've got a lunging maneuver here, C. So those are going to be the typical ways you're going to see a hamstring injury. And then sprinting, you're going to see it at late swing phase. If you look at the letter A, you can see his trunk is more pitched forward and his leg is out in front of him rather than underneath him. We're not going to need to change biomechanics on every runner, but that's just a good example. When you have an N of 1 and you're rehabbing it, your strength and conditioning coach or a track coach, there is probably a place to get that foot underneath the body instead of out in front with regards to reducing re-injury risk. All right, so mostly, well, I guess maybe I should ask by a show of hands, is the semitendinosus more injured? Any show of hands? How about biceps femoris? All right, still early. All right, let's try it again. Semitendinosus, anybody think it's the semi-T? How about the biceps femoris? All right, there we go. Yeah, so usually it's a biceps femoris. So it's the long head. So right, there's a short and a long head. And it's where the myofiber is attached to the muscle. Shorter fascicle length, remember, is an injury risk. It's typically in sprinting, kicking, or lunging. The most common is here in the middle, or the bold arrow. It's an interesting graphic because those arrows on the left side, I got this out of a journal article, they're all pointing to the semimembranosus, but the level of which the injury happens is accurate, but it should be over here on this side. Anyway, this is going to be the most common injury, 50%. The higher it is to the ischial tube, and then the longer distance, the longer the recovery is going to be. All right, history. So we know the history, right? It's typically acute onset, may or may not have a pop or a sensation of a pop. They usually grab their hamstring. Everybody saw Steph Curry, pretty innocuous movement. He grabs his hamstring, and the Warriors are quickly out of the playoffs. So there's a good differential diagnosis here. Proximal hamstrings avulsions, that's one with a suspicion of that. That's where X-ray is going to come into play. Palpation, like I said, increased rehab time if it's closer to the ischial tube or there's a greater total length of palpable pain. This is a look at an ultrasound imaging guide. So ultrasound is obviously user dependent and it's growing in its utility. And that's a look at where you would visualize which structures with the ultrasound. I put it up here because it also helps us think through where we're palpating and what we're looking for. Range of motion, so the active knee extension test, AKE, you're going to see that a lot in the literature. And so you can either do it from a 90-degree position, or I like the one where you have them just hug their knee to their chest. The hamstring produces a lot more torque with the hip inflection. So by biasing the hip to the thorax or to the chest, you're going to put that into more tension. And basically, you're just looking at how much they can straighten the knee using their quad. And you're going to grade it based on the level of deficit. So evidently, there's 2 grade 3s. Sorry about that. But less than a 15-degree loss, you know you're probably at a grade 1. Somewhere between 16 and 25 a grade 2, and grade 3 is going to be 26 to 35. Other things to check, love the slump test, or you can do a modified version and supine of the slump test, basically doing this. You can add chin flexion or neck flexion. So reassessing that nerve and its ability to glide. So you can do it supine or seated. Again, if they've had a prior knee injury, and then we're checking hip flexors. MR is not necessarily recommended for grade 1 and 2 injuries. Obviously, if you're at the college or pro level, probably everybody's going to get an MRI. But if parents are asking you for guidance, that's just what the literature says. All right, so looking at strength. So if you happen to have a handheld dynamometer or a 10 deck, there's ways to measure it. In particular, B up here is a good way to measure it. D. And so you're just looking at side-to-side strength differences, and this will help you monitor it for recovery purposes. You can do this as quick as 1 or 2 days after the injury and then monitor it serially. All right, so bottom line, right, as we move into the next phase of the presentation, right, we've got a prevalent injury. We get a loss of knee flexor strength. That's pretty persistent. So the other thing we're not going to be able to get into today, but on MRIs of NFL athletes, you're going to see scar tissue and changes in the muscle at 6 months and a year. So they're going to have return to sport, and their biceps femoris long head is going to show continued atrophy. For those of you with a NORD board or a handheld dynamometry, and you're measuring strength, you're measuring the combined strength of all the muscles, so there's no good way to isolate it. So your biceps short head is going to probably hypertrophy and cover up some of the deficits from the long head injury. Something to keep in mind. All right, so rehab principles. All right, we're going to start exercise early. We're going to emphasize eccentric strength. We're going to allow pain. Actually, we want pain. If there's not some pain in the rehab process, controlled, then you're probably going too slow, and you're not actually improving their chance at fascicle lengthening or restoring strength. You're going to return to running pretty quickly. So we're going to talk about some walk, jog, walk progressions that have become a jog, run, jog progression that become a run, sprint, run progression. And then, as you already have, we've got return to play criteria, right? So there's a lot of articles that say we need to start early. So the sooner the better. You can start with active range of motion. Basically, early lengthening is important in the rehab process. We're going to do it a few different ways. We're going to have an eccentric flexor. So we're going to have something about the knee, right? Because the hamstring, right, does hip extension and knee flexion. And so we've got to work both sides of that. So we're going to work knee flexor strength with a bilateral slider. We'll have some pictures later. Basically a bridge and an eccentric, letting your heels walk away from you or slide away from you. We'll go to unilateral and then unilateral with load. We'll do a hip extensor. So whether it's a GHD or a 45 kind of Roman chair, we're going to use that. And then we're going to do a hip thruster. So shoulders on the back of a bench. You can do it two-legged, one-legged with a barbell. The importance of allowing pain. So allowing pain doesn't improve your return to sport times. So painful or not painful. Same amount of re-injuries. So then we start to question, well, why are we going to work into pain? Am I going to lose my athlete? Are they not going to buy in? But what happens is you get greater strength changes earlier and you get better fascicle length. And like I said, fascicle length is going to be a big, important architectural change that reduces re-injury. All right, the other thing is if we wait to do things that are pain-free, on average, we're going to wait a week longer to initiate strengthening exercises. So again, we don't need to do that. It's a great article. I'd highly recommend reading it. And then I'll talk about a video if you're like, man, I'm not going to read it, but I'll watch a YouTube video about it. All right, another thing to think about is a lot of times we think about in a rehab progression of starting isometrics and then maybe concentrics and then eccentrics, right? So we think, oh, isometric is the safe way to start. Well, in this research study, what they did was they looked at a group that started with painful exercises, 4 out of 10 or less, and then they did a group that was only doing pain-free exercises. What they noticed was eccentric exercises in the green are pain-free, and then in the red is the amount of patients or athletes that were painful. What you can see is eccentrics were actually less painful than isometrics. So a lot of times we think isometric is the way to go, but the isometrics were actually more painful than the eccentrics. All right, and then the other interesting thing that I'd point out is that eccentric force is going to return before isometric. This is going to be hard unless you have a NORD board to pick out, so you're just going to have to trust the literature, but you're measuring isometrics with a handheld dynamometer. And so that is an isometric test. And so that is going to be a lagging indicator. Their eccentric strength, if you're using this program, is actually going to be restored before their isometric strength. All right, so we said we've got to work into pain and we're going to use eccentrics early. Now, what do we do on the running side of things? So running is going to be probably the most important factor, right? It's great if you're strong, but if you can't run, you're probably not going to make it on the field. All right, so we're going to start running early and we're going to do it often and we'll talk through those details. So lastly, the objective criteria, so that shouldn't have pain when palpating it. They shouldn't have pain during strength exercises. Should have similar eccentric knee flexor strength. Most of us are actually going to be measuring it isometrically. And then the flexibility, so that active knee extension test where we hug the knee to the chest, those should be symmetrical. And then we should be able to sprint at 100% without pain or fear of re-injury. All right, so rehab details. So what does our hamstring slider progression look like? So we've got basically a bridge and then eccentrically sliding out. That becomes a single leg version and then single leg both out eccentrically and then back in. What I'd say is in between here, instead of just doing a double leg eccentric, you can do a double leg eccentric and follow that up concentrically. Again, we want it to be less than 4 out of 10 pain, and here's some rep ranges. These are really hard. You don't need tons and tons of reps. So if you do a single leg bridge, let your heel slide out, let your butt hover above the ground, and then dig that heel and pull it back in, be quite challenging. So again, this is going to be great. It's a knee flexor side of things. We're going to get to the hip extensor side, right? And so we've got double leg, single leg, and weighted. You can also do this on a GHD machine. And what I would say is on a Roman chair, 45 pounds is probably about as good as you're going to get. With a GHD where you're flat, you can probably give some of your better athletes 2 or 3 plates, right? And so I just want you to think about the amount of strength they're going to need with that leg as that knee nears fully extended position. And we're not going to reproduce that with just a 45-pound weight, okay? All right, hip thrusters. So we've got a double leg hip thruster, single leg hip thruster. I really like jumping hip thrusters. You can add weight. It just becomes awkward, but if you can jump, that's generally pretty beneficial. The other thing you can do is you can jump. While you're in the air, you can push that foot out so that you're landing with the leg straighter. Hip inflection, knee and extension, that's how hamstring injuries happen. And then that from that position, then the hips lowering back to the ground. That makes sense at all? So you jump up, kick this foot out a little bit, and then lower your hips down on the landing. That'll give you quite the eccentric load. All right, I didn't get all my videos inserted. I videoed some in the clinic. My apologies. All right, running progression. So stage 0, before you start running, you got to be able to walk less than 4 out of 10 pain. But then we're going to do 20 meters of walking, then 60 meters of jogging, and then 20 meters of walking. So this is a 100-yard field or a 100-meter pitch. In stage 2, we're going to build. Stage 3 is run, sprint, run. Most of these hamstring injuries are going to happen in the transition from jogging to sprinting. Okay, it's not going to be from a standstill to a sprint. All right, the other thing to know is that hamstring loading is going to increase rapidly between 80% of max speed and 100%. So when you get between 80 and 100%, you've got to be much more dialed in and theoretically increase it in 5% increments. So if you take a 250-pound athlete and they're going at 80%, and then you take them to 100%, you get a 25, or technically it's a 20% increase in speed, a 30% increase in hamstring force, and a 50% increase in load. So if you're rushing the very end phase of this return to sprint, you're going to be in trouble. Other things to consider: running uphill on a treadmill shortens your stride length. So you can actually start sprinting earlier, whether it's a self-propelled treadmill or a propelled treadmill. The other thing you can do is you can push a sled, or you can row. You can actually, if you have a rowing machine, you can stack the rowing machine on some 45-pound plates. It'll be much more of a quad workout. As their hamstring gets better, you lower it back down to being flat on the floor, and you're going to transfer more of that into the more of a deadlift kind of hamstring loading progression. Wear people out on a bike. So think about intervals and things like that. All right, sample program. So you've got an injury day 0. What are you going to do day 1? So if they can make it around on a bike, great. Do your supine, knee to chest, nerve glides. You're going to look at some double leg eccentric sliders, maybe some Roman chair activities, or if you're in an athletic training room and don't have that, have them lay down and hug your table. Their legs are down hanging off the table, and they're basically doing a reverse hyper. So you can get hip extension that way. And then we can do a double limb hip thruster. And they can unweight it as much as they want, but you're getting them moving. All right, and then day 2, we maybe get in an upper body workout. Day 3, where again, we're looking at nerve glides, double leg eccentrics, Roman chair, maybe we're to a single leg hip thruster. The interesting thing, if you hurt your hamstring sprinting, it's when, right in that late swing phase, when the knee is extending and the hip is in flexion. So if you put the knee in flexion, leg hip thruster, so that's going to be pretty much asymptomatic pretty quickly because the knee is in flexion. The hamstring is going to be symptomatic if you've heard it during sprinting when the knee is closer to extension. So that's going to probably progress at a different rate. And the thing I want to illustrate with this is each of these 3 exercises, the hip extension and the knee flexion, they may progress at different rates. Your job is to continue to push them where they have a slight bit of pain during the exercise. And if it's pain-free, it's time to make it harder. All right, if we look as we progress, when we get into week 2, we're starting to increase our dosage. We're getting into lower body lifts. We're getting into cardio. We're alternating. We're starting to have warm-ups that look like go jog a mile. So whether they're going to jog on the field or they're jogging in the clinic. And then we're going to progress. We're going to introduce Nordic hamstring. One big thing that's evident in the Nordic hamstring literature is that a lot of people can't lower themselves very far before they end up falling. The problem with that is they work really hard with their hamstrings in a shortened position and they never get their nose close to the ground. So they're working at, they basically are giving up and falling forward in the area when they need to be eccentrically loading their hamstrings. So what you really need to consider is putting one of those jump bands around their chest so that they can get a better range of motion before they collapse. Because if they only get about 5 or 10 degrees and they fall into a push-up position, you're basically doing plyo push-ups. You're not actually working the hamstring eccentrically in the range of motion you need it. All right, so hypothetically, right, you're returning to participation or doing some things with the team. Anything that doesn't hurt, you can do skills, you can dribble, you can shoot, you can, catch passes, run routes, jog routes, walk through things, keep them involved. Maybe you're returning to sport at day 15, but let's be honest, returning to sport and returning to performance are different. And a lot of times that takes longer. Additionally, with imaging, a lot of times there's no additional value with predicting your time to return to sport. And it doesn't predict your risk of re-injury. What I will say about this image, though, is you've got continued scar tissue or continued evidence of injury well past the time of return to sport. All right, screening. Unfortunately, the Nordic hamstring or the Nord board, while it's being used and should be continued to be used while we're figuring things out, it doesn't seem to reduce injury risk or identify those athletes that are at injury risk. Maintenance, this is really important. So I use this match, call it football here in Texas. That could be a Friday or Saturday. Your Sunday's recovery. Hamstrings, heavy loads, so Nordic hamstrings, RDLs, hip thrusters. Tuesday, you probably need sprinting. There's really good evidence that sprinting at greater than 90% effort for 2 to 3 sprints, 20 to 40 meters, and a total of 250 to 300 meters of high-speed running is really important to reduce your injury risk the subsequent week. Okay, so if I can emphasize anything, at least one dose of high intensity sprinting, usually somewhere between 2 to 4 days before the next match. And if you're bored and want to Google this or Chat GPT, it will actually build you, if you ask a good question, a program that's pretty right on. So I literally typed that into Chat GPT, and it gave me pretty much the same thing that the literature gave me. So it's not always great. I've had it fail me several times, but anyway, so good stuff there. All right. One thing, so we talked about the Nordic hamstring. It's a really good exercise. You can do it early. We probably need to band a lot of our athletes, especially the younger ages in high school or your linemen or whatnot, if they're doing those. What will happen after an injury? We look down here. So the right is the injured side, and they are trying to work really hard at using that hamstring early in the range of motion, hence this bubble right here. So they're using the right more than the left. They're making a really good effort. What happens is they get closer and closer to the ground. That right hammy can't give you anything. It shuts down, and the left hamstring is doing the rest. Okay, so what we can't figure out with handheld dynamometry or a 10-deck unit is these force time traces. And what it's showing us is that what we need to be working is not working. So we definitely need to be doing some unilateral exercises. If you have a clinic or have access to a clinic that has a biodex, you can actually set it up where it pushes the knee or the hip into flexion, and then you can actually work knee extension from this hip flex position. So you can really wear out your hammy, and you can do it at slow speeds and at fast speeds. So anyway, the Biodex, you can have a lot of fun. There's a lot of things that aren't supported. Use them as you see fit. You're trying to get buy-in, you got to do something with your athlete, but know that for architectural changes, you've got to have eccentric loads and you've got to have sprinting. And the strength doesn't change with a couple weeks off before fall camp starts, but the architecture does. So you need at least one dose a week to help maintain those architectural changes going into the fall. All right. So really good resources, running injuries or anything by Brian Heiderscheit. So students in here, get on YouTube, look him up. He has several excellent talks. Jack Hickey breaks down the pain-free versus painful threshold. This is about a 15-minute YouTube video that's real good, and he talks about things in his research that didn't make it into the paper. And then this My Hamstring Injury Rehab is an awesome 10-minute video on a PT that rehabbed his own hamstring. I pulled several different resources from his stuff. So anyway, a lot of good stuff online. And then speaking of playing around with ChatGPT, if you take a picture of this Notebook LM by Google, I uploaded all the research I used to make this talk, and then hit a button and it turned it into like a 27-minute podcast. So anyway, if you're bored on your drive home, there's a podcast. And if you're a PT looking for a fellowship program, there's a QR code. All right. Any questions? All right. I appreciate it.
Brian, we do have one for the Zoom chat. Hey, Brian, we do have one in the Zoom chat.
Okay.
Is there a specific pain threshold that you should be aware of, especially early in the rehab process?
Yes. 4 out of 10 seems to be the magic number. So less than 4 out of 10, hopefully not painful later in the day or the next morning. Thank you.
Thank you.
Gentle reminder, please silence all cell phones and electronic devices as we are having all the different speakers come up here to speak on their presentations. And also, if you're looking for restrooms, they're right across the hall. Our next speaker is Dr. Dominic Maneen. He is a primary care sports medicine physician and medical director and owner of Houston Health and Sports Medicine. He has a bachelor's from University of Texas at Austin, MBA from Rockhurst University in Missouri, and his degree in osteopathic medicine from Kansas City University of Medicine and Biosciences. He completed his family medicine residency at Memorial Hermann Health System and primary care sports medicine fellowship at Cone Health Sports Medicine in North Carolina. He is a certified athletic trainer by the Board of Certification for Athletic Trainers. He was previously an athletic trainer for Houston Baptist University, currently known as Houston Christian University, as well as an intern athletic trainer with the Detroit Lions and the University of Texas at Austin Athletics. Today, Dr. Maneen will be presenting on osteopathic manipulation therapy in sports medicine.
Thank you.
All right. Good morning. Thank you guys for having me. Thank you for the introduction. I joke with my wife, reminds me of the alphabet soup behind my name, but you guys can relate. Starting with athletic training, I was the glorified water boy, then becoming a DO, you're a fake doctor, and then doing, primary sports medicine that isn't surgery raises questions. So I spent most of my adult life getting to explain what all of those three things are. Really enjoy the athletic trainers. I maintained my ATC for that reason. I did that at Texas. I'll go to my grave that if Colt McCoy doesn't get injured, we beat Alabama in 2010, but that's a different story. So I was one of the rare breeds that I went to DO school just because I wanted to maintain a lot of the manual skills. You guys are doing a lot of OMT and athletic training. There's just some nuances to it that I wanted to talk about. But I still do OMT weekly. The beauty of OMT or osteopathic manual therapy is you can do it in all kinds of settings, not just athletics, which is really nice. So my wife and I own our practice affiliated with Hermann up in the Woodlands. And she's even an MD with sports medicine, and jokes that had she known she'd go into that, she would have done athletic training or osteopathic medicine. So there's obviously a lot you can talk about with osteopathy and manual therapy in sports medicine. I want to kind of give a background on DOs and kind of what maybe makes us a little bit different or just a different approach, especially in the sports world. So these are kind of the four tenets if you've ever looked into it or studied it, but I think it carries over well into sports and the athletic training world as well. That the body is a unit, the body has this self-healing property to maintain, a homeostatic environment. So something you guys see, especially if you're at maybe a high school level where the body, mind, and spirit really does come into their health and that structure and function are interrelated. So yes, there's mechanical injuries you can have that may not, structurally be seen on imaging or your exam, but you can mentally kind of know your patient or your athlete and decide what to do. And the treatment, we have plenty of studies, you guys have probably read them by this point, that just getting your hands on patients or athletes is going to help them not only build a rapport, but you'll lead to better outcomes. So these are kind of some of the things we ask more in the sports side of world of OMT. There's OMT I do on pregnancy patients. I did OMT on both my children when they were less than a few hours old to help with their sucking for breastfeeding. So goes a long way. Geriatric, there's pneumonia protocols. So has tenants all over medicine, which I think is really cool. But I probably do most of it in the sports world. About your somatovisceral functions, your viscerosomatic functions, connecting their symptoms to that structure in their body can be really helpful in just learning what are ways to identify the pathology or in our world, the somatic dysfunction to help with that. And can OMT improve their condition? At the end of the day, you getting your hands on your patient is going to improve something because it's either going to tell you more and they're going to bitch and complain, or you're going to help fix them and that's going to get you where you need to go. So what kind of treatments? These are kind of how we break down in the DO world, how to look at OMT and what approach to take. You guys are more than well-versed in the biomechanical approach. The respiratory circulatory system, so thinking about how is that sacrum moving with their breaths, thinking about how their cranium is moving with their breaths. Sorry, just getting over a little cold. Neurological, that can mean yes, periphery or central, and I'll kind of talk a little bit about that. And then looking at kind of that metabolic pathway, their energy pathway, is there fatigue due to a structural dysfunction, and what does that look like? And then definitely more for the adolescent, kind of the behavioral world. You hear everyone say, I carry my, stress in my shoulders and my neck. A lot of times that's when patients are coming in with headaches. At the end of the day, it's behavioral anxiety and stress. So the two most common reasons people go to a physician, or at least a primary care physician in this country, number one is depression, and number two is low back pain. So I feel like OMT is a good way to kind of get my hands on patients to let them know about their pathology, so I can be adjusting or manipulating or doing treatment on their back while talking to them about, okay, hey, why does this make you, uncomfortable? Where is that anxiety and depression? And like most of your athletes, they're not walking in and saying, I am depressed. They're walking in saying, I can't sleep. I can't make a free throw. My, my mile time is getting longer, then you get deep down into it and find that it's a little bit more behavioral. So this is kind of the Merriam-Webster in the osteopathy world for what we call a somatic dysfunction. So an impaired or altered function of related components. It's very rare that you're going to have just one thing wrong with that. So you can look at the skeletal system, you can look at their joints. Myofascial is huge, as you guys are well aware, and then things like vascular, lymphatics, neural. It's nice because that's the only kind of finding you need to perform OMT. And then when you break it down even further than that, we're looking at, okay, what kind is a somatic dysfunction the primary disorder, and that's what's causing this, or is it because of something else, which tends to be much more common. Hey, they have degenerative disc disease that's causing myofascial pain. Hey, they have a concussion and that whiplash caused a lot of neck pain and headache. So really kind of getting down into it, I think that's the fun part of my job where, yes, I have kind of the musculoskeletal sports med brain, and then I kind of have the DO brain and can tie the two together and treat one versus the other. I jokingly will tell patients like, take physical therapy, take chiropractor, and kind of merge them together. And that's kind of a good way to look at osteopathy and what we can do. I think it's huge working with your team because no one's going to be able to, okay, hey, you might manipulate someone's neck. Great, they're going to feel good for those 24, 48 hours. But what are we going to do with the therapy and the rehab so you don't continuously need these type of treatments? So that's where I kind of look and take my approach. So when you see that term somatic dysfunction, just think that's, your structural finding, your mechanical finding, your biological finding, whatever it may be. So if you see that, especially kind of on my notes or notes from a DO, you can know that OMT is probably in their future. So kind of basic 101 for you guys, but just, acute versus chronic. Low back pain, for example, most people are living with for most of their life, and then it's just catching up to them as they become more sedentary. But you can do OMT in acute settings. Obviously things like fractures, you're probably not doing a whole lot, but sometimes lymphatics will help with that. So just trying to delineate, okay, is this an acute, subacute, or chronic condition? Because that changes for me too. Okay, what are the treatment options? An 80-year-old with osteoporosis who just likes to go for walks with her grandchildren versus the guy training for a triathlon. Very different approach that I'm going to have in what my techniques can do. And then your palpation is huge. So is it inflamed? Is it red? Is it erythematous? Is it boggy? Is there swelling? That's going to influence, okay, what am I capable of doing? Do I need different modalities and whatnot? Then is it truly muscle? Is it truly fascia? Is it lymphatic? Is it truly just joint related? So my physical exam takes, the majority of my time to really, assess that. And OMT in general, we like to work central and work our way out. So you'll see most, DOs that are practicing OMT are usually going to start at that thoracic spine and kind of work our way out to really find the dysfunction. So, your thrower with frozen shoulder, most likely it's probably scapular dyskinesis that is related to poor thoracic mobility. So you get to kind of work through that progress to, okay, let's start at the T-spine and work our way out. So it's a fun approach to kind of teach them about their kinetic chain and how that functions. And then, yeah, we do visceral somatic or visceral OMT as well. So like IBS, you'll hear the diagnosis of exclusion. There's a lot with, the somatics that go from the spine to that. So helping with constipation, diarrhea, there's things you can do with that as well. And even in the hospital, when I was more working inpatient and training, hey, there's things you can do to the ribs to help with pneumonia and everything in between. So things that I think you guys are well aware of are kind of the two basic principles of manual therapy in OMT is a direct and indirect treatment. So directly, I'm going into a barrier that they're going to have. They can handle that. That's usually my younger, healthier, more maybe in shape athletes. And then more commonly an indirect barrier. So I'm taking them away from that area of dysfunction to kind of reset that Golgi apparatus, get them moving back to normal. This is going to be in more of my chronic patients that don't have the range of motion, your computer workers that are sitting for long periods of time. So in the sports world, these both come in great handy because an acute strain maybe, I'm going to go indirect first and then, get to direct after that. So you can really look to see, okay, if I can relax that tissue, you increase blood flow, you're going to need to healing. It's, my poor man's way that I talk about muscle healing. It's like, okay, the right massage and the right myofascial release, that's not failing. We can get into more in-depth techniques. Then you get into, shockwave, orthobiologics, everything to increase that blood flow. Because at the end of the day, that's how we're going to heal these injuries. So just remember your basic tenets that blood and lymphatic usually tend to flow together. There's kind of a system and where the lymphatic will drain for your body. So there's an approach you take based on what diagnosis you're looking at. So this is kind of a general chart that we made. I teach part-time at the DO school with Sam Houston. So the students are learning this, from day one. So you can really do a direct and indirect technique with almost any form of OMT. These are kind of the main ones that we use in our world. You guys know a lot of these and are doing a lot of these. When I first learned, muscle energy in med school, it's like, okay, we were doing this as a freshman in an AT program. So you're doing a lot of it. Sometimes it's just different names and whatnot. Then there's a little bit more nuance with like balance ligament tension, and some of this we'll do in the breakout section. But something like counter strain, for example, is a complete indirect technique where I am truly just standing there, kind of finding their position of max relaxation, and we're just sitting there and letting the body kind of heal itself. And then more like in the sports world, the HVLA, the thrust, the difference. People ask, what's your thrust compared to a chiropractor's? Chiropractor, it's usually more high velocity, high amplitude. And I get to joke since my dad's a chiropractor, we get to butt heads all the time, where I'm doing more of a low amplitude. But think your quarterbacks, hey, Friday, I'm stiff, I got a game tonight or tomorrow. Okay, boom, boom, you have some mobility for tomorrow, but then get in there with the athletic trainer to focus on the rehab during the week. I think injury prevention is huge with OMT as well, especially teaching younger people the importance of flexibility and lymphatics is huge. So we'll kind of go into some of those during the breakout sessions. So remember, a somatic dysfunction doesn't mean structural damage. Yes, someone can have a torn meniscus and there could be a tibiofemoral somatic dysfunction. So you can treat structural issues with OMT, but they're not synonymous. So a lot of times, similar with a concussion, I'll say, hey, look, nothing's going to show up objectively, but just try to turn to your left and then turn to your right. You see that difference. Hey, there's a dysfunction there. So it's usually based on position and function more in our world. And then you hear about people say, oh, my one leg's longer than the other. Sure, you have Dr. Roper's kids where it's, anatomical, but more than not, it's truly just functional where you're, tight somewhere, stretching what's tight and strengthening what's loose, where then you have your structural damage. Sure, if someone has a broken neck or a torn ACL in that moment, there's not a lot of OMT I'm going to do that's going to get them better. So indications in the sports medicine world of why I might do OMT, obviously pain. I like to teach at least more probably my high school athletes in the off season, preventatively, things we can do to increase flexibility more than anything. And then you guys are familiar with the common compensatory pattern. We know just based on osteopathic education and data, what is a kind of normal pattern from their skull down to their heel on where people tend to be rotated or out of line structurally, so we can kind of help maintain that. And then what you guys are doing every day is just socialization, getting your hands on patients, talking to them, asking them, trying to see, is this really a functional problem or is it more mental or biomechanical or anything like that? I think a very underutilized tool is just watching your athletes walk and seeing, you can see kind of where their deformity is. And in our case, it usually is a somatic dysfunction, or unfortunately they have, flat feet or something similar. So similar to every patient, you really got to individualize it. Yes, maybe a quarterback and a starting pitcher, similar kind of mechanics, but my hockey goalie versus my runner, it's going to be very different in what our goals are. So that plays in my head on, okay, how often do I need to do treatment? What kind of treatment do we need to do? And then obviously any kind of movement is complicated. It's very multifactorial. So like I said, I usually tend to start central and then move my way out. So that's kind of the approach I take with patients. And then does it work? We unfortunately don't have a ton of studies for osteopathy medicine in sports, but they did show, when you can contract what's tight, when you can stretch what's tight and strengthen what's weak, you're going to get a lot better mobility and strength. So they did one with just thoracic spinal manipulation that showed, hey, if we can teach patients how to, activate their erector spinae, we lead to better outcomes, less injury, and better performance. Then some of you may be familiar, obviously, with the CARE Act, but the strength coaches and you guys are the only ones that can kind of have full access to the athletes or the patients full time. So it's good to really see, okay, yes, may mean longer nights for you, but the more you can do maybe in the off season to kind of prevent injury, the easier your time is during the season. So, whether it's during competition, practice, instruction, weightlifting, conditioning, there's ways you can kind of implement OMT and preventative medicine to help prevent injury during the season. Like most athletic trainers, you guys are not recognized for the amount of work that you do. And same with OMT. I don't think enough athletes know that this kind of exists. So you can see that almost 500 athletes a few years ago during COVID, they asked if any of you guys heard of this or any of you doing it. It was, such a small sample size. And then, almost all of them that got some form of OMT actually said, it helped with their pain and whatnot. And then you talk about the mental side of it. It reduces stress and anxiety. We've all probably had a therapeutic massage at some point. Same concept of what endorphins are released and when that GTO can be activated, what that does for us. So specifically today, more so in the breakout sessions, these are the things I tend to treat probably most common with OMT. Concussion's a big one. There's, obviously tons of research going into it. I love kind of messing with the neck during a concussion because most of the time it's some kind of whiplash injury that is really causing their headache and their neck pain. So I'll do a lot with that. The pelvis, everyone, oh, my doctor or someone told me one leg's longer than the other, and you just realize they don't know how to either fire their glutes or their psoas is on fire and super tight. So you can really, work to get that psoas. I just had a OB physician come in for years, just had pelvic pain. And as soon as I saw her just lay on the table, her knee was probably flexed to 15 degrees. So before I even touched her, I said, look, we got to get your hamstring flexibility. And then she was anterior rotated in one of her anominants. So I put that, pelvis back into place. And she texted me an hour later and said, I, feel like a new person. And rather than say, oh, cool, I did something, it's like, hey, this is now, you got to fix your hamstrings if you want to continue to feel like a new person. And then shoulder, since it's arguably the most dynamic joint in our body, 18 different muscles touch that scapula. So really get to work on scapula and shoulder OMT to help with mobility. And then like I've harped on, thoracics is kind of the key. We tend to, everyone's either carrying backpacks, sitting at a desk, sitting in a car, driving. So thoracic mobility, I think, is huge and something I work on with my patients. So when we talk about cervical OMT and a concussion, obviously got to know your anatomy, got to make sure the diagnosis is correct and there's nothing more going on than just a concussion or a muscle injury. So these are kind of three techniques that I tend to focus on. So just a little bit. So when you guys are, examining each other later, just remembering these small little muscles in your suboccipital triangle that can really have a lot of tenseness to them after a concussion. And then you got to remember that there are nerves in there too. So very rarely, but I will do it if my OMT is failing and they're having kind of more post-concussion symptoms. I'll even either do injections for these muscles, trigger point type injections, or then a handful of times even try to find that nerve with the ultrasound and try to calm it down that way. So just try to remember there's more than just, your scalenes back there in these small muscles. So get comfortable palpating in that area and feeling where their restriction is. So yeah. So I don't know if my audio came up on there. Sorry about that. but the nerves are there. So you got to remember that's where it kind of gets back to those first slides that there's the, nervous system component of it and the musculoskeletal. So just try to differentiate between that. The pelvis is fun. The pelvis and sacrum kind of in the DO world, people shy away from because it can be kind of overbearing. There's so much movement going on from there. So remember your anominants, remember that the pelvis is split up into two. So you're going to see a lot of difference between one side or the other, especially your lower extremity athletes. So if your soccer players tend to, have a dominant leg that they kick with, you can expect that that side is probably going to be different than their other side. So most of the time with anominants, we're talking if it's anterior or posterior. Also, you can have in flares and out flares or also shears. So we'll kind of go over how to diagnose that and focus on some treatments for that. So when we're going through, your anominate diagnosis, I harp to the medical students as well. You just got to remember your anatomy. If you know your anatomy, where muscles originate and insert, you can really, do most of the job for you. So getting comfortable palpating both your ASIS, your PSIS, and understanding that difference. Always got to remember to kind of look at their malleolar heights to really see how much of this is a functional versus anatomical difference. And then, like I mentioned, really looking at them walking or standing to kind of see where that where their pes cavus or pes planus may be. And then just being, in this day and age, unfortunately, like with Michigan State and Dr. Nasser, just really take your time explaining to patients what you're doing because you do have to palpate in some very, very sensitive areas. So taking that time to explain why you're doing it and how you're helping them. Remember, the sacrum can change with respiration. So when you're measuring a patient that's, breathing in versus breathing out, you're going to feel that sacrum move in different ways, and that's going to help with your diagnosis. The shoulder, I kind of mentioned, you guys are probably better. You and PTs are really the only ones that maybe look at the scapula when it comes to diagnosis, but that tends to be where most of the problem comes from. So focused rehab on that scapular dyskinesis. And we'll go over during lab, the Spencer technique is a very basic DO technique that just really focuses on that glenohumeral stability and really mobility, excuse me. So we'll go through kind of doing that together just to kind of help loosen things up and get your patients active and moving. So inactivity wise, obviously we're not moving enough. We, in the past few years have gotten to diagnose obesity at a younger level now and had to make new guidelines for it because it's so prevalent. So yeah, the American Heart Association will tell you, 2.5 hours a week of moderate activity. But from a cost perspective, inactivity is, I think, is costing us a lot of money in medicine. So taking the time to teach patients what to do when they're away from you, because they only get a couple hours with you if you're lucky. So getting them to buy in on, wow, you made me feel so good during this treatment. I need to do these things on my own so I don't have that pain. But yeah, we're up to now 1 in 4 adults, are not doing any kind of physical activity. So really just being able to take the time to focus with your patients or your athletes on what that can do for you. I think OMT and manual medicine is a great place to start because it's something you can do together. You can teach them, you can converse and kind of get to know them and them to buy in to to what you're selling, basically. All right. So again, we'll do most of this during the breakout session where it's a little easier to explain when we're getting our hands on patients. But if anyone has any specific questions, concerns.
Two questions from Zoom. So the first one is, have you treated a fibromyalgia patient? And if so, what techniques do you use and how often would you treat them?
All of them. Yeah, fibromyalgia is similar diagnosis of exclusion in my opinion. So that's going to be a lot of psychosomatic. But yeah, I treat them much more regularly than some of my other patients.
Okay, and then the other question is, what are some tips that you could give us that are often overlooked in some common injuries?
Yeah, I harped on most of them, but I think thoracic and scapular mobility is very much overlooked. And then if you're, I see probably less athletes in my clinic and more your average worker, but low back ergonomics for sleeping are huge. Ergonomics for your desk chair, your car chair go a long way as well. Awesome. Thank you, guys.
Our next presenter is Dr. Rehal Bhojani. He is a sports medicine physician and assistant professor with the Department of Orthopedic Surgery, clinical assistant professor with the Department of Family and Community Medicine, and program director of Sports Medicine Fellowship Program at the McGovern Medical School at the University of Texas Health Science Center at Houston. He is a sports medicine outreach program medical director with Memorial Hermann Brockett's Sports Medicine Institute. He has his bachelor's from University of Texas at Dallas and his medical degree with distinction in research from University of Texas Southwestern Medical School. He completed his family medicine residency at Memorial Hermann Health System and his primary care sports medicine fellowship at Henry Ford Hospital System in Michigan. He is a chief medical officer for the Houston Dynamo and Houston Dash, as well as a team physician for the Houston Texans and the Houston Rockets. Today, Dr. Bhojani will be presenting on facial injuries.
Good morning. Can anyone hear me? All right, well, let's go through this. Today, talking about facial injuries and talking through the different things you can see from all the way up to here to here. There are a wide variety of facial injuries that can occur in the sports medicine world, but I want to go through the ones that are the most common, the things you cannot miss. This is meant to be high yield, and if there is research or articles attached to it, they're towards the end of the talk. Things you cannot miss. The first things you got to talk about is the brain injury, the epidurals and subdurals. Concussions are another talk. I'm not going to worry about that. But what you need to remember that with head injuries, you have to have a high index of suspicion. I think concussions have been belabored. We know how to look for them. We know how to diagnose them. But that's not what I'm worried about in this talk. I'm more worried about the things you cannot miss, the things we've seen, things we will continue to see in the media, the things that end up putting athletes in the hospital. So with subdural hematomas, it's a low pressure bleed. It can be acute or it can even be subacute. It is the leading cause of death. So it's the one you cannot miss. And what will happen is they have either an altered mental status or loss of consciousness that could happen at the time of injury, 2 to 4 hours later, or even the next day. So that next day check or the 24 to 48 hour check after a head injury is extremely important. And this is one of the reasons why. It is a hospitalization and a surgical evacuation. There's no ifs, ands, or buts around it. Typically, if the subdural is small, they'll watch it, but that still means they end up in the hospital for 1 to 2 days. For epidurals, they're more acute because they're high pressure leaks. Once again, you'll get that quick LOC, you'll get the change in mental status. You'll know it, you'll suspect it, you send those. Those are the more easier ones to diagnose. And once again, they will require you to be hospitalized. When you talk about head injuries, the other things you can worry about are the intracerebral hemorrhages and the subarachnoid hemorrhages. These are a lot smaller. They're more capillary based. And so depending on how big it is and how quickly it occurs, it could be minute symptoms or it could be the worst headache of your life. As a result, you have to be able to quickly suspect it based on the mechanism of injury and be able to say something's not right. You cannot diagnose these. All you're trying to do is figure out is something not right? And is my index of suspicion high enough to where they need further imaging? Because these all require imaging. And depending on what it is, it requires a certain treatment. Scalp lacerations. Don't see this as much in football, but we see these in other things. Baseball, basketball, soccer. And when you get a scalp laceration from an acute perspective, the biggest thing to look for is that step-off deformity, because if there's a step-off deformity, there might be a depressed skull fracture. You do not want to sew these up right away. You want these to be further looked at before we do any intervention. And the best thing you do is just the local wound care, direct pressure, keep the pressure on. Don't keep dabbing it in and off to see if it's actually stopped bleeding. Just put the gauze on, leave it on, get some compression around it. And if you're not worried about it, then get it to the appropriate individual to have it sewed up. If it is concerning or you feel like there's any index, even if you don't feel a step off and you're concerned about it, send them to the emergency room, because at that point they can get the CT scan. Don't send them to the urgent care unless they have a CT scan. Don't send them to a freestanding ER unless they have a CT scanner. Otherwise, there's no point to send them there for that reason. Skull fractures are not as common, but we do see them. We see them only because the media is reporting them a lot more. It is still the same incidence irrespective over the last 25 to 30 years. And they're usually non-depressed and very linear. The issue with these, depending on where the fracture is it could cause a CSF leak, it could cause bleeding from the nose and the halo sign. If you remember the raccoon eyes and the battle sign could also indicate other issues with skull fractures, mastoid fractures and whatnot. So just be aware that there are different signs that your body can tell you. So it may not be immediate, but if it is suspicious, don't wait. When you do the on-pair evaluation for head injuries, we're not going to go through this too much, but ABCDE still very, very important. Glasgow Coma Scale still very important. AFPU is another acronym to use if you don't want to do the GCS. If they're alert or they respond to verbal or painful stimuli, then you might be in the clear. But if they don't respond to any of that, then you need to have a further discussion. And you need to continue to monitor them. The big change now is, we used to just check for concussion, say yes or no, and then if they didn't have a concussion, we really did not do a big chest check. Now, in most collegiate and professional atmospheres, that next day check, irrespective of if they've been diagnosed with a concussion or not, is to make sure that they don't have any secondary or delayed signs of a concussive injury or a secondary head injury. The new rules. You have two different rules. You have the Pecan rule, which is the pediatric head CT rule, and you have the Canadian head CT rule. There's a third one called from New Orleans also. These are the two criteria that we use in the pre-hospital setting to determine if they need to get a CT scan done. So any altered metastatus or a GCS score of less than 15 or palpable depression deformity, any LOC greater than 5 seconds with that and younger than 2 years old, or LOC of greater than 30 seconds with vomiting ×2. First time vomit's okay, unless you have other suspicions, but the second time vomit's not okay. Acting like them, not themselves. And if you can clear all that, great. Then your kid you should have a 95 to 97% chance of not missing anything. But if you can't clear all that, then that's a do not pass go. The Canadian head rules or the other criteria you can use, same kind of thing. This is more for adults and more for 18 and above. The one big thing you notice that vomiting is ×2. If you're over 65, if you're doing the sports like endurance races where you have the senior population, they have anything, you scan them at that point. If you don't have anything, then you need to work for things. And it's important to recognize that these rules have been validated in the pre-hospital setting. So this is not meant to be in the ER. This is meant to be for us to send them to the ER. Going through eye injuries, 1.5% of all sports injuries involve the eye. Basketball is the leading cause in the United States. Soccer is the leading cause in Europe. And most commonly it's projectile objects, balls, things, elbows, something going to the face. It's got to be projectile. You can have a functional one-eyed athlete in certain sports as long as their best corrected vision is better than 20/40, except for boxing and martial arts and mixed combat. When you look at the physical exam, there's a lot of different things you could do to examine. And here's the field of 9 that you could potentially do. Now, all of this is very difficult to do, especially if you're trying to do it fast. So I put this graphic to quickly go through it. When you do the external exam, you're looking for any deformities. Doing the visual acuity, yes, that's important. If they can't read, something's not right. And it's the easiest test you can do. You don't have to carry a bedfact eye chart. These lovely devices have Snell charts on their phones. You can put them 4 feet away and they count and are pretty close to being the real thing. Doing the pupillary function, looking back and forth and making sure the pupils react both sides when you flash the light in and out. Taking a quick peek in, looking at intraocular pressures. Obviously, we don't have to do that on the sidelines. Visual fields, it's easy to do. Close one eye, swing the fingers around, make sure all the visual fields are intact, and just do the standard H. Okay, so I take a second here to talk to you about the ocular movements. Doing the up, down, left, right, you will miss the muscles. You have to do the H so you can get all the muscles in the eye. If you go up, down, left, right, you're going to miss 2 of the muscle groups, the superior rectus and whatnot. So do the exam correctly and go, and that will help you quickly decide if anything's abnormal or anything doesn't feel right. Guess what? You just now made a decision to move it to the next step forward. You have different eye injuries. Corneal abrasions, once again, fairly easy to get in the non-protected athlete that are not wearing any kind of eye protection. And they usually cause pain, light sensitivity is a big one, and foreign body sensation. They have a lot of different kits now that you can do the little fluorescein with, and there's different ways of doing it, and I'm not going to belabor going into the lovely book that athletic trainers use to go buy everything on the planet from. There's a bunch of them, but they're all in there. If they have a positive test, being careful to irrigate properly, it is not usually a risk for infection, and using ointments such as the Voltaren eye drops or the Aquarius eye drops will pretty much work. Patching is no longer recommended. It was recommended when I first came out of fellowship. Now it's no longer recommended. So it's been 15 years since we recommended that. Topical anti-inflammatories do work on this. Avoiding steroids at all costs. These will make it actually worse and slow down the healing and put you at higher risk for infection. And 24 to 72 hours, the eyes heal quickly. As long as the visual fields are intact and they can tolerate the pain, they can go back in. Most people will need a day. Some people will need 2 or 3, but usually it doesn't take more than that. If it's taking more than 2 or 3 days, then something else is going on that needs to be addressed. Looking at foreign bodies, once again, it can happen. Penetrating eye trauma. So you can never, unless you have video evidence, you can't assume anything is not penetrated. So even if you take an elbow or you take a finger to the face or some kind of dirt fly to the eye, you assume the worst. The worst is something went in and actually penetrated the eye bulb. So you need to check for it. And the eye exam we talked about 2 slides ago, important. The fluorescein stain is also important. And just looking to make sure there's no leaks, there's no blood in any of the chambers. And if there is, then needs to be evaluated by the ophthalmologist. So it is a hard, fast rule that when you all as athletic trainers, as well as us as sports medicine physicians, travel to an environment that is not ours, it is extremely important to make sure who our local ophthalmologists and dentists are, or make sure we ask that question. Eyelid lacerations, pretty straightforward. You look for globe damage. If it is uncomfortable or there's a big lid margin laceration, we get those repaired, and those will be typically done in the setting where it's most controlled. And you look at other types of sports injuries, orbital fractures, once again, very, very important. You got to have an index of suspicion. You got to rule out globe ruptures, and you got to make sure there's no restriction in vertical gaze. If you had it, restriction, then we send them off and let the eye specialist take care of that. The teardrop pupil, which is the ruptured globe, also very, very bad news. Once again, signs and symptoms are listed there. The biggest thing to remember is there's this 360 subconjunctival hemorrhage. Typically, if you get a subconjunctival hemorrhage, it's either one side or the other side, up, down, left, right. But if it's a 360, that's a big concern. That's a flag. Doesn't matter what it is, doesn't matter how you diagnose it. If you see that, that's a do not pass go. Get them checked out by the eye doctor before they clear it, because chances are it will lead to something. When you look for hyphemas, they're an eye injury when you get the blood in the anterior chamber, and you typically have to refer these to the ophthalmologist, and you have to rule out a globe rupture with this. Shielding before you send them is extremely important. So this is the one place where you have to put an eye shield on because we want to make sure that they don't get any secondary injuries behind it. They get rechecked for every few days, and they will be cleared once they hit less than 25% at that point. The Marcus gun pupil, having a relevant afferent pupillary defect is also very something you cannot miss, especially since all it takes is shining up a pupil, pinprill light, and going back and forth. And all you're looking for is making sure that both pupils react equally. If one doesn't compared to the other, then they need to go quickly get seen in the emergent setting. It cannot wait because it needs to be addressed if it's local, if it's truly a bigger brain injury that needs to be addressed. Two other things you can talk about: the vitreous humors and the retinal hemorrhages. Once again, it's light sensitivity that will pretty much give this away, and both of them require urgent or immediate ophthalmology evaluations. One is surgical, one is not. Switching to the ear, this is, we've talked about, you've seen this a few times in wrestling. For those who cover wrestling, not much has changed in the last 15 years with regard to this. You still want to button them if you can. You can aspirate these if you've aspirated them before and you feel like you have this in a controlled setting. If you don't, then you get the lovely cauliflower ear. And one big change that's happened over the last 10 years is now we do prophylactically cover these with antibiotics just because of the risk of infection that can happen. We were trying to cover staph with these. Swimmer's ears and surfer's ears, two different things. Not much has changed in this realm either. The one thing is now we are traveling a little bit more in all settings. So people are getting on buses, people are getting on planes. And if they have this, you need to have a conversation with your physician to make sure it is safe for them to travel, depending on how acute it was and if they can handle the air pressure. And otherwise, you will typically just treat these like you've always treated them. When you have a tympanic membrane perforation, as it's seen here, there's different sizes. It is important to note the size of the perforation. That's something new that we're doing over the last 5 years. And the reason that's important is it gives us a kind of a guideline on how quickly we think these are going to heal. You do not want to put drops in these initially, because if you put the wrong drop in the ear, it will likely cause the nerve to get damaged. This is a do not pass go. So if you have concern for infection, they will typically take oral antibiotics first, and then maybe switch to topical once we know that the eardrum and then the nerve is not at risk at that point. You want to make sure that you pressure changing sports, you avoid these. So platform diving, for example, is one you typically do not let them do. Dental injuries. Once again, not much has changed in this literature over the last 5 to 10 years. The biggest thing to remember is that if it's a displaced tooth, don't mess with it. If it's avulsed or extruded, don't mess with it. Get it to doctors. If it's a crown fracture, don't mess with it. Get it to the dentist. But if you can put it back in place, the common rules, if you can get it back into alignment, try your best, unless you don't feel comfortable if there's a secondary root fracture. If you look at this slide, once again, there's a lot of different ways that we can preserve a tooth if it can't go back into the mouth. Putting it back to the mouth is obviously the first thing, but if you can't, then there's other ways of doing it. You need to do this quickly. So once again, I talked about the eye referral base, you need to have the dentist in place too. So no matter if you're a high school, college, pro, whatever, if you are in an environment that is not yours and you don't know your resources, these are the two that you will have the hardest time finding on the spot. Everything else will likely be found. So just making sure that you have the ability to be able to access this as quickly as you can. And I think the graph that's in the bottom corner here, which I'll highlight on the laser pointer since Bubba gave this to me, is looking at the different types of success rates based on the solution. So Sabertooth is readily available. It's very easy to get. It is also now in most pharmacies. So if you do not have it in your kit, you can go run to a H-E-B, Walgreens, CVS, and it is sitting there. It is on over the counter. I saw it 2 days ago, so I know it's there. We know that mouth guards can prevent injuries 7 times higher. So that's just something to have for those at-risk individuals. And in summary, you don't reimplant a primary tooth, only a permanent tooth. If you can get it done quickly. If you can't, put in the medium and get them over to the dentist. And if there's debris, try to rinse it with saline, normal saline, and just get it to the dentist as quickly as you can. If you have a sublux tooth, like with any tooth injury, I think this is one that you have to try to use a glove. Don't try to do this with your bare hands. And more importantly, just remember, people bite. So if you cause them pain, they will react. So just like in the ACLS protocol, the finger sweep has been taken away from the foreign object and looking for a foreign object inside the airway. Just be aware people bite, and if you're going to mess with them, make sure you protect yourself too. Nasal fractures. 50% of facial fractures are in the nose, and it could affect the bony surface, the cartilage surface, and or both. If you feel comfortable reducing these and you have had experience with this and you have a relationship with your team physician to do this, not very hard to reduce. You do not need pre-reduction films. You do need post-reduction films. You don't need pre-reduction films. The faster you reduce these, the easier and the better it has a chance to heal properly. The one thing you need to look for is that septohematoma. It needs to be checked the day of injury, the next day, and now the literature even says check it 48 hours afterwards because it can be missed. So that's a do not pass go because it requires an urgent drainage. And if you want to cover for staff, you can, especially when you have a concomitant skin injury with it. Sometimes they'll get the scrape if they hit their nose on the ground. So you want to make sure you cover for that appropriately. You have two types of nosebleeds, anterior and posterior nosebleeds. And you can see the diagram on the right-hand side showing the different ways of doing this. This slide was made for my fellows, so there's a lot of anatomy here because this is a board question for us. But the biggest thing is if it's an anterior nosebleed, which is the most common, you lean them forward and you put compression on, and you can use Afrin if you want to help kind of reduce the bleeding. And you can use a silver nitrate stick in the clinical setting. If you can see the bleeder, don't go trying to stick at something that you can't see. So if you can't visualize where the bleed is, don't go after the bleed. Posterior nosebleeds are the ones that you need to be aware of. If they're coughing up blood, but nothing's really coming out the bottom of the nose, no matter how you do head positioning, that's typically a posterior nosebleed. That's when you do send to the emergency room because that's where you need to have the ENT go in there and do endoscopic treatments more likely than not. If you have the ring sign where you have the blood and then you have the halo around the blood, that's a do not pass go. That's once again concern for CSF, and it could be a concomitant brain injury. So you need to make sure that if you see that halo sign as you're trying to do the tamponade for the nasal fracture, if you see it on your nasal tampon, if you see it on anything, assume the worst. Get them scanned to make sure it's all okay. It could still be mucus or something else coming from the nose, but you do not want to take that chance. Facial fractures, there are 4 of them, and I'm going to go through them piece by piece, but here they are in order. Nasal, zygomatic, and mandibular are the most common in that order. When you talk about mandibular fractures, it's a direct blow to the jaw. Really straightforward. It's tender where it hurts. You may have a laceration, you may have some ecchymosis underneath the tongue, and you may have some loose teeth. Typically, you need to have a CT scan for these, and the best way to immobilize it is what's shown in the picture there, and getting them over to the ER. From a return to play standpoint, typically if you have a non-displaced mandibular fracture, it's 4 weeks if it's non-contact, it's 2 to 3 months if it's contact. If it's surgical, it's going to depend on the type of surgery, but typically the timeline doesn't really change for that. For maxillary fractures, you need to use Lafort classification. Lafort 1 is up here, Lafort 2 is here, Lafort 3 is there. I'm not going to talk through what that means, but basically what it is a direct trauma fracture, and depending on the classification, 1, from an athletic training standpoint, this is one that the airway may become compromised, so making sure the airway stays secured. 2, sitting position helps because it helps reduce the blood drainage down back to the pharynx. 3, if you can't maintain an airway, you will need help getting an airway put in, and typically these will get surgically fixed. So these will also end up in the ER. So if you suspect a maxillary fracture and you have bleeding, you're already activating your EMS protocol and getting them to the hospital with ENT services, so that you don't waste time not having to deal with this. Otherwise, they will get intubated and it becomes a lot more difficult for the surgeon. Zygomatic fractures. Russell Westbrook was the most famous person to have this. It's a direct injury to a cheek. You can see his face. That's in the picture. He had a non-displaced fracture. You can get the sinking of the eye. These have a variable return to play based on what's available and how quickly can you handle it. I've seen these come back 3 to 7 days. I've seen these take 4 to 6 weeks. Just depends on the resources and the time and the comfort level of the surgeon involved in this case. So it's one that you're going to have a hard conversation with. When you look at frontal sinus fractures, those are something that you will see, the direct blows. You get the headaches, the nosebleeds. Once again, you're not going to see these unless you get a CT scan. X-rays are not the greatest for this. So if you're suspecting a facial fracture right in the front, the CT is much more valuable unless it's the nasal fracture. Nasal fracture, you can typically catch them on the X-ray, but once again, you will need to get a CT at some point. Once again, these are all going to get typically referred to ENT or MFS to get evaluated and adjusted for. This entire presentation, this is a paper that was written probably 2-3 years ago, and it pretty much goes through all the facial injuries in elite and professional sports. Most of these rules do apply to the high school settings, so I'm leaving this paper up there in case anyone wants to look it up. It's a pretty comprehensive review. And with that being said, I got 5 minutes to answer any questions. Yep. So I'll repeat the question for those on Zoom. The question was, how do you handle TMJ injuries and how do you prevent them? They're difficult, and they're very, I think I've seen it 3 to 4 times over the last 15 years, and I think they always come in spurts. So it doesn't make sense. It's one of those things in sports medicine. When you get the rule of threes, you get the rule of threes. They're difficult to manage because the TMJ ligament structure, when it does get injured, non-operatively takes a while, unfortunately, because it, like any other TMJ injury that's non-traumatic, those ligaments don't tend to scar down well. And so in the professional and collegiate world, typically those will get operated on. And it's a quick, easy operation just so they can tighten things up and they can get the return to play faster, as well as giving them a better chance of having less of a re-injury. The things you can typically do to prevent them, mouth guards, as you would think, may prevent them. They actually do not. It's usually those that have TMJ injuries. If you look at the literature from a traumatic sports medicine standpoint, it's a prior history of something going on. So either they have the clicking or they have the disc. Unless they take a direct blow, the most common thing that happens is they've already got TMJ symptoms beforehand, and they've been misdiagnosed as otalgia or something else, and they did not get addressed. So it's a difficult thing to manage. If you see more than one in your lifetime as a sports medicine provider in any setting, you consider yourself unlucky because you should not see them. Yeah. Other questions? Can you repeat the last part of it? Thank you, Travis.
Is there a current gold standard for treating head trauma with loss of consciousness in high school sports?
So
I saw the initial stuff for young kids and pre-kindergarten, but nothing for actual high school level.
yeah, so I'll repeat the question for those on Zoom. Is there a gold standard for high school football with head injuries and LOC? So there's 2 different ways of answering that question. The first answer to that question is looking at the SCAT-6. The SCAT-6 is very finite on how to handle that. If there's an LOC, it defines it by age group on if there needs to be any other evaluation. So an LOC has to be witnessed, first of all. There's a difference between an LOC and thinking you have an LOC, and more importantly, how long it lasts. Fortunately, we're blessed in Texas. For most places, I know there's some schools that don't have this. It doesn't take more than 15 seconds for someone to go over there and see it, especially if it's just a teammate, and you need to communicate with those on the field to adjust it. So if there's an LOC, depending on the age group and depending on the time, there is a gold standard. Depending on the age and the time in high school, typically 30 seconds is when you automatically want a CT scan. But for those for younger, it's any LOC depending on the age. The second document you can use is the Pecan rules or this the New Orleans criteria, which I did not list because the Pecan rules are a little bit newer. FIFA just is about to release a new guidelines for kids on LOC injuries from their world data. The NFL, I remember, is about to also release some young, because of their play for 60, they're about to release some of that stuff too, but it doesn't change what the SCAT-6 says. So I would at this point say the gold standard and the consensus is what the SCAT-6 says for LOC.
There was one more right here.
I was just curious if you had any guidance towards reducing mandibular dislocations.
The fun one. So the question was for the Zoom is, is there any guidance for reducing mandibular dislocations? They're difficult. If you have not done it, I will say the following three things. One, the YouTube videos do not do justice on how difficult it is. So for those of us that have access to ChatGPT and the social media, it's not as easy as it looks on those videos. Two, technique wise, I treat it almost like an elbow dislocation. It is only one way it goes back in. We can't do it like a shoulder where you have 3 or 4 different methods. There's only one way of doing it. So understanding that one way is extremely important. And 3, if you do reduce it, you'll take one chance at it, just like the elbow. So that's my best analogy to it. If you watch the technique, which I did not show, and I apologize, I should have shown that. If you do it, you take one attempt. If you cannot get it, then don't risk it further because of the risk of concomitant fractures that could be caused from the reduction attempt itself. All right. Thank you.
Our next presenter is Dr. James Saucedo. He is an orthopedic surgeon, an associate professor and hand fellowship director with the Department of Orthopedic Surgery at the McGovern Medical School at the University of Texas Health Science Center at Houston. He is also affiliated with Memorial Hermann Rocket Sports Medicine Institute. He received his bachelor's from Baylor University, MBA from Rice University, and his medical degree from Baylor College of Medicine. He completed his general surgery internship and orthopedic surgery residency at Northwestern University, as well as hand and microvascular surgery fellowship at the University of Washington Medical Center, Harborview Medical Center, and Children's Hospital Medical Center. He is board certified by the American Board of Orthopedic Surgery with added subspecialty certification in the surgery of the hand. Today, Dr. Saucedo will be presenting on other carpal fractures in the athlete.
All right, thank you all so much for inviting me to be here. Quick story about Bubba, and I had to remind him of this earlier. He and I used to go on Beck's Prime burger runs when I was a medical student with Dr. Lowe. I'll never forget those burgers. They were delicious. It's a pleasure to be here. I really appreciate it. One big disclosure, I've given a version of this talk to the Hand Society years ago. At that time, I think I had to give it within 10 to 12 minutes, so it's nice to be able to breathe between sentences. Also, I want to thank Dr. Bhojani for having a really hard topic. I mean, those were some tough questions he was getting there at the end. But it also reminded me of my time in med school because we used to play softball. And we had a really cute name. We were called the Non-Athletic Doctor Softball. And if you think about the acronym, it's NADS, right? And so we're still young, we're in school. And so we loved it because when our fans would cheer for us, they would say, "Go NADS." That's right, exactly. And the reason I remembered that is because we're talking about these mandibular fractures. One of my good friends, Dr. Jaime Rueda, man, he was probably the most athletic of all of us, went sliding into base, knocked out his jaw, and had to drink smoothies out of a wired jaw for about 4 to 6 weeks. So it is serious, but I appreciate the reminder of that. And then I don't want to leave Dr. Maneen out. He knows my hemoglobin A1C, so mad respect to anyone who does. So we're going to talk about other carpal fractures in the athlete. These are my disclosures. I'll leave it up to you to decide if that influences my talk at all. And we're going to go through a fairly generic outline here. We'll talk about some background. Because we're talking about 7 bones here, I'm going to go through some general principles to give a context. And then we'll kind of keep linking back to those as we go into some specifics about each of those bones. We'll talk about treatment, return to play. As I mentioned, we'll do the specific injuries and then some case examples. And so the other carpal fractures, these are the other guys, right? They don't get a whole lot of respect like the scaphoid does. And so that means, though, that they often tend to be less common, right? That explains why people don't think about them too much. It means that they may be less recognized, less understood, and then oftentimes less treated. And because of that, they can continue to cause pain and other issues. And so quickly they go from being the other guys to the problem child. And I can see that not many folks have seen that movie. I'm guessing the generation here, it's a whole new generation. My gosh, you haven't heard of Goonies yet either, have you? Oh, you have? Okay, thank God. And so one thing that's very important is the eyes see what the mind wants them to see, right? So you have to maintain a level of suspicion and know the anatomy. When someone presents after an injury with radial-sided pain, you don't want to just think de Quervain's or scaphoid fracture. You also have to consider the other bones hanging out over there, the trapezoid and the trapezium, for example. If they present with ulnar-sided wrist pain, it's not just ECU or TFCC or ulnar styloid. It's also triquetrum, hamate, pisiform, etc. You also have to understand the demands of the athlete. And we're not just talking about in terms of how we're going to treat them when they get to go back to play, but also the stress that they're putting their hand and wrist through, right? So racket sports, for example, tend to be more ulnar-sided type injuries, whereas someone who is loading their hyperextended wrist, such as a lineman, may put their capitate more at risk than others. There are x-rays that we can take. I think a lot of us have access to fluoroscopy. You're going to get your standard AP, lateral, and oblique views, but there are specialized views such as the carpal tunnel view where you can see other anatomy, such as right here where you can see your pisiform, your hook of hamate, of which has a little fracture. You also have your trapezium, and you can see some of the others there as well. And then advanced imaging. I generally have a low threshold for getting advanced imaging because we're talking about 3-dimensional objects that we're trying to get a better sense of through 2-dimensional images. So treatment, you have to think about a few things all at once, right? It's patient, it's injury, and it's sport. Okay, are we talking about a high school athlete, or are we talking about a college athlete who's aspiring to the pros, or are they already there? The injury that they have, is this the type of injury that's going to have long-term consequences for that patient or not? One thing that I like to think about a lot is this essential or non-essential? And by essential, I mean, is there articular involvement? Is there stability involved? Is there a tendency towards not healing because there is a tenuous blood supply? Those that are more prone to avascular necrosis, those that are prone to articular injury and instability, I consider essential. All the others are non-essential. And so we're considering that as well when we're thinking about what we're going to do next. And then the sport. This includes the position and whether or not you can immobilize them while they're healing or recovering, as well as whether they have any contractual obligations. Timing is also important. Where are they in the season? In other words, can it wait? Is this an essential type injury that needs to be treated immediately, or is this a non-essential that we can temporize until time is more convenient? The rule of minimization. So we're trying to minimize downtime, we're trying to minimize complications, and we're also trying to minimize uncertainty. So there are times when you have a fracture that may be amenable to non-operative management, but we don't want to worry about it that whole season. Hook of hamate comes to mind. A lot of times hook of hamate fractures, we try to treat these non-operatively. They're non-displaced. It could take 6 weeks to 3 months, and sometimes we're still stuck with an incompletely united fracture, persistent pain, and possibly having to do something down the road. So all these different considerations go into our decision-making. In terms of treatment options, you can cast, you can fix, or you can excise. But you have to ask yourself, how long is it going to take to heal, and how likely is it to heal? How predictable is the healing? Fixing it, once you decide to fix it, there are other considerations involved, but I think it's reasonable, given the right circumstances, to consider this both in displaced and non-displaced fractures. And then, of course, excision, which is going to refer to those non-essential fragments, those ones that it doesn't matter if it's there or it's not, those we may be more aggressive with. This is a nice little table we put together a few years ago that helps us with that decision-making, thinking about essential versus non-essential, displaced versus non-displaced. If it's an essential fragment, again, remember it's joint surface or articular, tenuous blood supply, or has anything to do with stability in the rest of the wrist, you're going to fix it either with open reduction, internal fixation, or closed reduction, percutaneous pinning. That's when you have the wires sticking out of the skin sometimes. If it's a non-displaced fracture but essential, you can consider treating it without surgery, but there are those considerations I mentioned. Sometimes we fix these just so we don't have to worry about it anymore, get them on the road to recovery. Non-essential fragments that are displaced, if they're having pain, we generally just take those out. If it's non-displaced, well, you kind of have your choice. It depends on the situation. You can try non-op, temporize it, or just simply excise it. So you can see with the non-essential fragments, we don't care too much about those. Return to play decisions are going to consider all these other factors, injury features, the treatment that you ultimately chose, as well as patient demands. Non-essential fragments that are painless can be delayed, as I mentioned, or excised if symptomatic. Essential fragments that were fixed, those should be protected until they're healed. If you've committed to fixing it, then they ought to be committed to the 6 weeks to 3 months or however long it takes for us to get healing there. So that's an important part of our conversation when we're looking at the different treatment options for that patient's injury. And positions that allow for immobilization may speed up the return to sport. So that may kind of go into it as well. So as you can see, there's no simple answers here, right? This is a conversation. We really engage in a shared decision-making model. It can be challenging at times, especially when we have kids whose parents aspire for them to be pro players. We know that the chances of that happening may be a little bit better than my getting my A1C down. Dr. Maneen left already, so I'll let that pass. But we're going to talk about specific injuries now. So the trapezoid is pretty well protected. So it takes a significant amount of force. So this tends to be the rarest carpal fracture that we have. It's well protected by its neighbors, but usually due to second metacarpal impaction. Associated injuries are common, so you need to have a high level of suspicion. So I have a low threshold for CT scan in these cases, and this is really going to follow that general treatment guideline that I gave you. Is it displaced or not displaced, essential versus non-essential? You can see why I started with that, right? Because a lot of these are going to follow that pattern. Thank you. Has everyone heard everything I've said so far? Just okay, good. I didn't want to have to repeat all those slides again. The trapezium, about 1 to 5% of carpal fractures. There are body versus ridge fractures. Body and shear fractures are generally due to that first metacarpal impacting the trapezium, whereas ridge fractures can be due to a direct impact or avulsion by the transverse carpal ligament. That transverse carpal ligament is the roof of your carpal tunnel. So when you hear people refer to carpal tunnel syndrome, when you hear people refer to carpal tunnel surgery, they're actually cutting that ligament. And so we don't rely too much on that ligament. So if you have a little piece of that, and if it's symptomatic, a lot of times we'll just go in and take it out. Again, asymptomatic, we generally leave alone. X-rays, the fluoroscan that you might be using in your clinic or in the locker room, AP carpal tunnel view, that's where you're looking actually right down the carpal tunnel. But also the beauty of having fluoroscan is that you can rotate throughout. And so doing that, you'll be able to find a lot more than you would by just taking these spot views. And then again, treatment depends on essential versus non-essential, displaced versus non-displaced. The capitate, that's pretty rare. That's a pretty thick bone of about 1 to 2%, and it's generally associated with other injuries. So if you see a capitate fracture that's pretty clear as the sun on that, you need to look for other injuries, have a low threshold for CT scan or MRI. Generally from fall on an outstretched, hyperextended wrist, and basically that dorsal radius impinges upon it. And present with vague, low-intensity pain. So let's say you had a patient who had a pretty hard fall about 3-4 months ago. They're still having a lot of pain on the center of their wrist, have a high threshold, or excuse me, a low threshold for ordering advanced imaging, but also high suspicion for it. A lot of times when we think central dorsal wrist pain, we're thinking SL interval pathology, but it can also be a capitate. There is a high risk of avascular necrosis with this. So in general, if I'm faced with this, I generally have a pretty low threshold for just fixing these. The lunate rarely occurs in isolation, generally axial and hyperextension injuries, tenuous blood supply. So remember, this is, I would consider this an essential bone or fragment. So advanced imaging if you suspect this at all, such as an MRI or CT scan. Kienbock's, which is idiopathic avascular necrosis, sometimes appears as a fracture on MRI. So that's where the hand surgeon, the rest of the team can come in and help make that determination. So if it was completely atraumatic, we're thinking more Kienbock's. That takes us down a different pathway versus someone who had an acute injury and then those findings. Generally speaking, open treatment regardless of displacement, again, because we're thinking about the predictability, we're thinking about the cost of waiting versus the benefit of early intervention. The triquetrum is one that we see pretty frequently. There's 3 major flavors for this. Hyperextension plus ulnar deviation gives you a dorsal cortical fracture because it impinges on that ulnar styloid. Well, forceful palm reflection and twisting can lead to that ligamentous avulsion, that so-called chip fracture that you'll often see, or you can get compression between the hamate and the distal ulna and get a body fracture. X-rays with lateral and a 45-degree oblique. If you just think about that beam coming down, you're just trying to rotate to get where it might hit on that. So this is where knowing that anatomy is very helpful. And avulsion fractures without associated instability, which most of these are pretty stable injuries, can be treated non-operatively with a brace until they no longer need it. In other words, until they're comfortable. The pisiform can often be from a direct blow from the stick. It may also be an eccentric pull from the FCU, the flexor carpi ulnaris. Think about trying to lift something pretty quick and having a violent eccentric pull that can sometimes pull apart, because remember that FCU is inserting on that pisiform before it inserts at the base of the 5th metacarpal, very similar to our patella. Fewer than 50% are associated with other injuries. You can get PT arthritis, pisotriquetral arthritis, even in younger patients. And carpal tunnel or supinated oblique views can be helpful in finding these. And generally speaking, we're going to excise these if they're symptomatic. And consider, for the surgeons, consider a pisohamate ligament incision as well to decompress the ulnar nerve as it passes through Guillen's canal. So the hamate, we're going to have a few cases for this here in just a moment, but the 3 major types for this are hook, body, and dorsal avulsion. Carpal tunnel or supinated views. So as you're looking on that fluoroscopy, move that wrist as you're taking a look. Generally speaking, the tenderness, if you feel right here on your ulnar-sided wrist, right there, there's that little bump there. That's the pisiform. That's not the hook of the hamate. Okay, the pisiform is that little bone there that cobblers would sometimes use to advance the nails in the shoes. But if you take your thumb with your joint right here, that IP joint, on the pisiform and press down on it, you're basically right there on that hook of the hamate. These are very common in patients or athletes who are using club sports, racket sports, right? We see it a lot in our baseball players. You can consider non-op for these. In fact, traditionally that we would, right? We'd put them in a cast. But it can take anywhere from 6 to 12 weeks for these to heal. And they don't always. There's this one series where they took out a lot of non-union or partial unions in this one series of hook of handmade excisions, and up to 83% were actually just partially united. So the thing is you can nurse this along, you can try to get it to heal, then we try to get back to sport, and it's just this chronic injury to that area. So there is a case to be made for just taking these out, even acutely, and I think a lot of us have started moving that way. Recently, I took one out in the acute setting. My gosh, it's so much easier than if you have it wait and they go to 3 months in a cast, and then they go back to play, and then they re-injure it, and so on and so forth. The surgical planes are much cleaner. So I think a lot of us are going to more acute treatment of this. So we're going to go through a few case examples with some tips and tricks. Again, forgive me, this was directed towards an audience of surgeons before, but I still think it's interesting. If you would, just give me a little bit of feedback. Do y'all want to see some cases, see what it looks like in surgery? Raise your hand. Okay, cool. You said yes, everyone witnessed it, so we're going to go through the insanity. So this is a 22-year-old right-hand dominant male who had a disagreement with a cement block and decided to show their masculinity. And guess what? The block, I think, in the end, silence was golden. And you can see here a little bit of an injury there at the base of the fourth and especially the fifth at the carpal metacarpal of the CMC joint. Okay, so you can see right here kind of falling back a little bit. This doesn't quite look normal. We get a CT scan to take a look. And so you can see this fifth metacarpal impacted into the hamate with a few little chips right there on that dorsal ridge of the hamate. Right here makes it a little bit clear, just impacted, kind of shearing that off right there. And so maybe not exactly an athlete's injury per se, but I think we've all seen those patients who missed the shot and punched the bleacher or something else. I know I took care of one of those a few years ago. So it's para-athletic injury maybe. And so you can see here some impaction, a little bit of comminution. I can tell you, if you drop a vase and you have one or two big pieces, you might be able to fix that, right? If you drop a vase and there's a lot of pieces there, there's a good chance that you won't, right? So the nice thing about this, though, it's like an uncooked egg versus a hard-boiled egg, right? If you drop a hard-boiled egg, some of those cracks they stay together a little bit, right? So the nice thing about these types of impact type fractures is that soft tissue envelope keeps its attachment to a lot of those bones. And so through a process called ligamentataxis, a lot of those fragments can line up, okay? So basically by pulling on it, everything lines up a little bit better. So this is actually, it may be a little bit difficult in an acute setting where a patient's in a lot of pain, but if you can get adequate pain control or even anesthesia, you can get a lot of information by pulling things out and looking at an x-ray. And so I like to treat a lot of these through traction. And so we have finger traps right here pulling through the small and the ring finger, and then we're taking some x-rays. And you can't see it very well here, but what that allows us to do is line things up, and then I don't have to go after each of those small fragments. I just need to maintain that relationship and maintain those soft tissue attachments and maintain that blood supply, and it can heal in that way. And so that's what we did for this patient. We did closed reduction and percutaneous pinning. I actually use bigger pins now than I used to, so I look at that and say, oh my gosh, that actually worked. Well, I think so. You can see right here, I didn't get that piece perfectly reduced, but that's okay, right? Imagine trying to open that up and try to get that little piece of the vase down, right? That's going to be tough, if not impossible, and potentially cause way more problems than it's worth. The juice isn't worth the squeeze, as they say. So we're able to pull those pins at about 6 weeks, and I think look pretty good right there. And I'll show you this little close-up here. You can still kind of see that fragment there. But overall, I think he was able to do pretty well. I don't know if he ever apologized to the cement block or if he took his frustration out on another. Case number 2, so 20-year-old right-hand dominant male, hard fall while playing basketball, had immediate pain and swelling. You can see right here, there's a little bit of a difference between the metacarpal alignment, right? So those aren't quite parallel. So right away, things don't look right. And so we're going to look a little bit more carefully. Right here, Well, there's a little bit of overlap. Well, I'll tell you, depending on the angle that you take these x-rays at, sometimes it looks like there's overlap, but that's because we're taking a two-dimensional image of a three-dimensional object, right? So this gap right here, it looks like they're overlapping, and when you look to the side, they're not. So I wasn't sure if that was the x-ray or if that was a real problem, but the fact that those two lines cross prompted me to get a CT scan, and you can see we have a nice hamate body fracture right there with that metacarpal basically falling into the crevasse. I think that's how you say it, right? No. Thank you for the few that smile at my silly humor. Again, traction, direct dorsal approach. We have a lot more to work with here, big fragments. By using the traction, I am able to free up other hands in the OR with me, right? So I don't want someone just pulling on a hand. I'd rather those other hands help with retraction and so on and so forth. I mean, frankly, as I tell some of the residents and fellows, that's going to be more consistent than they're pulling anyway. So we're able to get everything lined up. I ended up placing a headless compression screw, and it's kind of hard to see here, but the rest of the hook is right here. I did not excise the hook. The hook is right there. It's just a little whitewash. I ended up adding this wire because once I fixed that hamate, I wanted to offload some of the pressure on that hamate body, and so we placed another K wire there going across those cortices to disimpact that. Pull the pin at 6 weeks. These are its x-rays, so you can see the hook of the hamate right there a little bit better on these views, but we're able to get them healed up pretty well. So why didn't I just excise that fragment? It's a big fragment, right? And it was an essential fragment that had an articular surface on it. I wanted to restore that. So last case. 21-year-old right-hand dominant male collegiate baseball player, 5 months of ulnar-sided hand pain, mobilization. They did try non-op management. He's coming to me for another opinion. I think this is the same guy I'm thinking of. He was in the off-season, perfect timing. He's doing really well and on his team, wants to keep playing. If you look here at the hamate view, we don't always get to see this on the x-ray, but we could see it right there. Basically, this is a chronic. From that, it looks like a partial union, still having a lot of pain. MRI, you can see it right here. You can see a little bit. Let's see. Actually, you can't see it very well right there. Yeah, you can. Right there. And then over here on this image, you can see that black line. And then right here on that sagittal cut. We decided to excise it. Job number one for me is finding that motor branch because first do no harm. That is right there going around that hook of the hamate. So we want to protect that because that's responsible for a lot of the strength in the hand as well as a lot of the motion that we get in the hand. We try to remain subperiosteal because we want to protect that nerve as much as possible, get down to the plane of the fracture, take it out, and then really try to smooth that surface where we took it out. I don't repair the periosteum every time. Sometimes if I have a nice layer of periosteum, that's the skin of the bone, I'll repair it over that cancellous surface. We don't always have that, so it's just even more reason for us to make sure it's nice and smooth, because one thing you'll notice sometimes the tendons will kind of come over a little bit towards where that was. You don't want a rough surface that's gliding over. And you can see here that the hook is gone. I got a couple of minutes, so I'm going to wrap this up. Not uncommon to have persistent ulnar-sided wrist pain. It does generally resolve with time, and we can send them back to play once that wound is healed as tolerated. It's not uncommon for patients to say, hey, it still hurts. What have you been doing? I've been working out. Well, that's why it hurts, but you said I could work out. Of course you can, but why does it hurt? Hurts because you're working out, and you can see how we talk in circles. And so a lot of times, they just, I think we have this sense that it's just going to be perfect afterwards, and unfortunately, that's not possible. So it's important that you counsel carefully and manage those expectations. There's a nice study, probably about 8 years now, with Goldfarb and his co-authors, that basically they sat down with these patients, and it turns out that people have pain for a lot longer than what was previously reported. Even at final follow-up, up to 16% of these patients still described intermittent pain here and there, but most of the patients do return to sport. There was a 25 incidents of postoperative complications. Most of them resolved, and they were more common in the non-athletes and in those patients who had a longer time between treatment and onset of symptoms or injury. So in summary, maintain a suspicion for other carpal fractures, consider specialized views. I have a very low threshold for that. you have to consider a lot of different things, right? It's the patient, it's the injury, it's the sport that they're playing. Want to minimize downtime, complications, and uncertainty. So sometimes we are a little bit more aggressive with these. You can immobilize, you can fix, or you can cut it out. Really depends on displaced versus non-displaced, essential versus non-essential. And there's that graph there to kind of help you remember. So return to play, though, depends on the ability to wear a brace. Sometimes we send them back a little bit sooner if we can protect it. 1 to 2 weeks after excision, so there is a big advantage to that. If you are going to fix it, I count usually about 6 to 8 weeks. That's about how long it takes in general for those fractures to heal. You may be able to send them back sooner, as I mentioned, with a brace, unless they have pins. If they have pins, I wait until those are out. Generally, a full return at 10 to 12 weeks. So thank you all very much. I appreciate it. That's my personal contact information in case you want to shoot me a text or an email, or if you have a good dad joke to share.
We do have one question in the Zoom chat. In your experience, do you ever see swelling keeping a fracture from being visible on imaging?
Generally speaking, with soft tissue swelling, it shouldn't distort the image too much. Now, there are times you can have a non-displaced fracture. We refer to those as occult fractures. So you may not see that immediately. Sometimes it takes 2 or 3 weeks to have enough resorption at the fracture site to see it on radiographs. So in general, in those situations, if they're pretty point tender and they had a pretty decent mechanism to explain a fracture, I would just, either immobilize them or consider advanced imaging. I thought I used enough time to avoid questions. Cool, thank you.
Okay, we're getting ready to divide the room into thirds. Wherever you're at right now, stay there, please, for the breakouts. We will be rotating the presenters to your rooms. So we're going to do that. That's going to take us just a couple of minutes to get done. While I'm doing a few things up here, those of you athletic trainers that are licensed in the state of Texas, so you have staters that aren't licensed in Texas, there's a few of you out of state that are. The rules have changed. They just put into the rules for licensed athletic trainers in Texas, you now must show proof of your delegation of authority. You've always had to have it. You now will have to be able to show proof of it. Okay. The other one that went into rules doesn't matter for you because you're licensed. It's a deal for temporary license, but you will have to have your delegation of authority saved and available if it's asked for. So just think like audit or something along those lines. So that just went into the rules last week or the week before. Testing, 1, 2, 3, test, 1, 2, 3, testing, 1, 2, 3.
We have to present it to Zoom, so we're gonna gather around him over here, if you guys will come. Circle around this way. Yeah, it's more like spread around throughout here, like the camera is gonna have him right here, so we're not sitting on that here.
Yeah. And probably want to be close because the face is kind of small.
Yeah.
It only shows so much. So. All right. This is my first time doing a breakout session at this conference in 10 years. So I think I remember what we did last time. I kind of walked through a different topic last time. I know you saw the slide deck. So the big thing today is to actually talk through, and I'm going to show you guys how to do the exam. Unfortunately, I don't have an otoscope and a telescope, so we're going to visualize that, and I'll use my cell phone as the prompt for it. When we do these exams, I'm going to go through the whole exam, regardless of the injury pattern, and then I'll talk through individual pathologies as I go through the whole exam. But the most important thing to remember is in the face, there's not a lot there. It's pretty visible except for the skull, except for the brain. And the brain talks to you because the brain can tell you things just by looking at certain pathologies. So when I give my talk, it was extremely important for people to remember that sometimes in the things you see and things that you get told, don't take them lightly. So you get to my guinea pig. So have a seat. All right. So I know that the head is not part of the facial injuries, but I do want to go through some of the head exam. And I'll go through head to toe, head to neck, not toe, head to neck. Okay, so when you get head injury, we talked about the symptoms that you're going to look for, right? IOC, multiple vomitings, neurological deficits, and whatnot. So I'm going to show you the exam from the neurological standpoint.
You examine the skull, you put some gloves on, and you feel the skull. You don't look at the skull, because if you look at the skull, there's this thing they call hair, and everyone's got different types of hair, and you're not going to see it. Your job in the skull is to look for two things. Anything that feels like it's not supposed to be there, which is a step-off deformity, which is the most common thing, or two, blood, right? Because you can sometimes not see the blood because the hair is so thick, or it's just kind of washed away in the sweat or whatever. So when you do it, there's no right or wrong way of doing it. Everyone has a system, and so I treat it the same way like you do your abdominal exam. Do it the same way every time. Either go quadrant by quadrant, up, down in the 4 quadrants, or go up and down. So usually what I'll do is I'll start off on one side and I'll palpate along and come up and down like a lawnmower and go all the way down. Now, this shouldn't take you more than 5 to 10 seconds to do. You have 2 hands and you have 8 fingertips that you can use. You use your fingertips because they're the most sensitive part. Make sure you have gloves on. If you feel anything or you see anything, stop, note it. Get through the rest of the exam first. I try to get through the rest of the exam first, unless it's an obvious exsanguinous deformity that's causing a ton of bleeding that you need to quickly compress off. So if you have something that's bleeding very rapidly, put something on it, compress it, but get the rest of the exam done first, because the chances are if you get focused on one thing, you're going to miss something else. So for the students in the room, when you're younger and you're still trying to learn everything, it's important to remember that if you get tunnel vision early, you're going to miss something. It was taught to me by my fellowship director. I was burned on it my first year out. I promise you, it happens to all of us, and you do not want to get burned. So when you do that, let's say something happened here at her part line and there's a big laceration. I'll put a 4x4 there. I know that's there. I know it's injured. I'll still use my other hand, quickly walk the rest of the skull going up and down, use the base of your fingertips, and you're looking for anything that steps off or anything that feels like it's not right. Once you get done with that, you're done with the head exam, okay? If you've got a laceration or a bleeding source, you make a decision. Decision 1 is this bad enough? Do I need to send him to the ER? Bad enough meaning it's bleeding and you're not gonna be able to control it. B, you're worried about something showing you it's not supposed to be seen, like you see bone, you see brain, you see other things. If you see it and you don't like it, send it. End of story. When you wrap these things up, wrap it in the way, just like with any other fracture reduction, right? You're trying to close off the space and create some tension there. So if you have a laceration this way, best thing you do is go around the chin. If you have a laceration in the front or the side, wrap around the side, but get a full 360 compression on it so that you can move on. When you do wrap it, at that point, you've already told yourself, you've examined anything that's being wrapped with it, so you don't have to go back and open it back up. In the ATLS protocol, when you do this, if you're going to wrap something up and bandage it, you want to make sure it's already been fully cleared before you cover it. Because once you cover it, taking it off is only going to make it last longer, okay? So you get it done with the skull, you ask those important questions, right? You don't have to ask them if they vomited. You're going to know if they vomited. You're going to ask them if they have any chance of vomiting, because if they're going to vomit at that time, you make sure you have an appropriate trash bag or a place where they can quickly do that. Asking about the headache, they can tell you where the headache is, but if they hurt in a different spot, that's a clue. If they feel like they're not altered or they feel like they're not looking like themselves, that's a clue. So we cleared the head. Next thing we're going to go to is the eyes. Okay, so with most of the face, you'll quickly be able to see lacerations on the face. It's not going to be an issue. So once again, looking at the laceration, it's important to remember 3 things. And my rule of 3 applies to everything when I do an exam because that's just the way I remember things. 1, name the laceration type. Is it linear? Is it T-shaped? Is it multiple directions? Is it, and you can call it however you want to do it, but make sure it's descriptive enough for someone else to understand it. 2, understand the length of it, because the longer it is, the more it's going to be difficult to put tension on it. And 3, is it clean? Right? Is there debris in there, or is there exposure to things you're not supposed to see? So he has a laceration here. You can say it's a 2 centimeter laceration. It's linear. It's in above the eyebrow, and it looks clean. If it's not clean, you can use saline if you're comfortable to clean it off. You look at lacerations. If you have a laceration in any of the facial regions, you remember the muscles are literally right underneath it, right? So you have to make sure that if you do anything to stabilize that laceration that doesn't involve just pure compression, or if you're trying to sew it back up, the muscles still have to work. Because if you sew too deep, and I know that in the athletic training world, suturing is coming. You guys will be able to suture. If you suture too deep, you will actually invoke the muscle, and you'll stop the muscle from working. And that might actually look like a neurological deficit down the line. So you got to make sure it works before you put something in there, okay? So you know the cranial nerve exam. And I'll go through that in a second, but the cranial nerve exam is something you can do. How long do you think anyone takes to do a cranial nerve exam? How quickly can you do it? Give me a number. 10 seconds, 20 seconds, a minute? All right. So if you say a minute, I agree with that. So how much of the cranial nerve exam would I have done before I even got to this point, just by sitting right here? A lot of it, right? They're talking, you can see the muscles of mastication, you can see if they're moving. You can see if the tongue's moving. You probably can get most of the eye exam done with going to focus eye exam. You can see the facial movements. You can get most of that done. So like any exam, a lot of your exam is being done overlapping. So we'll go through the individual nerve findings here in a second, but do as much of the exam as quickly as you can. So once you get through it, we'll get focused on the eye now. Several movements for the eye, right? We talked about the 6 muscles of the eye, and it requires you to go into an H form. So there's different ways of doing this. I'm going to show you all the different ways that I've ever seen have ocular movements done. So Larissa, you can follow me. So you have the simple horizontal plane here, right? That's the one everyone does, regardless. I would say that that's actually not true. This is what I've seen done in various settings. I've seen the diagonals going up, down, down, and down. That's one way I've seen it done. I've seen the straight up, down, left, and right. I've seen the more traditional H, right? So there's different ways of doing it. If you know which muscle does what, then you know which muscles make sense. If you don't remember them, that's okay. The H gives it away. If you do the H and it doesn't look right, then you know something's wrong. You don't need to know what's wrong. You just need to know something is wrong. So starting at the midline, you're going to go side by side, and you're going to go up and down. Now, the movements are one thing, and then as part of your concussion exam and in the new SCAT-6, it's going to comment on nystagmus, saccades, vestibular ocular reflex, and these other big terms beyond the scope of what I'm talking about here, because we've got other things to worry about, but those are important things to remember that you can actually see that just by doing the H exam. If you're doing the rest of the concussion evaluation, well, that's for another time, but just remember that that's all important. Once you do the H exam, the second thing I like to do is the visual field. So I will cover the eye myself because I don't want cheating to happen, so I can see it. So I will stand head to head. So I know the camera's going to block it, so I'm going to keep my hands out covering one eye. The way I typically do is I'll stand nose to nose because then I can see that they're looking right at me. If they're not, then I know they're cheating. So Vanessa, you're going to keep looking straight ahead at the camera, and your job is to come into full planes, coming from above, coming from below, coming from the side, and even coming across, right? So when do you think she should be able to see your fingers moving? How far into the field? Are we talking way up here? Or tell me when you want to stop. How about there, right? Same thing down here, Lisa, tell me when you see it. Right there. So it's really, you've got a great visual field. And you should be able to see it here. And then when you have the eye covered, coming across the midline, you should be able to see it right about at 20 degrees. So your visual field is fairly expansive. You have to do both eyes because you've got to make sure, but the whole time the eye needs to be fixated on a single object. So typically I have them fixated on my nose while I do this exam. So you know I've done 2. The third thing you can do is the pupillary reflex, right? So you can take your lovely pen light or your cell phone, and your job, once again, Melissa, is to look straight ahead. And my job is to bring the pen light across. And if you notice, both pupils will contract. I let go, both pupils will dilate. Coming across the other side, going back and forth. I'm slowed down the exam so you all can see it. So once again, if you don't remember what's what, if it's an afferent or efferent defect, it doesn't matter. If it's asymmetric or it doesn't react, that's a do not pass go. That's one of your check boxes. Okay, right? That didn't work right. Something's not right. Can the pupils be asymmetric at baseline? Yes. Some people have something called anisocoria, and if it's no more than 2 millimeters, it's passable. So you have to look at that baseline exam before you do it. So you've done the visual field, you've done the pupillary reflex, you've done your extraocular movements. If you have your ophthalmoscope with you, which is, we should all have one, including me included, which I don't have. Next thing you do is the quick eye exam. The quick eye exam is not one that's meant to be dilated. So you're looking for several things. You can see subconjunctival hemorrhage. You're looking for any obvious debris. You're looking to see if you can get into the pupil and get behind the pupil, which you can to the most part if you keep the light down. You should be able to see anything obviously wrong. You know what the back of the retina is supposed to look like. So if you don't think it looks right, that's okay. You don't think it looks right, you know what to do. You get them, that's a checkbox. So once you do the eye exam, you've done your mostly INGs, because at that point, you've already inspected it, you've done your range of motion, you technically have done your strength testing of ocular muscles, and you've done your provocative testing. So just like any MSK exam, those are your 4 components, you still have gone through it. And If it looks abnormal and you don't know what it is, and I keep saying this because there's a lot of things we may or may not remember at the time of this injury, because our brain's going to fight or flight, and we not remember. Describe it. I see blood inside the pupil. The pupil looks like a teardrop. I see redness in the conjunctiva all the way around. I see that the eye is not moving equally in all the different planes. The pupils are uneven. One pupil looks like it's blown out. If you can't say it, just describe it, and that's important enough for the next person you're handing off to. Okay? Questions about the eye? All right. The nose. The nose is pretty straightforward, right? Because there's only 3 things you can look in the nose. One, if it looks normal. Now, do people walk around with nasal deformities? All the time. So if it's a nasal deformity that's not tender, what's the chances of it being broken? Fairly low. Okay. So the deformity has to have something associated with it. Bleeding, pain, fluid that's not blood that's not supposed to be there, or a balloon inside the nose, which is your septohematoma. Okay. So the way I do the nose exam is I'll line up my thumbs, both sides, and I'll walk through it, because that's important. You have your bony septum, and then you have your cartilaginous septum. You can feel to an extent what that's supposed to feel like. And if you don't know, you have one on you, you can quickly check it. Once you've done that, if there's pain with it, you can have pain without a fracture. Obviously, you can have a bridge contusion. The second thing is you're feeling for, is it stable, right? So if they say, Melissa, go ahead and say ow.
Ow.
There you go. So now they're hurting there. Now what I've done is, okay, I said I've identified this part. So now I'm going to try to move it around. And if I feel like it's moving around more than I think it's supposed to, bone's not supposed to move, cartilage is supposed to move, then we have an issue. If you avoid about it, and irrespective of what that exam is, you're going to take a look up the nose, and make sure when you look up with your otoscope, and you look not just up along the septal bridge, but you also look back, right? Because you're looking for 3 separate things. 1, to see if you see a deformity in the septum between the nose. 2, if you see any bleeders, whether in the front or in the back. And 3, if you see the septohematoma. You check both sides. Always check both sides. And now we've talked about the halo sign or ring sign. There's a very good chance that you will have blood on your little speculum when you come out if there's a nosebleed, right? Wipe it off with a piece of napkin. Because if you wipe it off, chances are you're going to get the halo sign. So if you don't see it and you put the nose and you do the whole, okay, I'm going to put the napkin in. The textbook says, put the napkin, touch it down, and see if you see the halo sign. Yes, that's the classic education way of looking at it. The other way of looking at it is you see blood on your little speculum device, you wipe it off and you look at it. Because if it's all blood, it's great. If you see anything that looks like there's a discrepancy, then guess what? You now have an index of suspicion for it. That's the clinical side of it. Like I said, everyone has their own chips. Questions about the nose at all? All right. Ears, because we got this thing called ears. Ears are almost as easy as a nose because it's very simple. You can see it and you know what to look into. Looking at the ears, most people will look at the pin of the ear, look at the entire outer boundary, and that's important. Do not forget behind the ear, because you have this thing called a mastoid process, and you can have this thing back there. It's called a battle sign. People have heard of it before. Don't miss it, because chances are if you don't expose it, you don't see it, you're not going to know it's there. So when you look at the front and you look at the back, look for the the auricular hematoma, look to see if there's any issues. Now, pain pulling down, does anyone know what that means? Do anyone remember the sign by any chance? Okay, so there's different signs in kids that don't work on adults. So if you pull on the pin of the ear and it hurts in a kid, usually means there's something going on inside the ear canal. Okay, it doesn't mean what. The pediatric literature may suggest it's infection. But if you pull here and they say ow and it feels like it's deeper, that means there's something going on. And it's a quick, easy test if you don't have an otoscope to say something's not right. When you look, once again, before you stick the otoscope into the ear canal, make sure you look at the outer ear, external auditory canal, because what you're looking for is something that's not there. Drainage, blood, crusting, or things you're not supposed to see, like a halo sign in the ear either. That can happen because that means you've got a significant injury. When you stick the otoscope into the ear, the most important thing to remember when you stick the otoscope into the ear is you watch it go in. You do not go in blind. You do not stick the otoscope in and then go look. You want to look as you're going in, because you're going to want to see the canal you're going to want to see the tympanic membrane, and you want to make sure you don't pass anything. Because how many times have I seen people get burned by saying, "Oh, there's blood in the ear, but we can't find the source," and you go look as you go in, and it's sitting right there, and you just went right past it. So when you go in, you look, you go out, you keep looking to make sure there's nothing there. That's only in the traumatic case, and if you have the index of suspicion. When you look for tympanic membrane, you look for your three sound bones. You look to make sure there's no bulging, retraction, blood, or anything like that. If you see something that's suspicious and you want to clear it out, make sure that the eardrum's intact. If you cannot see the eardrum, you don't know if it's intact. So you do not put it, unless you can visualize it, don't assume that it's intact, okay? Going into the mouth, go ahead and open your mouth for me, thank you. How many teeth do you have? 30, 36. How many teeth do kids have? It depends. That's the right answer. It depends. So if you don't remember the number of teeth you have, you look at the symmetry of the mouth, right? Unless they had a tooth come out, you can quickly figure out if all the teeth are in there now. When you're looking for injuries, you're looking to see, is the alignment of the teeth intact? One, don't look at the tooth from the bottom part. Go ahead and open up. Don't look at it from here. Look at it from the base, because the base is going to tell you if it's sticking forward or sticking backwards, or if it's pulled up, or if it's pushed down, right? You're also going to be able to see fractures by looking at the base and working your way up. Don't look at it from the top down. Look at it from the bottom up. As you look for the teeth, you're going to look for three things. One, is it in alignment? Two, can you keep it in alignment? Or three, is it going to fall out? Because if it's going to fall out, you need to make a decision if it's worth letting it fall out, because what's the first thing people are going to do when it falls out in their mouth? They're going to swallow it. They're not going to try to spit it out unless it's by the time it's too late. They're going to try to swallow it. So if it's unsafe, then you need to figure out a way to either splint it or make a decision if that tooth is loose enough just to come out and put it into a saber tooth and move on, because then the gum is injured and then you're going to go. We've talked about the teeth. What we didn't talk about is the uvula, the tonsils, the adenoids, and the tongue. Okay, so you need to visualize all of that. Make sure you visualize on the top of the tongue. You can stick it out, measure your leg up underneath. Make sure you look at the uvula, because you can have uvular injuries. Make sure you look at the tonsils. Even the tonsils may not be enlarged, you can get tonsillar injury, you can get tonsillar bleeding. And make sure you palpate underneath, because your parotid glands and your sublingual glands are sitting right there. So in 30 minutes, I've gone through the entire facial injury section. This should take you no more than 3 minutes to get through on a real exam. And 3 minutes is a comprehensive exam. If you don't know, based on the history and based on what you saw, what you're looking for, check it all. I'd rather you just check it all and take the 2 extra minutes and be done with it, than rather than miss it and come back later, because there's a lot of things you can't see with the naked eye. You have to go look up orifices, the nose, the ears, the mouth, even the eye, behind the pupil and in the retina. That's technically something you have to go look into. So if you don't see it, go find a way to look at it. For those that are worried about the cost, it's important to remember now that, and I just give this plug because it's important. You can have Bluetooth-based otoscopes and ophthalmoscopes. They cost $50 on Amazon now. I don't know if you've seen that. And you can stick the camera in, and you can watch it on your phone, and you can see everything on your phone. So if you don't want to pay the $250 or $300, $50 is much more valuable. It's better than nothing and not be best as everything, but it's better than nothing. So doing the facial exam with the right tools is very easy to do, and it's very easy to carry that stuff in your kits as you travel wherever you go. With that being said, I got 2 minutes. I have open up for questions. Yeah.
On average, how long do you feel that it would take for a nasal hematoma to develop?
Fastest one I've ever seen is 20 minutes.
Repeat the question.
Yep. The question is how long or how quickly can a septal hematoma develop in the nose, right? Fastest one I've ever seen is 20 minutes. I can tell you exactly when it happened. It happened in my fellowship. The longest one I've ever seen, I want to call it long, is 48 hours. I saw one happen 2 days later. I didn't examine the athlete the 2 days prior to it, but I examined them in training room from a Sunday game on a Tuesday, and I saw it on Tuesday. And so it's variable. And that's why with facial injuries and head injuries, the next day and the subsequent day follow-up, it doesn't have to be fully comprehensive. It could take a little more than 3 minutes. That is an important check for you because you don't want to miss it.
Zoom has a couple questions. So,
Yep.
So one of the questions was Someone had a 10-year-old with the front 3 bottom teeth knocked backwards from a baseball. It's still intact in the gums. Would you recommend us trying to like reset before something?
So 10-year-old, 3 teeth knocked out, pushed, so posterior subluxation, prior dislocation, right? And what would you do, right? So there's 2 questions I would ask. One, is it your primary tooth or your permanent tooth? If it's your primary tooth, what do you do? No, take them out because it's not going to matter. As long as you can, as long as you can feel comfortable that the root is going to stay intact. If you don't, splint it and move on. If it's a permanent tooth, once again, if it's multiple teeth next to each other, the better answer is to not try to take it out and just leave it and try to get some immobilization to it, and then get it to the dentist as quickly as possible. Second question. So if you are comfortable doing it, it's like putting a shoulder back in, right? The first time you do it with someone in the room, when you feel comfortable putting a nasal fracture back in or resetting it, it's like a shoulder fracture. If you've done it one time with someone around you, it's very easy the second time. If you've never done it, then there's only 2 reasons that I would consider attempting it. One, if it's an obvious deformity that you know you need to put back in place because it's causing airway compromise, or 2, if you feel like it's going to cause a bigger problem if you don't do it. And the bigger problem is this. You're sitting in a small town 150 miles away from your nearest big city. You know you're not going to make it back that night. And you know that at that point this may become more problematic because of airway compromise or because of continuous bleeding or whatever. Then you need to have a discussion maybe with your team physician. And we have these things called FaceTime now, so you can quickly video it and watch it happen. Parental consent, obviously important, having a conversation with the parent, as well as making sure that you don't make more than 1 attempt. Don't not make more than 1 attempt. If you can't do it in 1 attempt, then it's not worth trying at that point, because all you're going to do is cause a second fracture, and then that becomes a lot harder to manage. All right. Any other questions from Zoom? Well, thank you guys for this, and I'm going to go jump to the next room. Ooh, I'll take this. Yeah.
Yes, of course.
I guess I need to look this way then. Oh, okay.
Not block this.
I see. Okay. All right. So I think I gave my best presentation of the day over here already. So I'm sorry. You get the seconds here. First of all, before I get started, any questions about the presentation? I realize I should have brought a skeleton or a sawbones model of the hand and wrist. I apologize for that. I'll do that next time. But one of the things that we talked about over there is there are differences in when we see them in the office versus when you see them in the locker room, right? In terms of acuity. So a lot of times when I see them in the office, it's a little while after the injury. So I'm going to just speak generally about patients who are coming into the office, and then we can sort of update that as needed as we go through it, such as different considerations, if they're really swollen or really tender, that sort of thing. In general, when they're acutely injured, things are going to be more swollen, they're going to be more painful. So you may not be able to get a full exam, right? Instead, what you might get is point tenderness, but that's still useful information. So when they come into the room, I'm looking at a couple of things. I'm looking at how they're swinging their arms, how they're guarding it, if at all. I might even go to shake their hand, even if it's the injured hand. I know not to squeeze it, but they don't know that. And so you get a lot of information right there, actually, because sometimes they'll say, this is the one that's hurt, Doc, right? But that tells you a lot about their personality, as well as how much it hurts or may not hurt, how functional it may still be for them, versus someone who's like, right? And it's very dramatic, right? That gives you kind of a, I know I felt like Dracula. That gives you a little bit of a sense of personality and or how badly it hurts them, right? Because that can give you important information about how things are going to go in this treatment relationship as well. Because someone who has a lot of anxiety, that's something you have to account for and you're going to have to manage. And I think we're talking about it more now than we used to, but that is a pretty critical part of a patient's outcome. We know from studies, they've been demonstrating this. David Ring is one of the champions of this out of Austin. But depression has more to do with the patient's outcome, their self-efficacy versus the catastrophization that they engage in is going to impact their outcome. So that's a little bit of an aside. So once I do that, I'm observing as they're talking and telling me about the injury, the trauma that occurred. I'm looking at how they're using their hands. I'm someone that talks with my hands a lot, for example, and you kind of get a sense from folks too of how they're using it. If they're kind of moving their backpack out of the way with the injured hand, that gives you a sense of how bad or not so bad it is. Because at some point you're going to ask them how bad is the pain, and if they say 10 out of 10 and you just saw them move that heavy bag out of the way, you believe them that it hurts, but it kind of gives you a different sense of how bad, right? So I'm watching it, I'm looking for swelling, I'm looking for bruising, I'm looking for guarding, all those different things. And then when we want, and that's part of the exam, right? Before I've even laid hands on them. Then I'm asking to move everything. And I might have them start with their shoulders just to get a global sense, even though I don't take care of shoulders or, even elbows as much anymore. Hand and wrist, that's still part of it, right? Because number one, if they had a wrist injury, you might have a frozen shoulder. You don't want to miss that, right? But it also kind of gets them used to the exam and everything. So shoulders, checking the range of motion, checking elbows in terms of extension, flexion, supination, pronation, and make sure they keep their elbows to the side because you can cheat a little bit. I had an old injury when I was little. I don't have full pronation there, so I cheat and bring the elbow out. But that gives you a sense. If they're able, again, if they're acutely injured, they may not be able to do all these things, that's okay. But let's say they're a few months out, I might have them check flexion and extension, right? Reverse that order. Finger range of motion, might even take them to all the fingers. I didn't do that last time. But these are all little range of motion things, right? Because you're checking range of motion. You're also checking to see how they're guarding, if at all. It also kind of distracts them a little bit because now that you're kind of looking at the things they can do, right? Not necessarily the things they can't do. So once I start moving on to the next part, this is when we start examining, and this is where, this is where I think having a model or a diagram would have been helpful. But as I mentioned earlier, that talk was primarily to surgeons, and I had like 10 minutes. And so I had to assume they knew the anatomy. But so we're looking at everything again. Maybe you've already moved everything. Now we're going to touch and press and manipulate. And so starting over here, what did we do first? I think we did we did ECU, right? Yeah. So hold the head over here. Okay, so I'm kind of pressing around there. Immediately adjacent to that is your ECU tendon, the extensor carpi ulnaris. Okay, so the back of the wrist, all the extensor tendons are organized into 6 dorsal compartments. Okay, so the 6th one is the ECU, and that's going to be right here in this area. So I might press around on that to kind of get a sense of how painful or not so painful it is. I might palpate over here the ulnar styloid. Okay, might palpate along the distal radial ulnar joint. I may even come over here and I'm trying to do it in the same order, but I don't know if we're going to be able to. I might have them put both forearms right here, bring thumbs to pinky, and have them slowly rotate. And I'm looking for any ECU subluxation. She actually has a little bit of it right there. But basically, when you go into supination, that extensor carpi ulnaris is going to take a little bit of a sharp turn. It's not a sharp turn, but it's a sharper turn at the end of that subsheath as it inserts over to the base of the 5th metacarpal. So subluxation in and of itself is not pathologic. A lot of us have bilateral asymptomatic subluxation. That's not the problem. It's the painful subluxation. But it's important to do both because one, it helps you to pick up on it if there's any asymmetry. I just took care of a collegiate golf player and she had bilateral subluxation, except one was way more swollen, way more painful, and she'd been dealing with it for like 6 months. Okay, despite rest and all those things. You can see how that's going to push me more towards surgery versus immobilization and rest, right? So you're checking for that. Another thing you can do is, let's say it is kind of swollen, it is kind of painful, then you may want to check another thing. Have palm to their face towards them, spread those fingers out, resist me, or mantenga for your Spanish speakers. And that is called ECU synergy test. And it's a very strange test, but how the heck is that causing pain right here in the ECU tendon? I don't know. I'm not going to think about it right now, but it does. And so it's a fairly specific test for ECU tenosynovitis. The other thing while they're there is I might check for the distal radial ulnar joint for stability. Okay, so DREJ stability. So I'll keep her in neutral. Okay, and what I mean by neutral is thumb is lined up with her humerus there. I'll stabilize her hand over here. I'll take her ulna. I'm not up here because if she has pain up here, it's going to hurt as soon as I press on it, right? I'm not checking for pain as much as I'm checking for stability. So I'm going to check it here, and I'm going to move it back and forth like that. Okay, now it's okay if she has pain, but my point is I want the pain to come from the motion, not from the palpation, right? And I might take her into supination, stress test it there to check for stability, and then in the pronation, same thing. So it's basically assessing the ligamentous stability of the distal radial ulnar joint with those motions. The other thing I might do is press right here at the distal ulna, okay, into the fovea. I'm looking for TFCC pathology when I do that. This move here, aside from stability, let's say it's stable, but it's painful, that can actually give you an indication of very specific TFCC or triangular fibrocartilage complex pathology. It's called the subcruentum. I didn't talk about that last time, but that's a nice little advanced pearl there for you. Okay, so we've talked about the DRUJ, we've talked about the distal ulna, the ulnar styloid, the ECU tendon. On this side of it too, we can talk about the FCU, okay? So the flexor carpi ulnaris, remember it's going to insert through that pisiform to the base of the fifth metacarpal, much like your extensor mechanism with the patella into the tibial tubercle. And so you can press right there at the pisiform, at the pisotriquetral joint, okay? And then sometimes if it's a little sore, but not really, and I'm trying to get a little more specificity or maybe even a little more sensitivity out of it, I might have her flex her hand against me, or flex her wrist rather, and I'll take my other hand and kind of press on that pisiform and along the FCU. And sometimes if they have FCU tendinitis or calcific tendinitis or pisotriquetral arthritis, or a fractured pisiform, all those little things can present right there in that area. Okay. One point I made in the other room and I didn't make here, and forgive me for that, is even before we've done all this, I have already looked at the radiographs 9 out of 10 times because that's just how the workflow works out. And I'm looking for everything that might explain what their pain may be coming from. If there's an obvious injury, I acknowledge it, but then I look at everything else and then I'll go back to that injury because I don't want to miss anything. But once I examine them, let's say there's a couple of things that have popped up on here, I'm going to go look at those radiographs again with a new set of eyes, right? Because now I know what hurts and they've pointed it out and I've been able to recreate it. Okay, so we talked about the pisiform, the FCU. The other thing I might do is remember IP joint of your thumb. That's that joint right there on the pisiform. Roll your thumb in, and that's going to put you approximately at the hook of the hamate. She had some tenderness earlier, so I'm not going to press on that again. We've talked a lot about that. Moving more radial on the wrist. Over here at this little gap right there, that's usually going to correspond with your SL interval. So the scapholunate interosseous ligament, if they have some pain and or swelling there, that suggests some pathology. Around that area though, if we're going to go back ulnar. So we talked about the pisiform, we've talked a little bit about the triquetrum. The hamate, it's going to be at the base of the fourth and the fifth metacarpals. Moving more radial at that level, roughly, it's going to be the capitate. You're going to feel kind of that little dip right there, that's sort of capitate neck going to the scapholunate interval roughly. Over here, moving even further radial, we have the radial styloid here, but then we have that anatomic snuff box. And does anyone know why that's called the snuff box? Yeah, exactly. Yeah, we've been looking for all the partiers in the room. That's as she was pointing out a while ago. So at the floor of the snuff box is your scaphoid, okay? We didn't talk about this over there, but if you go on this side, then it's the scaphoid tubercle, right kind of at the base of the thumb. But distal to the scaphoid, you're going to have the trapezium at the base of the thumb, and then you're going to have the trapezoid at the base of the index metacarpal. And between those three bones, you're going to have the triscaphe joint, or the scaphotrapezial trapezoid joint, or the STT joint. Okay, so you can see it's a mouthful. So when you hear STT joint, we're referring to that joint over there between the scaphoid, the trapezium, and the trapezoid. And that's all in that area. And then going back ulnar, so we talked about the scapholunate interval. We talked about the scaphoid. We didn't talk about the lunate. The lunate, sometimes it's a little bit covered by the dorsal lip of the distal labia, so it can be hard to feel. So if you flex down the wrist a little bit, you can get in that area a little bit more. But I'll be honest, especially if a patient is pretty swollen, sometimes it's hard to kind of know exactly what bone that you're pushing on. You're using surface anatomy and you have a pretty good sense of it, but when there's swelling, I mean, sometimes you can't feel it very well. However, it gives you enough information still, though, that now you've pressed on them, right? You have a good sense of where it really hurts. Now you can go back to those x-rays and look at them again, right, with sharper eyes. So we got that question earlier about, can swelling obscure radiographs? I mean, I understand the sensitivity of the question, and I think more often than not, what it really is just that it's not displaced enough to fully see it. But if you get a good exam and you get the point tenderness, sometimes you can see that fracture even if it's non-displaced. But it really does take 2 to 3 weeks sometimes to see it. So there's enough resorption. I hate to say it, we're humans working with humans. There's variables on both sides of that equation, right? So sometimes we're not going to see it unless we have a high level of suspicion. Every once in a while, you'll have a patient come in with a non-displaced fracture. You don't see it. Then it becomes, so then you immobilize it, you protect it, you bring them back, you repeat radiographs, and then, oh yeah, you do see it because now you have the resorption. Sometimes if you look back at them and you look carefully enough and you cross your eyes a certain way, you can actually see it a little bit, okay? But again, hindsight is 20/20, right? So, all right, so we've talked about the different bones. I think we've covered all of those. There are a few provocative maneuvers we can do. This one right here is called the Watson scaphoid shift test. This is to assess for scapholunate interosseous instability or disruption of the scapholunate interosseous ligament. You're going to bring them into ulnar deviation. You're going to put your thumb on the scaphoid tubercle, kind of applying a dorsal directed force, and you're going to go from ulnar to radial deviation while trying to relax that a little bit. And basically a positive test is a painful clunk, because what you're doing when you start out with that test, you're basically pushing the proximal pole of the scaphoid, the butt of the scaphoid, out of the scaphoid facet a little bit. You want me to do that again? Yeah. And then as you bring it in, you're kind of, that scaphoid is allowed to reduce back into the scaphoid facet, and a positive test would be a painful clunk. Okay. Let's see, what else?
I think you did pretty much everything. Anybody have any questions or anything specific that you've run into?
You know, one thing we didn't talk about, so we didn't talk about the rest of the hand. So thumbs are a really common injury. Checking the thumb MP joint. Sorry, I didn't mean to cut you off there. You know, so you're going to assess the stability in a couple of different ways. If they're really painful and swollen, your exam's going to be limited. But if you're right here in full extension at the MP joint, you're testing the accessory collateral ligament. You want to bring it down to about 30 degrees of flexion to get the proper collateral ligament. And basically what we're looking for is a hard endpoint. If you have a hard endpoint when you stress it, then it ought to be okay. If it's a soft endpoint, like in other words, if you were a callous person, thank you, and we're going to keep pulling it and you didn't care what they said to you, it feels like you could go on forever. So that's a positive test for instability. You know, sometimes we'll even numb up the thumb to get a good exam that's not limited by pain. And that's one of those situations where, yeah, you can feel a soft endpoint. There are certain thresholds that we use, like 30 degrees of deviation there at the joint, or 15 degrees more than the contralateral side. Because remember, God gave us one side to compare to the other. So sometimes it's not super obvious. So you're just comparing the amount of instability compared to the other side. If you have someone who fell on their thumb, they're really swollen, it's painful, and they have a big area of swelling right there, be especially suspicious of a ulnar collateral ligament injury. Even a Stenner lesion, that's where that ligament gets ripped off so violently that it goes over over the adductor aponeurosis and is sitting on top of that. And for a lot of us, that is a surgical indication. So I think those cover the big things. The metacarpals, palpate along those, palpate along your fingers. We didn't cover hand as much over in the other room. Trying to think of some other things. Someone punched something. Oh, go ahead. Yeah. Save me from myself. Yeah.
Type of big race plan, what would you recommend? Because a lot of times our athletes get older, end up with a permanent deformity. It really takes.
Yeah.
So like I said, the split does the trick most times, but if you don't have access to that, what would you recommend?
Yeah.
Repeat that.
Yeah, so he asked a really great question about boutonniere deformities and the treatment for that, specifically regarding splinting options. That is a brilliant question. I'm glad you asked it because that really is a tough problem for everyone involved. And so basically a boutonniere is a disruption of the central slip. That is part of the extensor mechanism that inserts in the dorsal base of the middle phalanx so that you can extend your PIP joint. Okay. What can happen is if there's disruption, and it's not always immediately obvious either. I mean, sometimes they're able to pull through with their lateral bands and extend that joint. But what happens over time is you get this boutonniere deformity that kind of goes into this position right there. Okay. So basically the proximal phalangeal head buttonholes between the central slip right there through the rent where the central slip used to, or excuse me, between the lateral bands through the rent where the central slip kind of retracted a little bit. And these are very challenging to treat in part because they develop a flexion contracture and now you're dealing with a deficit because that extensor tendon component can't pull that middle phalanx into extension and a contracture where things are actively now working against you. Okay. So the quicker you can get to it, the more successful you're going to be. PIP joint extension is going to put that central slip closer to its insertion point and actually give it a chance to heal. And sometimes it's not immediately obvious. If you get x-rays, you might get lucky and see a little chip fracture where it pulled a piece off like an avulsion fracture, but you're not always that lucky. Sometimes if the pain will tolerate, you can do an Elson test where you hold resisted flexion at the PIP joint and you ask them to extend against you. And if the central slip is intact, this actually gets pretty floppy. Okay. And so an easy way to do is have them put both fingers like that together and tell them, try to meet those two in the middle. If you have an intact central slip, you can't do it. Okay. If their central slip is out, basically it uncouples the extensor mechanism and then those lateral bands and the continuation of them go into the terminal tendon at the DIP joint and it'll actually kind of look like this. Okay. So that's the Elson test or modified Elson test. If you don't have a figure 8, get an alumifoam and just get that PIP straight. And I would leave the DIP joint free because what happens is as they develop it, you have this unopposed extension at the DIP joint, and you can start getting an extension contracture that is married to the PIP joint flexion contracture. So by getting them straight right here and having them do this, that can be helpful. So there's other treatment options. Don Lalonde out of Canada, who popularized wide-awake local anesthesia, no tourniquet surgery, or Lalonde, also has a great protocol that he and his therapist developed together for boutonnieres. And so I won't give the exception. I can give you the exception later, but just to stay on time, basically you're going to immobilize that PIP joint essentially full time for about 8 weeks. And then you go to part-time immobilization, meaning for the next 8 weeks, you're going to put them in a relative motion orthosis or reverse Wendell Merritt. So a Wendell Merritt, you have them in extension at the MP joint, a reverse, you're going to put them in flexion at the MP joint. What that does is it helps recruit those lateral bands, dorsalizes those lateral bands, and so now you're able to extend a little bit more. So you do that during the daytime for 8 weeks and then nighttime extension splinting. So about 3 months of recovery. And there's a few exceptions to that, but yeah, tough injury. Great question. Yep. Thank you. Oh, yeah. Thank you, sir. Thank you.
Awesome. Hey guys, thanks again for having me. I'm Dominic, Maneen. I'm going to show you kind of a rapid fire for some of the OMT that I do in sports medicine. A lot of you guys know a lot of this and maybe different names, so it should hopefully be a refresher, but just some things to think about and things you can do kind of right away to help. So concussions are something that I think go undertreated in terms of, hey, we just kind of say give it time, which is not wrong, but there's things you can do to help with the symptoms. So I really like focusing on those cervical muscles in a concussion. So the first thing I usually do with my concussion patients is really think about that suboccipital release. So you guys know right below that occiput, you get your fingers kind of right below it. And then the key with everything today and just your manual therapy in general is let your hands do the talking. Don't try to force it where it doesn't want to go. I think we tend to either do not enough pressure or we try to say the textbook said to rotate his head 30 degrees. That's not the case for everyone. So right now I just have my fingers, and this is his third time getting it. So he's kind of loose now, but you're going and I'm just pushing my fingers directly up. And then I'm letting his muscles kind of talk to me. Does he want to go left? Does he want to go right? Does he want to come up? Does he want to come down? So and this is a great time for you because you're, normally sitting at the head. So it'd be like, hey, tell me about, why, what do you think happened if they're not sure? Or just you guys that are with them for hours a week, this is a time to get to know them. How's school going? How are your classes? How's mom and dad? Everything in between while I'm just letting that muscle release. Then if I get a good release, great. If I don't, I'll kind of get on each side and then just do an effleurage kind of that treatment. So I'm just milking those muscles kind of towards me like this. So the key is getting your fingers deep enough into it. You're not going to hurt them. There's nothing really here in sense of like, oh, are you going to make a broken bone worse or anything? So I'm just pushing up in and then I'm just working it out. And I'll move down that cervical spine to kind of do all 7 levels for that and do that on both sides. Then something that goes very under recognized is the venous congestion that we get with, yes, concussion, but this works also for, colds, bronchitis, allergies, everything in between. So kind of your frontal, your ethmoid sinuses. There's sinuses on your scalp as well. So think of when you palpate a baby and their sutures haven't closed, those then become sinuses in, adults. So remember that picture where kind of from here is one side that this kind of your arm and upper right thorax has a lymphatic drainage, and then the rest of the body, legs, everything down is up here in that left thoracic inlet. So whatever, your school calls it, drive kind of a lymphatic bus and open up that lymphatic chain. So then I can do the lymphatic treatment appropriately. So for concussion, for URIs, I'm going to start at that superior sagittal sinus and just work my way down. This one a little bit more using your anatomy where, okay, I know the sinus, the suture is kind of right in the middle. So I'm just on each side of that suture. Our goal is to get everything to drain through here. So that's kind of the direction I'm leading it in. So I'll start there for, a few rounds, if you will. Then I'll move to the frontal sinus, and that's where I may do, one side versus the other. So just so you guys in the camera can see easier, let's say on the frontal sinus, again, dividing it kind of in half. And now I'm just using your fingers almost like a myofascial release. But again, just make sure you get your angle right. You're kind of trying to drain it towards that inlet that you just opened. Then I'll go to the ethmoid, come in. So this is great for people that sound like me and your kid gets you sick. Moving those sinuses down and draining. Then is when I go to that posterior and cervical chain. Board BOC questions they love is, remember, the posterior lymphadenopathy is usually associated with mono. Why, we don't know, but it's a good exam skill and board question. So then I'm just getting back on that lymphatic chain, starting just below the occiput and just rotating again, going towards that inlet that we opened. All right, and then just remember at the end, you want to make sure that everything drained and kind of drive the bus again. A little bit more nuanced, osteopathic world, the cervical spine. So my concussions, the vertebrae in the cervical spine don't have a lot of rotation as much as they do side bending. So I'll palpate starting at C1 and go down. And all I'm doing is palpating to see, hey, is one side seem more sideways than the other? So if it's, let's say tilted to the right, for example, then you want to check that in flexion and extension. So in the DO world, we name things for where they want to live, meaning if when I flex his neck, things get better, okay, then he has a flexion dysfunction. Versus if I flex it and it's like, oh, wow, that got a lot worse. Let me check an extension. Okay, he's a lot better in extension. He's got an extension dysfunction. And now is when your muscle energy 101 comes in. So if we're wanted to do a direct technique and he has a flexed and let's say rotated side bent right, I'm going to flex him up to that level. So we'll say I'm at maybe C4 right now. Then I'm going to side bend and rotate. And then you're just going to have your patient with, a fifth of their strength, try to push back towards you. Good, good. And he holds that and relax. Then you take them further into that barrier. The key is what barrier you start at is just where you feel the restriction. Because, if you watch a video or a textbook, they're going to, flex him, rotate, side bend. It's like, all right, now you're getting into the upper thoracics. Just listen to kind of what the hands are telling you. And here's where I'm already feeling restriction. And he doesn't even look flexed, but he is. And then I'm going to rotate and side bend that way. So that's good kind of muscle energy we can do as well. You can do it kind of on both sides. If he has multiple levels, if it's something that's not getting better, or let's say it's just neck pain and not concussion and he's got to play this weekend, that's where I'll come in and, manipulate and actually do a thrust in that regard. Okay, so that's kind of my neck concussion side of things. The pelvis is another one that I think goes overlooked. You guys know muscle energy for the pelvis, but I'm just going to walk you through kind of my diagnosis. So the first thing is your anatomy. So finding that ASIS. So on bigger patients, if you need to use your thenar eminence, your thumb, and I'm just looking to see is one side higher than the other. Then I'll move all the way down to his malleoli and kind of see the same thing as one leg longer than the other. And I'll say, hey, sit up without using your arms. And all you're looking for is there a change. Whether it's better, worse, becomes equal. If there's a change, you've diagnosed a functional leg length discrepancy. So now it's your job, my job, to kind of find, okay, why is that happening? So we'll just say, to give you guys the benefit for both. Let's say he was anteriorly rotated on this left side. So your exam on the front, if this is anterior rotated, this left ASIS is going to be lower than the right. And then this leg is going to seem longer than this one. You're like, okay, is that not sure? You flip them over onto the back. And we were on this side. So if he was anterior rotated, I would expect this PSIS to be higher than the one on the right. Because then I know, okay, we have an anterior dysfunction. I'll always, when I have them on their stomach, do a quick sacral diagnosis as well. The sacral base, like I said, really moves with respiration. So I'll get my hand just on that sacral base and you breathe in and out. And when he breathes in, it should be extending backwards. And when he breathes out, it should be flexing. So if I feel like there's restriction, I might spend some time here doing some treatment. My office is next to an OB clinic, so I get a lot of either pregnant or postpartum patients. You think that baby pushing your tailbone as they come out. So a lot of dysfunctions you'll see in that population as well. All right, then flip back over. So we're gonna assume this left side was anteriorly rotated. So, or let me do it on this side just so I don't block the camera as much. So if he were anteriorly rotated, again, I'm flexing his hip and knee. Now the textbook, you're going to see him get to here. Go to where you feel the restriction. there. I already can feel his hamstrings trying to fight me. And then I'm just going to stay here and okay, try to make your legs straight against me. Good, good. And if they overpower you, just tell him, hey, not as much, not as much. And then he relaxes. Then I'm going to take him further into that barrier. Good. And do that again for me. Perfect. And you'll do that maybe 3 to 5 times. Hold it, 7, 10 seconds. Then I'll check. Okay, it looks better. If it doesn't, then I can sometimes say, okay, maybe it's a whole pubic shear, and I'll just do a little bit of distraction. So the key is distraction, yes, what you're doing to the body, but you also need your patient to relax. So this is where I'm telling him like, oh, talking life in his case, talking, hey, Atascocita football sucks since you left and U of H is awful since you left. And then boom, I'm just applying that little distracted force to really get that leg to where I want to go. So let's say that he was posterior on this side. So posterior would be everything would just be the opposite now. So, hey, this is rotated. That PSIS looks lower. Same concept. Go to this side. Except now I'm going to extend the hip, flex the knee, and he gets a little bit better motion here. And now he's just trying to bring his knee up and extend it against me. So what he's doing now is firing that posterior chain to move it anterior to make it equal. And then you have him relax and just take him further into that barrier. Okay. And then the other ones are in flares and out flares. That's referring to the pelvis. So, hey, am I in here or out here or vice versa? You don't need any fancy tools or anything. Just take your thumb and pinky, find that pubic bone, find that ASIS, and then compare it side to side. And if you're like, oh, it's like this, great. You diagnosed an in flare or an out flare. So then what muscles do we use to fix those are going to be your abductors and adductors. So if it were an out flare, meaning he's kind of rotated out here and I want to push it back in, I'm going to use his muscles to do that. So as he's going to abduct against me as I'm resisting him, and then he abducts 3-5 seconds, go in more, he's pushing. So this is kind of what it's doing. So he's firing those muscles to try to pull that back into place. And then if it were an out flare, same thing, except now he's adducting and I'm getting him back out to pull it back out into place. So that's a quick, hip and pelvis, and then sit up and face here. And then you heard me mention a lot like thoracics. In the DO world, we call it a PTP, where there's a posterior transverse process. So I'm just feeling his thoracic spine, and right here, we're probably at T4 maybe, I can feel on this right side, he's rotated like this, meaning I did not have to push as hard to kind of get a diagnosis that that is rotated. So then same thing, you want to check, hey, when you're extended, does it get better? Not really. When he's flexed, okay, it's much more equal in flexion. So we know in the thoracic spine, if one level is rotated, it's automatically side bent the next way. So here I would say he's T4, he's flexed, rotated right, and side bent left. So that tells me everything I need to do to fix it. So if we wanted to do muscle energy for this, you're going to have him relax. I'm keeping my hand on that transverse process of T4, and then direct or indirect. For this one, we can do direct. So we said he was flexed. So we'll take him into that flex position just till I feel motion. And then we said he was rotated right. Rotated right, and then side bent left. And now he's just going back to a neutral position. Go ahead and fight me back. Good, and relax. And then we're going to just take him further into that barrier. And try again. Good, good, good. Relax. And then lie on your back. If he were, I couldn't get it to go that, I tried a couple other techniques, then that's when you can do, a high velocity, low amplitude thrust. So I'm going to kind of do a modified. So I'm getting my thenar imminence right on T4. Good. And then I'm going to have him breathe in. And when he breathes out, I'm closing that barrier. I'm not thrusting yet. Breathe in and out. And this table is not ideal for me. Breathe in. And then on the last one is when I'll come in and thrust down. Obviously, ergonomically, I'd have a table that can get me over him a little bit better just to have my mechanics. But that truly, I'm just pushing it back into place. So that's kind of the mainstay for a cervical, thoracic, and hip. I want to do a little bit on the shoulder just to give you guys a little bit of an idea. Shoulder pathology, again, 18 different muscles touch that scapula. Kind of motion is lotion at the shoulder. You know, everyone knows the sleeper stretch, and you see your baseball guys and softball girls doing, you know, their warm-ups. So pick a side. I like to just get motion. We know there's kind of when I talked about that pattern that the typical body kind of has. So you want to follow the pattern of the shoulder. So usually it's a flexion and extension, and you can do one at a time, or, you know, I combine them. So I'm flexing and then I'll kind of exaggerate it more and more. So this is really good for your adhesive capsulitis patients, which board question 2, think diabetes if they have adhesive capsulitis. All right, so I flex and extend, and then I'm going to add AB duct. Same thing, you kind of start small and then go further. All right, and then you'll repeat these with some distraction as well. And then best one, you relax, let your arm fall, is a little bit of distraction with circumduction. So go counterclockwise, get bigger and bigger, and then we'll go clockwise and get bigger and bigger. So that's it's called the Spencer technique, but I think for, you know, you guys just getting motion at the shoulder, because then you're going to get that motion at the scapula started. So this is a great maybe first thing to do before they get going on kind of their rehab and what they're looking at. All right, go ahead and sit up. Let's see, I sped through those just because each session's been a little bit different. So since you guys are almost going to have lunch, I'll just take some questions if there's anything specific pathology-wise, a body part-wise that you're confused about, or something you want to see more of or ask questions about. Yes, ma'am. Mhm. Yeah, I think, you know, it's sure. Yeah. For Zoom, it was, you know, how often with the concussion should we do this? There's not a great answer in terms of, hey, you need to come. I have not concussion. I have a 88-year-old Russian grandma sees me every week for OMT. Maybe once a month does she actually need something done, but you can tell she's had a history of back surgery. You know, it's therapeutic for her. She feels better doing it. Concussion wise, obviously in my clinic, maybe seeing them once a week. So I usually will do it every time I see them. Or if I know the athletic trainer well enough, I'll say, hey, you know, you really need to focus on their upper thoracics or neck. So from my standpoint, I'll do something with them on every week. If you guys are seeing them daily in the training room, let your stat and your symptoms kind of dictate. Because obviously doing a lot of neck motion, if their vestibular exam is all over the place, you're probably not going to want to move their head so much, because then they're just going to get dizzy and blame you anyway. And then coach is yelling and it's a shit show. So take what the body is telling you, take what your patient is telling you. Obviously, you know, college athletes, high school athletes, you may be able to kind of do more because they don't necessarily know how to explain their symptoms, but concussions, you know, you'll see in car wrecks and everything in between. But yeah, at least once a week, I tend to do it, and not everyone needs it. Any others? Yeah.
They asked if you could demonstrate a manipulation for ankle stiffness.
Yeah, so take whatever shoe off you want. So the key is kind of what I said in the beginning is ankle stiffness. What does that mean? That can mean so many different things. Now, I've examined him earlier and he has really a tight posterior chain. So before I would do any kind of manipulation, it said, hey, we got to work on this flexibility. So you could do some muscle energy of the calf and the gastroc. Remember to tell your athletes to stretch with both the legs straight and the knee bent as well. One that's commonly done in the DO world, you'll hear it called our pistol whip. And I'll show you, flip over. So depending on the pathology, whether it's a cuneiform, the cuboid, the navicular drop is something you hear a lot of, especially in people with flat feet. So probably better on this side. So let's just say he has kind of a navicular drop, meaning when I palpate his navicular and on the feet, you're not sure, is this pathology? Compare it to the healthy side. Does it feel different? Great, something's going on. That's enough for you guys to at least say, we need to investigate this. But what you want to do is try to use with manipulation of an ankle is you want to try to use the muscles and then my force to get everything back into place. So if it's, let's say, navicular that is basically posterior and kind of depress down, what I'm doing is taking my thumbs and digging. I'm pushing up on that navicular because I want it to go up and out. But then what I'm doing is I bring him up and I'm flexing here. So he's relaxed. I'm doing all the work. I'm flexing here. Now, again, his ankles are tight. So this is not where I would start. And then as I come down, because now what I'm doing is I'm elongating this interior chain. And this I would do, I'll show you in real time, but just first, as I'm whipping him down and plantar flexing him, I'm pushing in with my thumbs. So it kind of looks, you know, we go in, out. And I go real quick, and just that motion of me kind of pushing back, I'm pushing that navicular through. You can do it on the cuneiforms as well. It works for any of those kind of dorsal ankle bones. But that's the key, is listening to the body, because let's say that's what he needed. Man, I mean, as soon as I get up here, like he's fighting me here. So it's like, you got to work on that Achilles and that gastroc first. And that may take away some of your symptoms. You know, I sing it to my patients all the day, you know, hip bones connected to the knee bones, connected to the backbone. There's truth to that, especially in the DO world.
Is there a certain certification that you recommend to increase manual therapy techniques?
Yeah, I mean, obviously in the DO world, and you'll find, I think you guys have a couple DOs talking to you. Not all DOs do OMT. There's actually one woman here in Katy, that's all she does, is just has an OMT practice, and she's very good at it. In the athletic training world, you know, I don't remember all the different kind of certifications you can get, but I think there is, you know, extra training you can do in manual therapy. Orosty is really helpful. ART, I'll still do like active release therapy on patients, which I know you guys have access to. So depending, I would check, you know, between NATA and the BOC, there's probably right resources. Then if you're fortunate enough to work with a DO who does it, just get in the room with them, you know, to say, hey, can I watch you do this? And just like I mentioned earlier, like I work with Sheldon on the sideline, so I trust him, and he'll just let me know if he needs something from me, so you can build that trust to start doing things. I told the groups, don't wait to start soft tissue treatment, whether it's for a musculoskeletal injury or like your sinuses. That's only going to help the patient, help the athlete. If a physician yells at you and says you made it worse, like that's just a physician who has a stick up there, you know what. So do what you're trained to do, feel what you're comfortable with. Obviously, don't manipulate anything if you're not sure if that's, you know, the right way to go. But I know a few athletic trainers that feel comfortable with manipulation, feel comfortable with injections, and it's just building that trust with your physician so that you can get the patient what they need quicker. All good. Thanks, guys. Yep.
Thanks.
Is what you guys are eating. We did a little raffle from everybody who signed up and who's here in person. So can I have Sophia Q come up first? She was the winner of the first door prize. The second person is Isabella Perez. Yeah, a nice can bag. Yeah, you got the door prize. You got this super nice grocery bag. Sarah Sturm. There she is. Karen Wanders. No problem. Caitlin Wentz. You got a super cool foldable cartridge. No, they work. You got an awesome folder.
You're done. I've got it covered. When you're done, turn off the mic.
With just button.
Yeah, just as long as the green light's not on, it'll be on.
Good. Rory Blevins. You got a selfie light. Samantha Salazar. Dorothy Byerly. Queenie Quatch. And that's it. So tomorrow we'll have another round of door prizes. So if you didn't win today, hopefully you win tomorrow.
We're live.
All right, welcome back, everybody. My name is Elena Sofia Hyams. I am one of the outreach athletic trainers with Memorial Hermann. I will be your MC for this afternoon. Hope everybody is ready for this second round of speakers. Our first one will be Dr. Ticas. She is currently an emergency medicine physician, director of sports medicine, and assistant professor for the Department of Emergency Medicine at the University of Texas Science Center at Houston McGovern Medical School. She received a BA from the University of St. Thomas and an MBS from William Carey University. She completed residency at the University of Florida College of Medicine and fellowship at University of Arizona College of Medicine. She received her MD at the University of Texas Southwestern Medical Center. Currently certified in sports medicine and emergency medicine by the American Board of Emergency Medicine. Today, Dr. Ticas will be presenting on chest injuries and emergencies.
Okay, hi everyone. Go ahead and keep eating. I'll just keep talking. Sorry in advance, I've been a little sick, so I can't really control what's happening here. We can thank my toddler for that one. But she just gave a really great introduction, so we can kind of skip this part. But I am at the Pearland Clinic on Mondays, and outside of that, I work at both LBJ and Memorial Hermann TMC in the ER there. So we'll start with just chest trauma basics. So our chest trauma is basically our thoracic cavity is contained of three major anatomical systems. That's your airway, the lungs, and your cardiovascular system. And anytime there's any blunt or penetrating trauma to either of those spaces, it can disrupt one or multiple of those organ systems. Life-threatening chest injuries in contact and collision sports is relatively rare, but it's not impossible and does happen. So we do have to be aware of like the big bad things that can happen. When these patients present, you will very likely know what happened. You're watching the games, you're watching what's happening. So it's not like you have to start from square one. But these patients can either present as stable or unstable. When they're pretty stable, they can tell you what hurts. They're complaining of chest pain, they're complaining of shortness of breath, back pain, abdominal pain. You'll see them pass out. But when they're unstable, you don't really know what's bothering them, but you will see that they're in pretty severe respiratory distress. They will have decreased breath sounds. If they're in profound shock, that's when their pulse starts to get irregular, their blood pressure starts to drop, and that can actually lead to cardiac arrest. There's two major mechanisms of injury when we're talking about the chest. First is blunt trauma. That's most of the stuff that you'll see. It's a direct blow that's going to cause increased intrathoracic pressure. So like the pictures you see there. If it's a penetrating trauma, those are more rare, but those are pretty self-explanatory. Something's going in and out of your chest. Won't be fun. So when you first walk up to these patients, there's certain initial actions and kind of like what we call your primary survey that needs to be done. Those are your basic ABCs. So starting with A, it's your airway. Are they talking to you? The first thing, the most basic thing you can ask is, hey, what's your name? Where are you? Do they know anything? Can they say anything to you? B is breathing. Pretty self-explanatory. Are they breathing? Or do they have breath sounds? Is their breathing labored? Is it just, do they look like they're in distress? C is circulation. And that's kind of when you want hemorrhage control if they're bleeding. But with C is basically you feel for pulses. Are they present? Are they cold and clammy or do they look kind of warm and well perfused? D is, it gets a little more complicated. That's basically the disability portion. Are they moving all their extremities? Is it just to pain? Is it to voice? Are they opening their eyes? And are they even making sense or are they just grunting, making noises, or saying words that don't quite answer the questions that you're asking? E is exposure. That's basically typically not done on the field, but you'll completely expose the patient, look for wounds, blood, what's their muscle tone, and things like that. You don't really want to move on to the next one until the first one's taken care of. You can kind of combine some of them, but you really just, it's a stepwise action. So next we'll just kind of run through some of the big types of chest trauma. If you see that little danger sign, those are pretty life-threatening and you do want to identify those as quickly as possible. So first is flail chest. That's kind of like what you see in the picture. It's when 3 or more ribs in a row are fractured in at least 2 places. So it leads to a discontinuity with the rest of the ribs. So if you see here, these ribs here, it's 1, 2, 3, and they're broken in 2 different places. And it causes kind of this backward motion of your chest wall. So typically when you breathe in, your chest wall tends to expand, but that portion will push in. And so when you breathe out, when your chest wall is kind of collapsing back in normally, that flail part will push out in this backward paradoxical motion. So if you can kind of see there in the video, that's kind of what we're talking about, that uneven rise in the chest wall. So what you'll see is kind of this visible or very palpable deformity. You'll see some bruising, and then you'll feel what we call crepitus. So that's basically this crunching or crackling that you feel under the skin. So if you can think of taking a bite into a Rice Krispie treat, that sound that you hear is basically what you feel when you're touching over their chest wall. These patients will present with chest pain, shortness of breath, painful breathing, and their vital signs will be kind of funky. Their heart rate will shoot up, their respiratory rate will go up, and their O2 sat will start to go down. Diagnosing this is, it's like I said, when you see them, like you saw the chest wall, you'll kind of know that something's off. And obviously once they get to the emergency room, an x-ray is pretty evident on the x-ray too. And And the treatment options is if it's a younger person, they're pretty stable. You basically just want to pain control them, make sure they can take in those deep breaths and use this incentive spirometer. So when you use it, you put it out to your mouth, you take in a deep breath, and there's a little ball there that moves up, and they usually give them a target goal that they want them to hit. If they're unstable or in any kind of distress, that's when we go ahead and intubate the patient. But either way, all these patients will require admission to a hospital. Next will be pulmonary contusions. So these kind of go hand in hand with any sort of rib fractures, little chest. Is basically that when any trauma will cause leakage of blood and or proteins into the lung tissue. Basically, just a bruise of the lung. So once that fluid, blood, they'll go into the tissues of the lung and it'll start to interfere with gas exchange, which basically means your oxygen levels will start to plummet. This is your most common type of potentially lethal chest trauma. It's just the thing that we see most often. When you're looking at the signs and symptoms of pulmonary contusions, once they get to the more advanced stages, they'll have low oxygen saturations, but also their lips and their fingers will start to turn blue, letting you know that something's not quite right. They'll let you know that it's pretty painful to take a breath, and they're going to have lower exercise tolerance if they're not too severe and can still actually continue doing their exercises. The vital signs kind of do what the other ones have done. The respiratory rate goes up, your heart rate goes up. And when you actually take a listen to these patients, they have decreased breath sounds or a very crackling kind of noise when you're listening to them. They can present as wheezing, coughing, and coughing up blood is not uncommon in these pulmonary contusions either. The area near where they get hit can be pretty painful and tender, and that sometimes can be your only sign that something's going on. And half of these cases are actually asymptomatic when it first happens. But the more severe the injury is, the more quickly these symptoms will start to appear. The treatments for pulmonary contusions will kind of depend on the severity. A severe injury can develop very quickly. It can develop in 3 to 4 hours. But patients that have an injury but not quite as severe, it's usually within 1 to 2 days that they'll start to notice that they can't breathe as well, that they're having more pain. If it is left untreated, though, it can actually lead to rapid deterioration and death. But when you're treating them, the care is mainly supportive. It's just giving them supplemental oxygen, pain control, close monitoring. If they're very severe, they're having a lot of trouble breathing, that's when you intubate them and use supplemental oxygen like those CPAP or BiPAP machines that kind of help with that pressure to kind of expand those lungs. But either way, you want to make sure they're expanding their lungs to prevent any kind of pneumonia, which kind of has more downstream effects. Next, we'll talk about a pneumothorax. So that happens where an air leaks into the space between your lung and chest. So there you can see your chest wall, there's your lung. The air is kind of in the space where it shouldn't be, and it starts to compress that lung. So it's going to lead to a collapsed lung. Pneumothorax can actually be split into two. So it's either going to be a spontaneous pneumothorax or a traumatic pneumothorax. The traumatic pneumothorax is pretty self-explanatory. Something hits you, something penetrates you, and now you have air around your lung. The spontaneous ones are a little trickier because you're really not expecting them. A primary one is kind of a patient that is completely healthy, completely normal, has no lung disease, and they get these pneumothoraxes. You're at a higher risk if you're male, if you smoke, or if you have a family history of these pneumothoraxes. The secondary one is you have a known lung disease. So that's people that have COPD, pneumonia, asthma, Marfan's. These people form blebs on their lung that can spontaneously rupture. And that's kind of how some of these patients will present. To diagnose the pneumothorax, usually it's by physical exam. You'll listen to the patient. They'll have bilateral breath sounds, but one side will sound a little more diminished than the other side. If you look at the x-ray here, This slide it looks pretty hazy, like light grayish, fuzzy. Here you can see it's like just darker black. That means there's no lung there. Your lung is kind of down here and collapse into this little haziness down here. These patients will present with chest pain, shortness of breath, and again, the same vital signs, higher heart rate, higher respiratory rate, and decreased oxygen. These may be a little hard to diagnose on the field, but if somebody out there has a butterfly or a little portable ultrasound, you can kind of see the difference and see what you're looking at. This side is a normal lung. If you can see this bright white line here, that's kind of your lung sliding across your tissues. This little bump here is ribs. So right between your two ribs, you see lung sliding with that bright white line. And then you see bright white kind of shot downwards. So these are called comet tails. So that means everything's sliding the way it should be, and that's a normal lung. When you're looking at a pneumothorax, again, you have a bump on this side rib. That bright white line is your lung, but it's not as glittery as this side. This side looks kind of glittery and shimmery. This type, it's not. And then it also doesn't have those bright white shooting lines moving down either. So that's kind of what you're looking for when you're going to grab an ultrasound. If you let a pneumothorax kind of go untreated or it's a more severe one, it forms what we call a tension pneumothorax. So that means the air is forced into that same space between the lung and the chest wall, but there's no escape. So it just keeps causing pressure. So air is coming into this space, it's building up this pressure. So it's collapsing that lung to the point where it starts to shift everything to one side. So your heart, your aorta, your inferior, superior vena cava, everything in that middle part of your chest starts to shift to the side that's unaffected. So that all means is that any blood that's supposed to be coming out of your heart this way or back into your heart this way is diminished. So everything's compressed, blood's not returning or going away from your heart. Very, very bad. This in total can lead to circulatory collapse. This you really want to be sure you can diagnose quickly because people don't do well with it. They'll usually present with shortness of breath, chest pain, but it can even present as just cardiac arrest, like to the point where they haven't had no blood return or flow for a while and they're just in cardiac arrest. Here's the x-ray of that. So again, haziness on this side means lung is okay. Dark on this side means there's no lung. The lung is sitting right here, and it's starting to push everything to this unaffected side. To diagnose a tension pneumothorax, your physical exam will be key. You'll listen for breath sounds, and this time, instead of it just being diminished, it'll be completely absent when you listen to the affected side. So if you put a stethoscope on this side, you really won't hear anything. You'll look for tracheal deviation. So if you can see in the picture, basically a ton of the mass in the neck is shifted in this direction. This is midline, and it's all kind of coming in this side because, like I said, everything's being shifted. So everything in the neck also gets shifted as well. And because there is no blood return or flow like it should be, everything starts to get kind of backed up. And you'll look at the neck veins and you'll see that they're pretty distended. To treat these, as soon as you know which side's affected, the side that doesn't have any breath sounds, you'll go ahead and put a needle into that space I like the picture. It's basically right in the middle of your clavicle. You go 2 rib spaces down and you put a needle in there. And you can untake this. There's like a little white cap that you unhook and it leaves kind of like a little straw in there. And that's kind of how it lets the air out. That's what the most quick and efficient treatment is. Once you've gotten to that point, then you'll kind of, in the hospital later, what we do is we put a chest tube in. It kind of goes on the side, 4th rib space right underneath like your armpit. And you'll put a big tube that causes continuous draining of that space. So once it's drained out, you'll kind of re-expand the lung and things will start to settle down. Next, we'll talk about a hemothorax. So that's basically, instead of air, now we have blood. Blood will start to collect in the area between the lungs and the chest wall. It can be from either blunt or penetrating trauma, such as rib fractures. If you look at the x-ray at this time, when we're talking about air around your lung, it was pretty dark. But here, when you start seeing blood on an x-ray, it starts to become bright, bright white. Patients complain of shortness of breath, chest pain, just like all your other ones, but they can also be pretty asymptomatic. On your physical exam, when you listen to your breath sounds, on the side that has the blood, the breath sounds will be diminished. If you actually tap on their chest, if you kind of tap on your chest, it's kind of like a hollow sound. But when you tap on something that has blood filled up there, it'll be a much duller sound. And it'll be pretty obvious if you tap hard enough. Again, your respiratory rate, heart rate, oxygen status will go down. It can also be normal depending on the amount of blood that's there. You can diagnose these on the field with ultrasound. It is a little harder than the pneumothorax, but it'll be like a bright white that you see. And just like a pneumothorax, the treatment will typically consist of putting in one of those larger test tubes because you'll need to drain all that blood out. When you start talking about trauma to the chest, we also have to think about cardiac contusions. This typically occurs when you're struck in the anterior aspect of your chest near your heart. And these are closely associated with sternal fractures. We see a lot of these in MVCs, but they can also occur a lot with just any kind of direct trauma to the area. They can be without any specific complaints. You have to be, this has to be pretty high on what you're thinking for you to kind of think of it, because it's not very common, but it can be detrimental. And when you look at the patient, their exam can be pretty normal, that sometimes they'll just have very mild tenderness right over that sternal region. These patients, you'll want to observe them for 24 hours on telemetry because they are a risk of developing arrhythmias and shock. Closely with the contusions is cardiac tamponade. These life-threatening conditions occur when there's fluid building up around your heart. So if you look at the picture, everybody has this pericardial sac that sits around your heart just kind of as a protective measure of it. This is kind of like a sliced version to show you that that's your pericardial sac pretty closely kind of touching the wall of your heart. So when something happens, any kind of injury that's going to cause increased buildup around your heart, that means your heart cannot expand and contract the way it needs to. There's too much pressure around that area. So these people will present with chest pain, shortness of breath, but because now you're dealing with the heart, the pumping, the return of blood, they can present very altered, confused, and they can be in circulatory shock and decompensation. What you'll look for on your exam is what is known as Beck's triad. One is low blood pressure. Again, no blood flowing in the direction they need to be going. Your blood pressure is going to drop because of the change in the flow. Same thing, you're going to have distension of the neck veins. And because now there is extra fluid surrounding your heart, when you take a listen to it, your heart's going to sound like it's kind of very far away from you. When you're looking at the ultrasound, when you're looking at the heart, where you put your probe makes your heart kind of look upside down and a little backwards. So this is just kind of how you see it. You'll see your ventricles down here or up here, and then your atria here. So like I said, the picture's just upside down on an ultrasound. So this is a normal heart. Again, ventricles, atrium, your valves are flapping. Everything's contracting, relaxing, just in synchrony. The bright white around it is that pericardial sac that we were talking about. Now, when we're talking about fluid in that sac, the bright white's the sac. Now you have darkness surrounding your heart. So that's all the fluid that's building up around your heart. So your heart just kind of flaps around in this pool of fluid. It's not as organized. You see the valves on this right here are kind of flapping oddly, not as in control. And the heart just isn't pumping as effectively as it should be. So to treat these very quickly in the ER, what we'll do is a pericardiocentesis. Is we'll put our ultrasound probe on the area of the heart to get that view. And basically, we're going to get this big giant needle, follow it right in with our ultrasound, right into that fluid, and just withdraw fluid out. It doesn't take a lot. Usually it's 15 to 20 cc's that we can remove and have some improvement in their vital signs. But there's sometimes that the trauma is so severe that's just going to cause continuous leakage of fluid into that sac. So they'll actually need surgery to go in, cut that sac, and just allow it to keep draining. That's just kind of a small picture of them breaking open that sac, and it'll just kind of leak, have that fluid leak out. Finally, what's kind of become more prominent now recently is commotio cordis. So that is a sudden blunt impact to the chest causing sudden death in the absence of any known cardiac damage. So these risk factors are getting hit with a small dense object such as a hockey puck, lacrosse ball, baseball, fist, anything small and dense, something that's a direct blow to the area. Obviously, if you have a thinner wall, a thinner chest wall, you're more likely to be affected by this. But the mean age is typically 15 and is more likely in males. So to trigger this, you have to hit the heart at a certain spot right in your cardiac cycle. So this is just the typical cardiac cycle that you'll see on an EKG. And for it to get hit and trigger commotio cordis, you have to hit it right when your T is about to go up. Basically, that's when your ventricles have just contracted and they're on the verge of relaxing, and that's when you get hit. So if you get hit, so you'll see normal pump, normal pump, normal pump, you'll get hit, and then you'll go into ventricular fibrillation. That's just a rhythm that's just not compatible with life. Basically, your normal heart will pump these electrical pulses normally, rhythmically, and you'll get a nice, pretty little rhythm. But once this happens, when you get hit, basically your ventricles down at the bottom will start to quiver and shake, so they're not pumping at all. So there's actually no blood pumping whatsoever during this time. So as soon as this happens, there's going to be sudden collapse, loss of consciousness, and it needs to, you need to be able to recognize this pretty quickly. Patients will be pulseless. As soon as you have no rhythm, you will have a cardiac arrest. And so therefore, if you go to the athlete, feel a pulse, no pulse, you have to start CPR as soon as possible. But this requires prompt defibrillation with an AED or something to restore that normal cardiac rhythm and get the blood pumping again. So finally, in conclusion, although pretty rare in athletics, life-threatening chest injuries can and do occur. So we need to be aware of them. The initial care and determination is the determination of the mechanism of injury, evaluation of the patient, do your ABCs, and how conscious or not are they. You can be aware of the signs and symptoms of serious chest injuries, like looking for your physical exam signs, bruising, distension, and be prepared just by having an AED present and know how to activate your emergency medical response system. That's it for me. There we go. Y'all have any questions? That was a lot of information.
All right. Next up, we have Emily Surgener. She is currently a physical therapist at Memorial Hermann Rocket Sports Medicine Institute. She has received her BS from the University of Florida and doctorate of physical therapy from Duke University School of Medicine. She is certified strength and conditioning specialist by the National Strength and Conditioning Association and is a committee member of the American Academy of Sports Physical Therapy. She is actively involved in post-operative knee research with a specific interest in the female soccer athlete. She is a team physical therapist with Houston Christian University and Stratford High School. Today, Emily will be presenting on post-operative knee considerations in the athletic training room.
Awesome. Thank you, Alina Sophia, for that intro. Like she said, my name is Emily. Good afternoon. I'm going to be talking about post-operative knee considerations specific to the athletic training room. This is a population that's near and dear to my heart, and I'm grateful for the opportunity to spend the next few minutes discussing knees. So, what I'd really like to spend the most time on is troubleshooting some common pitfalls that occur during rehab for a post-op knee. For simplicity's sake, we'll discuss it from the lens of an ACL reconstruction, but these concepts can be applied to other surgeries as well. First, I want to briefly review that timeline to set the stage for any who may be unfamiliar with this rehab. But disclaimer, as you all know, their general guidelines and protocols vary by surgeon. Just because an athlete meets a certain time point as well does not mean they match it functionally. And really what today is about is addressing that functional piece to ensure we're setting these athletes up for success down the line. Sometimes I think post-ops get a little fuzzy in the training room, especially if things don't go exactly according to plan. So my goal is to leave you with some tangible problem-solving skills and treatments to deepen your toolbox when that inevitably happens. So it's no secret that knee injuries and surgeries are very prevalent in just about any athletic training room you step into. But here are a couple stats specific to the high school and collegiate population that many of us serve that resonated with me. All right, so your athlete has surgery. They show up, suddenly they're in phase 1. This is the max protection phase. We're working to get full extension and quad activation, all the while educating the athlete on why we need that so badly and what it means. They're fresh out of surgery and ideally starting rehab the next day, although this can depend a little bit on the surgeon. Quad is king, and accessing and keeping terminal knee extension is the most important thing you can do here. Next, we get out of the acute time frame and enter arguably my favorite phase, which is phase 2. We're hopefully getting off the table to work on functional strength, starting out with double leg, moving to split, and then to single leg strengthening. We're teaching technique for all the major compound lifts and working towards jogging. Before you know it, the athlete's running on their own and could be back with their strength coach for workouts or with their team for lift. Rehab time is spent teaching plyometric technique and training power. Phase 4, you're starting single leg hopping if you haven't already and working on the fun stuff, sprinting and cutting at very shallow ranges. Phase 5, we've almost made it, and the athlete is working back in with their team on non-contact drills at practice. Their hamstring to quad ratio is exactly where you'd want them to be at 60%, and they're hitting over 90% LSI on all their strength too. Hop testing, agility testing, all also looks amazing, and they're confident, but not too confident that their knee is gonna hold up and feel better than ever going back to playing. But rarely do we ever see it play out so perfectly without any hiccups, right? So what do we do when things don't go exactly according to plan? While there are quite a few complications you can encounter, these are a few of the main ones that I wanted to discuss today from a PT lens. They warrant dedicated clinical reasoning and time to address prior to moving on to later phases, but I can assure you it's time well spent. Leave one room tidy before moving to the next, so to speak, and you'll find it pays off in the long run. Without taking care of these early on, your athletes won't have the foundation they require to be successful in late stage rehab, and you might see them back again for another injury. While we're talking about some of those roadblocks, typically they're going to pop up during the early part of rehab up until 12 weeks. but you could certainly see athletes struggle with these beyond that 3-month mark, depending on how fast you're going and any other concomitant procedures that they had. But I typically find that they start to show inklings of them early on in the rehab. First and foremost, you might encounter difficulty getting extension. There are quite a few things here on the list, but don't get too caught up in it. We'll break it up in a second into 2 categories based on where they feel that limitation. Awesome. So before you can proceed, we must check and recheck motion. So I like to passively move them into full extension with overpressure and ask them where they feel it. Treat based on that, and then most importantly, recheck, right? Check, intervene, repeat. Check, intervene, recheck, and repeat until you figured it out. This applies for flexion as well. Super important to have an asterisk sign to know if you're on the right path. Takes 20 seconds and will ensure that you aren't wasting your time and that you're actually doing something that is helping. So now to break it up, when we talk about lacking extension, I like to organize it into 2 camps, those that lack it due to anterior pain or symptoms and those that lack due to feeling something more posteriorly. Say you check extension, they feel it somewhere in the back. This is an example flow of how you might go about addressing the posterior anatomy that are contributing to symptoms and objective findings. Heel prop, strap stretch, I feel like typical go-tos, see those pretty frequently in the training room. Hamstring, calf, like pretty common to default to stretching those. But sometimes we need to go a little bit deeper. Maybe the stretch didn't quite do it and we dive in with some soft tissue. Maybe we dry needle, maybe we have to put some heat on it to make the stretch more effective. Diving a little bit more laterally, maybe it's actually the fib head, needs a little bit of MOBs. Prone hang, nerve glides, lots of things that could be contributing to that lack of in-range extension and lots of things to investigate. So like I said, kind of clear out low-hanging fruit. I'm typically going to start them here in a heel prop and barring any posterior lateral corner or PCL repair, allow those creep principles to work and then stretch out hamstring and calf. Maybe after that, the athlete's still having posterior pain. I think it's still maybe muscular or capsular based. So put them in prone, cue them to feel the table flush against their leg, and help them provide them an external cue out of the typical long sitting position. So I actually really love to get people in prone once they can tolerate it because it's going to stretch out the front of the hip as well, which I feel like can get kind of angry when you're in long sitting for so long doing post-op rehab. Adding heat makes stretching the muscle tissue more effective, or you could add a weight as well. Ensure that the hamstrings are relaxed here. I feel like that's a big pitfall even within this intervention itself, is sometimes you put athletes on the table and you get this little like shake. The hamstrings are just guarding and honestly it could make it worse. So I like to gradually increase the distance they hang off, start with just ankles off, then shins, then right below the knee. You could also throw biofeedback on the hamstrings and Q0 activation to ensure that they're really shutting off. If these don't work, circle back to some of the other things on the list before. So switching gears, now we lack it anteriorly. So you check extension, they feel it in the front. Here's where my mind goes as to what might be limiting that. Patellar hypomobility, fat pad, or anterior interval can get a little sticky and irritated, especially with those portals. Scar hypomobility, more prominent. I would say around like 3-4 and beyond as the scar lays down, and then still having some swelling in the joint as well. Typically, resorting to some manual techniques here, making sure the patella is moving, especially superiorly. Massaging the portal sites, especially that medial one, tends to scar a little bit more. Dry needling works well for some of those athletes that really hate if you're like just sitting there for a few minutes digging into their portals. You just pop them in and they can sit there for a few minutes. Sometimes I'll also do some soft tissue to the IT band or a lateral retinaculum release on the patella to kind of get under its lateral border, help with tracking. And then I also have found it really nice, especially as we see more and more LETs. Sometimes that lateral part of the knee and thigh gets a little angry. So these arrows just kind of point to some of those common sites of regions where we're maybe employing some manual therapy. And just to give you guys a little video of that superior patellar glide, here the patient also has biofeedback on to show her how much she is activating her quad. And the therapist is applying a superior glide to assist her into that full terminal knee extension with an awesome heel pop. Okay, switching gears a little bit to flexion. There are a few things that can limit flexion. I'd say it's a little potentially less intimidating than the extension, but like before, don't forget to check it. Ask them where they feel it so you know which direction to go in, intervene, and then recheck. So depending on where they feel it, these are a few things that you might try. Some are pretty basic, but if heel slides aren't doing it and they're not working, don't be afraid to switch it up. So it's kind of a balance of we need to do the basics, we need to have the foundational things, but if you're trying the same thing over and over again and you're still not getting past 90, then we probably need to look at it from a different avenue. There are a lot of ways to get knee flexion, and sometimes switching the locus of control or gravity's pull can really help them make gains. Ideally, you're able to get them to a point where they feel it in the front of their knee, the restriction, if you will. And then this is when you can make meaningful change in the joint. So have them hold it there for 3 to 4 minutes, follow it up with flexion-based strengthening to reinforce the gains made and improve carryover between sessions. All right, everyone's favorite, graft site pain. One of the most frustrating and finicky things to deal with is an angry tendon. When we appreciate the iatrogenic damage that occurs during the graft harvest and surgery, as well as the relative increase in load that the rehab process presents, and some more than others, especially if they're really keen on doing stuff outside of the training room and PT, and they're going to 2 other coaches and all that stuff, then we can appreciate how these patients might be at risk for some tendon pain and a bit of an overload. Proactively, I like to include isometric holds early on to build tendon resilience and target time under tension before I load them up with weight concentrically. But if and when you do find yourself managing an angry tendon, here are a few ways you can load it to calm it down. Ionto, ice, and anti-inflammatories are fine if you're trying to manage symptoms. Maybe in the short term, they're trying to play through it, but at some point, they're going to need this type of load to prevent it from becoming a chronic tendinopathy where we would start seeing those degenerative cellular changes. Okay, awesome. So wall sits on your left-hand side. Pretty simple. They can do it wherever. It's intuitive. They're right there. Do you know how to do a wall sit? Most likely. I like to actually keep them a little bit more shallow so they feel in their quad more. The middle one, I think is a little bit better for those quad tendons versus the patellar tendon graft site pain. Just make sure you're using a strap that doesn't actually stretch so that they're getting that isometric resistance. And then on the right-hand side, a little bit more aggressive. Maybe it's a little bit, you do that down the road a little bit, or you've already included it before they have tendon pain. They're feeling it in their quad. They're able to get that interior tibial translation that we're looking for and we know is necessary to really get the quad going. Commonly used for patellar tendon pain here, kicking into a band off the side of a bed. Anecdotally, I love to put the towel under. It's not evidence-based per se, but I feel like it helps them like activate and feel their quad a little bit more than this kind of like awkward in between hanging off the table where it's really more like maybe like 70 degrees of flexion instead of closer to 90. So it opens up your wheelhouse a little bit too in terms of the ranges of flexion that you can target with this. So I would start at an angle of knee flexion that they have very minimal or like no pain at that range when they kick into the band, and then change it to work into more provocative ranges over time. I like to start at about 10 to 20 second holds on and off and build up to that 5 times 45 seconds if you still need, per the Jill Cook protocol, for more chronically irritable tendon issues. All right. Quad activation. Need it, gotta have it, get it early and keep it. Why do we see such difficulty with it following surgery? A few things, right? They're in pain, they're on medications, they're swelling, no one's having a good time, but also there's arthrogenic muscle inhibition. So I explain it as a blockage in communication, this idea of like, there's the kind of a block from the pathway that your spine and the nervous system is trying to communicate with the muscles. And so it's not like you lost all your muscle mass in one day or overnight, right? But rather the communication from the brain to that muscle isn't working. Picture trying to get around Houston at rush hour. The traffic will clear, but we have to continue trying to drive in the meantime, and it's really tough to do so. High reps and frequency are key here. Find an exercise that you can get them to feel their quad. Don't be afraid of open chain, but rather use it intentionally so. It is the only thing that will isolate the quad, and it's necessary, but use a strap or manual assist as needed until they're able to tolerate it independently for the tendon's sake. So activation doesn't equal strength, right? But we got to have activation to get strength later. Typically, I see in a lot of training rooms people starting with NMES and STIM, and that's a pretty historical way to start. And I think that's a fair place to start. But once they can really get any sort of quad activation through that muscle and they can feel it, would highly suggest doing biofeedback. And so that way they can get the feedback and they're activating their quad on their own versus having the electrical stimulation do it for them. We're moving into quad sets, strap assist, putting them in a heel prop position, then having them squeeze their quad to show them what that hyperextension or their full extension is like. And then straight leg raises, short arc quads, all the things that we know. Prone TKEs also are a good one. And I think that those can be really helpful for people that have problems co-contracting in terms of hamstring and quad. Again, also another way to get them prone and kind of work the quad in a way that the hip flexor or the hip is in relative extension or a relatively neutral position compared to that long sitting position. Okay, like I said, there are many ways to target the quad. Some of my favorite are biofeedback and blood flow restriction training. So on the left here is a video of one of our patients. She's doing the biofeedback. She was having some problems the other day with co-contracting a little bit. So we put the sensors on her quad. And then also there's two underneath on the hamstring that you can't see quite as much. In the video there, the left channel that's like white and red is the hamstring. And we're cueing her to keep it close to 0 or in the red. And then on the right side, trying to get all the way up in the green is her quad. So I love this really awesome way to try to show them like what each of those things feel like. BFR is, I think, invaluable for athletes, right? It makes you feel like you're working hard, but it's also just an amazing tool in the training room, especially for our athletes that are non-weight bearing for a while due to those meniscus procedures or osteotomies. While I don't see biofeedback in the training rooms quite as much, I would encourage you to look into it if your budget allows. You can use it to test side-to-side surface EMG as well for the quadricep, which we'd hope to be equal around 12 weeks. And so just another kind of way to get a really quick objective test, takes a couple minutes or so, and is something that those athletes can tangibly see and feel and get that immediate feedback on if they're actually using their quad or not. If they can't access it, they can't strengthen it. So making sure they're able to activate it is huge. Last thing I'll say about this for the BFR, anecdotally, I find it's actually helpful for tendon pain too, whether that's due to the distraction of the pain from the lack of blood flow or because it's a submaximal load. Not sure, but definitely works well. And again, I think it's just a must-have for athletes. And I think these range a bit more in terms of pricing, and so maybe they're a little bit easier to get access to. All right. So not all leg raises are created equal, right? It is called a straight leg raise. We would like it to be straight when we do it, but you got to start somewhere. I think something is better than nothing. And I think I've changed my mind on that a little bit in practice, but I think it's at least helpful for them to get any sort of lift so they can feel a little bit of what it's like to lift their leg off. And then also I think it's just like a mental boost of like, hey, I'm moving my leg again. Sometimes I'll have them start in like more so 90 degrees of hip flexion and work at a more shallow range kind of up top because it's a bit gravity minimized. It's a lot easier than starting flat on the table. That initial lift off is really hard, as we know, to get, as well as that like last part of the eccentric control down to the table. Zooming out a little bit, I want to emphasize that despite surgical limitations, there's always something that these athletes can be doing to get better. So they can train upper body, they can train most static core things early, and I'd suggest getting a ball in their hands as well as soon as possible, even if it's for something unrelated to their rehab. Adding biofeedback and BFR can be useful when addressing some of the pitfalls that we discussed earlier, but they're also invaluable because they foster athlete engagement. They encourage them to take ownership of their rehab, and I would encourage you to support that, cheer them on, encourage community amongst the athletes in the training room, have them compete in straight leg raises or plank holds, right? They love to compete. They're not able to compete right now, so let's do our best in the training room. Next, I want to appreciate that this injury is life-changing physically, but also mentally. And it really varies amongst athletes. You could take two people that tear their ACL, maybe they're twins, maybe they're as close as they can possibly be, and they might have really different experiences. So just can't say enough about the mental implications as well, especially in our younger populations who don't know any different. And then this may be the first true bit of adversity that they've had to deal with in their life. So current literature found that adolescent athletes who underwent knee injury reported lower health-related quality of life. All the more reason to check in with them and administer the ACL RSI serially to proactively identify needs for referral before it's time to return to sport. All right, and perhaps the most understated piece, communication. Without it, none of this works. So get in touch with your rehab team, get in touch with your medical team, your surgeons, your PTs, your nurses, athletic trainers, right? Everyone works together. It's really helpful to discern how the training room time is going to be best spent. Every training room has different resources. Every PT clinic has different resources. They might have 20 minutes in the athletic training room at the end of school and then go to PT for an hour or an hour and a half. So get with that team and make a plan early to figure out how we can best spend the time in the training room to complement their formal rehab. Or if that is all the rehab they're getting, then that's a whole other challenge in itself. Talk with the strength coaches, like how can they offload you as athletic trainers to kind of like take some of those strength pieces and make sure that we're working as a team to optimize success for this patient population. All right, just want to say thanks to Steve Higbee, Kevin Maloney, and all the patients who consented to have their images utilized. These are my references. And thanks for your time today. Here's my contact info. Would love to connect with any of you guys that are interested in talking about this more. And have a good rest of the afternoon. Yeah, what's up?
When it comes to like rehab modalities, are there certain things you only want to do in one phase, like maybe only ice in one phase or don't use it for the rest of the phases, or does it just depend on the patient, or can you use all of them throughout the whole treatment process?
Yeah, that's a great question. So I think with ice specifically, I definitely tend to use it a little bit earlier, but maybe you're using it pretty regularly, like in the first week or so. And some of the surgeons that we work with will actually make sure that they have some sort of ice setup as home at home as well. And so they're using that for the first couple weeks. And then I find it to be useful after a really hard workout when they're working to get their strength back. So maybe in those first 3 months or so. I think, if an athlete feels like it's going to change their life, then go for it. I don't think you're going to hurt anything. I would say all in all, it can be variable, but mostly in the early timeframes for that or anytime there's an acute injury. Thank you, everybody.
Wait. Nope.
Okay, next up, we have Mr. Tom Woods. He is the head athletic trainer at Decaney High School. He received his BS from Bridgewater State University, his MS from Indiana State University, and his master's education from the University of Houston. He is a licensed and certified athletic trainer who's been the past president of SWATA and GHATS. He has served 14 years of service to the NATA Research and Education Foundation Board of Directors, has been the SWATA Hall of Fame and GHATS Hall of Honor. He is the recipient of many national, state, district, and local awards for service to the sports medicine community. He's a present member of the SWATA Clinical Program Committee, the NATA MDAT Committee, and the ATLAS Ambassador for the Corey Stringer Institute. Today, Mr. Woods presents on emergency preparedness.
Thank you. Good afternoon. So our conversation today is going to be even a little more focused. We're going to go with cardiac emergency preparedness. We're going to focus on cardiac emergencies, and we want to look at a systematic approach with a focus on the secondary school setting. I don't have any conflicts to declare, and any opinions expressed on my own don't reflect those of those committees or my employer. I do want to take this opportunity to thank Project Adam coordinator Sarah Theroff at Cook Children's Heart Center, Brittany Hainsworth, and Carol Hildreth at Texas Children's Hospital for sharing a lot of important information with me as I prepared this presentation. So what do we want to do today? I want to contrast both the incidence and the significance of cardiac emergencies with other causes of sudden death in young athletes. Describe the strategies used to assess and to improve cardiac emergency preparedness in the targeted secondary school settings. I want to cite some professional and some legal entities that impact cardiac emergency preparedness and discuss the benefits of implementing components of Project Adam into the athletic programs. I'm not going to stay up here and say that I'm the sage on the stage, that I have all the answers when it comes to cardiac emergencies, nor will I say that I have every single thing implemented that we're going to discuss today. But what I will say is this, is that my associate and I are working very hard to make our programs the best that we can possibly be. And when that comes to student safety, that is the arching goal that we have there. Just like you're here to make your programs better so that you can make your athletes safe. Everybody knows the scenario, right? Damar Hamlin sustains a commotio cordis in an NFL game, and two medical teams come out and they all coordinate. They do an outstanding job. Send out the team as they come out. And it was a win-win-win. It was certainly a win for Damar Hamlin. They saved his life. It was a win for the NFL because it showed what the emergency preparedness and what they had in place was about. And certainly it was a win for the athletic training profession. But for those of us that work with kids for a living, and particularly my colleagues in the secondary school setting, it should also set off some triggers that go along with that. Who is our team, and what will our medical response look like? So when you're in the NFL stadium and you've got all of these folks that are basically focused on what's going on into the field, how does the scenario change when it's a Thursday afternoon? You've got kids that are working out in other fields and you're trying to prepare 2 or 3 football teams to go off for games. And all of a sudden a couple kids come in and say, Janie got hit in the chest with a softball and she's not moving. What's your response going to look like? And how does that change from what Damar Hamlin's situation was? So when you look at the medical resources of the NFL versus those of most secondary schools, you got to ask yourself, all right, how do we even up the playing field? Because to me, the stakes are just as high, all right? Of all the services that we perform in the secondary school setting, I will argue that emergency care is the most visible and potentially impactful. I'm rather partial to my athletes. I feel like our kids deserve the same fighting chance that NFL players have. And I'm not trying to rain on anybody's parade, but just like you, our kids are important. Keep in mind that we can do a lot of different things. We've had some great presentations on rehabilitation, we'll have on nutrition, a variety of different things, counseling. When it comes to a true crisis, a true medical emergency, there are no do-overs. Rehabilitation's not come along well? Okay, we'll try a different tact. Hey, I really feel like I'm anxious about this. Hey, let's get you some counseling. But when it comes to a true crisis, particularly if we're talking about a cardiac crisis, there are no do-overs. Either you're prepared and you act effectively, or you aren't and you don't. And the same entities that were applauding the situation with Mr. Hamlin, not going to be as kind to us in our situation if the results aren't as positive. How many people, show of hands, are familiar with the hashtag Safer Sidelines? I see a few folks out there. Sure, thank you. Stephanie CAQSM is an investigative reporter and with the Courier Journal. And she did some research on what's going on with youth sports and she includes the high school setting in there, and came up with some very alarming findings. I'll read just one of those on there. Youth sports is a multi-billion-dollar industry, eclipsing even the NFL, okay? And yet you look at how many NFL players we've lost, direct fatalities, versus how many high school players we've lost fatalities while participating in sports. And so don't think that the youth sports is a huge industry. Just go take a look at any of your ball fields on an evening, or you go stay at the Holiday Inn and there's always going to be a competitive team there. All of the things that are going on, there's a lot of money that changes hands on there. And yet you ask the question, how much of that, even in the school setting, how much of that is being spent on safety procedures? And it's certainly a question that you want to ask. I would argue to you here that when a true emergency arises in secondary school athletics, the whole team is what you have in place 30 seconds before that kid drops. And the outcome certainly can depend on that. One last point on the safer sidelines. Again, show of hands, how many in the secondary school setting here? Lots and lots, okay? How many drills you have every month, right? We drill for weather conditions. We have, of course, the perfunctory fire drills. We have the active shooter and lockdown. Think about this, all right? In the last 10 years, no student has died from a fire at school, not a one. And yet in the last 10 years, we've lost over 200 students playing high school sports. How many drills have we had relative to secondary school safety? So the stakes been raised, all right? Social media influence. We had a young lady in a soccer game that collapsed on us here this past year. And I'll guarantee you there were already things on social media before ESD 11 ever left the field, all right? You know there's always somebody that's filming what's going on and the reports that'll go out right from that. And there's someone that's judging what we're doing out there. And a much higher expectation of care. Parents now feel like, hey, they saved Damar Hamlin, you can save my child as well. Don't believe that it's a litigious society we have right now. Take a drive down I-45 South and see all of the banners and billboards that are out there for lawyer services. We push, you win. You know where I'm coming from there. What are they going to look at in the situation? What are the qualifications of the people involved? What's the preparedness of the organization? Our conversation today. What actions were taken on there? I would argue that preparation not only saves lives, but it saves careers as well. And we are well positioned to be part of the solution on that. All right, that's great, Woodsy. So why the focus on cardiac care? Well, it's the #1 killer of young athletes. Early in my career, I had two nightmares as an AT that I hope would never happen. One was quadriplegia of an athlete from football, and the other was one of my kids expiring because they got hit in the throat with a baseball. Well, as time has come along, come to realize that the odds of those things weren't so great, but the odds of having something happen because of sudden cardiac arrest were a whole lot higher. Plus the insidious nature of it. Oftentimes the first sign of a cardiac issue is what? When they drop on you, right? So along with that, considering those same victims can show signs such as agonal breaths or seizures that can throw people off and delay the care. The clock is ticking from there. Also, when you talk about cardiac emergencies, you're talking about something that's time and equipment critical, all right? 7 to 10% decline in survivability for every minute that there's a CPR and AED delay. So that definitely rises to the surface on there. Coming right out of the Corey Stringer Institute, they talk about the top 4, right? So heart, head, heat, hemoglobin. Cardiac conditions comes right to the top here. Yeah, Woodsy, cardiac emergencies. We have an AED. All right. Well, when they first come out, I actually remember when portable defibrillators actually first came on the market. Yeah, and I kind of had that idea too. Yeah, we've got an AED now. We're good on that. But what happens though is that it's delusional in the mindset, because that comes under the idea that we are going to be the ones that witness what happens, and we're going to be the ones that are right there at that time. What's the reality? We're going to get called to come out there, and there are going to be others that are going to be the first responders out there as well. So we got to create a team, and we've got to have a situation where we make it easy to save that life. All right, so yeah, we have an AED. Do the staff and students know where it's located? There was one situation where a youngster expired. They went inside to get the AED, not knowing that there was another one basically 200 feet away from them. Do those initial rescuers even know how to use it? Somebody can be very intimidated by an AED. Is it accessible, or is it locked behind a door somewhere? Something that you have to come to grips with, particularly if outdoor security is a point here. Are there accessories available, such as shears? That young lady, we cut everything right off of it. We didn't mess around. Razor, masks. Remember, every one of us here is certified to a BLS level. What does that call for? Resuscitation masks or BVM, right? Narcan. We've had 2 situations this year, not in athletics, but that doesn't mean that that couldn't bleed over, that our nurses had to administer Narcan, all right? Possibility that one of our cardiac situations can come about by opioids with our athletics, with our athletes? Sure, that's absolutely. I'm going to make this statement. Is it fully operational? And if in that situation, who maintains that equipment? Is it close to the incident? We'll talk about the 3-minute rule, the American Heart Association AED program recommendation. 3 minutes from the time that you witness the drop to collapse until there's an AED on the patient. Will the rescuers even get to the EAP or the SERP, or they're going to wait? They're going to call you and wait for you to get there. That's not unfeasible, and I've seen that happen before. Will they even perform as needed? Can the rescuers direct EMS to the scene? How many people here in the high school setting have PRN athletic trainers come to their site? Do you share with them what your emergency action plan is? Do they know where to bring those ambulances in? All right. Do they know where the AEDs are? Have something prepared for them when they get there. It brings us around to what's going on right now, hot off the presses, that cardiac safety in the secondary schools has now become a boilerplate topic, and there have been Senate bills here in Texas that have addressed that. Senate Bill 1177 and its sister bill 865. Basically, this came about because there was an athlete in one of the HISD schools that collapsed and died, and there were some questions regarding the functionality of the AED. I'm not an attorney. I don't know all of the specifics of the case. That's outside of me. But I do know that this was one of the things that was brought up as a result of bringing these bills forward in here. It focuses on maintenance of AEDs in schools, and it focuses on training in AED CPR. So if you're an AT in a secondary school, you really need to kind of pay attention to what's going on here. Now, I know it's a busy slide. My apologies on here. But first and foremost, as far as making sure that your AED is functional and that everything is as it should be. In some ways, they have taken it to a higher authority. Now, when your jurisdictional fire marshals come out and they do their safety inspections, part of that safety inspection is you have to provide them a list of all AEDs on campus, and they're going to check those AEDs both to make sure that the pads are functioning, that the batteries are within date, and that the unit is operating. And don't forget that these fire marshals have the opportunity to write a citation, not something that would make your building principal very happy. So they're bringing this to another supervisory level on there. All right. Along with that, you can no longer just check off tags and say, yeah, we've checked it, it's done. There must be written documentation of the inspections that have been done, and there must be someone who will take these and actually organize and file them so that they can be pulled at any given time on there. So, and this legislation, it's passed both chambers of the House, and so it's ready for the governor to sign, and this is going to take place on September 1. So from here, information to take with you is you want to establish who is responsible for maintaining the AEDs in your program. Hitting into some Texas law, basically mandating AEDs, got to have them at UIL events. One person, at least one employee has to be trained in AED CPR anytime a substantial number of students is on campus. That's, describe what substantial number is, but certainly that's any athletic event out there. Basically, just instruction in CPR, SERPs, and we'll get more into SERPs on there, but you must have a written plan to utilize your AED in the event of a cardiac emergency. From there, filtering down to the UIL, want to go to the third point. A campus AED must be readily available to any UIL activity, all right, and any activity that is off campus as well. So readily, define what readily means on there. Oh yeah, we have an AED. It's down at the front of the building and our track meet is back over there, okay? Does that come under readily? All right. Remember that your ATSAs, your student aides, are now part of that legally. You must train them in CPR AED because they are now considered part of the healthcare team. Campus AED is readily available, and if you have multiple events, then a determination has to be made as to where that AED will be. Your school districts are required now to develop procedures, including the appropriate response time for CPR, use of the AED, and along with that, they're recommending that the American Heart Association guidelines come in place, determining where you have your AEDs on campus. Schools have to conduct a regular safety drill. We have a whole packet of that at Spring ISD, but that's something that you want to talk to your safety people about. You heard us talk about SERP, Cardiac Emergency Response Plans. It's different from an EAP, all right? An emergency action plan is venue specific for all emergencies, right? Whereas as opposed to policies, procedures, and protocols, this is what comes under there. If we have a cardiac emergency, then these are what needs to be done. This is what needs to be done. Project Adam has an incredible resource on SERP templates. And so it's simply, if you take time and go onto that website, you'll find something that will plug into your system very easily. All right, something else legislative. You need to know about the HEARTS Act and the state level policies. The HEARTS Act was signed into law 2024, and basically what it does, this is at the federal level. It directs Health and Human Services to award grants to public elementary and secondary schools that have, and here's the point on this, that have partnered with a nonprofit healthcare organization to help get AEDs, develop SERPs. In other words, to bring your cardiac responsiveness up a level. Let me segue now into Project Adam. Project Adam was named after Adam Lamell. He was a 17-year-old athlete that died due to sudden cardiac arrest during a basketball game. Adam meaning automatic defibrillators in Adam's memory. It started off as a very small group and now has 44 affiliates in 32 states, 3 of whom are in Texas. All right. And it was launched basically to look at youth programs, schools, community sites to become heart safe. So their mission basically educates school nurses, coaches, athletic trainers about sudden cardiac death and to offer free resources to help in emergency cardiac preparedness. All right. So they spearhead the Heart Safe School initiatives. But if you go onto the website, you'll see they have some phenomenal resources, everything broken down to make it so easy to increase your cardiac safety of your institution. Along with that, they have programs that bring community recognition because of your commitment to youth sports safety. Anybody from Pearland ISD? All right. Alvin ISD. All right, well, good deal. Congratulations on being heart safe school districts. Well done. All right, so what are the components of being heart safe? Oh, there's got 14 things up there. A little concerned. Not really. Actually, these can all be put together and they can be done systematically. What you want to do, you're going to audit your program and you're going to utilize the Texas statutes, like what we just mentioned, UIL regs, Heart Association guidelines, Project Adam recommendations, and what you previously have established for your EAPs and your policies and procedures. All right? Go through your program with a very critical eye, looking for accessibility and thinking 3-minute rule. We did at Duquesne, and we found there were some serious gaps. Picture you see at the top, that's actually where our natatorium is. Our training room and AED is literally in that door to the right, which would be only a few steps away. Problem is, when the doors there close, there is no access to that AED outside of a pool area. Not a good thing. So likewise, we had a situation, and it was kind of an administrative glitch that basically made a huge part of our outdoor facilities inaccessible within the 3-minute rule. So use what you have, keep it stationary where it's appropriate, but also utilize portable AED in bags where it's appropriate. On the left side, what we did, because we can't leave because of we're close to a highway and there's a lot of transients that come through, we can't keep our AEDs outside on the track area. But what we do is we've taken that concessionaire, we made sure the coaches have got keys, and we've given them instructions on it, and we mounted it on there. Here you see us mounting it in the middle, mounting an AED right outside the natatorium so they can get to it. Everything else we keep close by. We keep them either in bags so that they can grab a hold of it and get it quickly. Signage provides clarity. There's a lot of different ways to go about doing that. There's some templates in the Project Adam, but creative options can enhance your communication abilities. There's some of the toolbox AED signage out of Project Adam. Evelyn Tandy at San Xavier's High School put some posted signs outside that as part of her emergency action plan, and there actually includes the location of the nearest AED up on there. AED maintenance check. Again, this is now an auditable task. You want to confirm who's responsible for that. It needs to be performed monthly at a minimum. You're going to confirm the operational status of every, not only the unit, but every accessory. If your unit is more than 5 years old, make sure that you check with the manufacturer to confirm the status of the warranty. With time, these have to be either replaced or they have to be refurbished. Accessory kit, either near or with the AED. All right, get it. Thank you. CPR, an AED coordinator. This can be anybody, district staff. It can be someone. It could be you. Could be somebody in athletics. All right, to oversee these activities and make sure that these tasks are done. Your written CERP. There are several templates that are available. Clear method of communication, and that should be public address, PA instead of AV. My apologies. But basically, what would you say over there to get people where they need to be? All right. What about during your games? Do you utilize radios? Do you utilize hand signals? All right, for us, I know at ours, if we go hand to the chest, that's our signal that we have a cardiac issue. Make sure you discuss those during your medical timeout. Collaborate with your EMS so they're involved with this. Make sure that you're sharing the plans with those people, not just that are within athletics, but think about fine arts. Well, fine arts isn't under athletics. All right, after 3:45, if something happens, who are they going to call? Right? So make sure that we're with them. CPR training for our team members. Make it a festive occasion. Include your student aides. Don't rely solely on coaches. Hey, I have my CPR card, because sometimes that training is on and sometimes it's not. You got to make sure they know what the plans are for your facility. Put together a quick chart to locate the AEDs. So again, everyone knows where they are. Administrators. I swear 9 times out of 10, they're like the atmosphere. They are the first ones on the scene of an emergency. Make sure that they're an integral part of your overall medical team. Response drills. We need to have drills. We need to go hands-on, all right? This should not be overwhelming, because Project Adam actually has dozens and dozens of resources that actually make it easy as pie to put a great response drill in place, including the strategies afterwards. 3 simple processes to becoming a heart-safe school. There's your Texas affiliates for Project Adam, and I'm sure that if you're interested in this, you can contact any of these individuals, and they would be more than happy to assist you with that. So I had this great opportunity to put one of my grandkids in there. Yes, slid it in. So let's chat. Questions? No questions? Ooh. Going once, going twice. I appreciate it. Thank you very much. We have the resources right after that.
Okay, next up, we have Dr. Curtis, who is currently a pediatric sports medicine physician at the University of Texas Health Science Center at Houston. She received a BS from Xavier University, Master of Physical Therapy from University of Texas Medical Branch at Galveston, MD from Meharry Medical College School of Medicine, Sports Medicine Fellowship at Cincinnati Children's Hospital Medical Center, and did medical residency at the University of Texas Health Science Center at Houston. She is board certified by the American Board of Pediatrics. She is a member of the American Medical Society of Sports Medicine and the American Academy of Pediatrics. Today, Dr. Curtis will be presenting on GI issues in athletes.
Everyone, get started. All right, so I don't have any disclosures. So today I'm just going to do a brief physiology overview of the GI system, discuss some of the common issues that we see in our young athletes and some strategies to manage, prevent, and treat those issues. So GI issues, which is a broad spectrum of issues, can be present in 30 to 70% of athletes. There are many internal and external factors that can contribute. Internal meaning just specific things going on with the athlete. External could be the training environment, of course, in this good Houston heat. Heat can exacerbate a lot of these symptoms. Sometimes training at night can bring out more symptoms than training during the daytime. So various factors there. It can be physiologic, just a normal response to exercise, but there can be mechanical forces that contribute or underlying nutritional factors that contribute. If there's infection, inflammation, or emotional stress going on, cortisol, the stress hormone, can have an effect on the GI tract as well. There is a higher prevalence in endurance sports. It was initially said it was more common in women, but that's been disputed. But it is more common in less trained athletes and in younger athletes in general for various reasons. And it can be correlated with intensity, duration, and fluid status. So dehydration can make a lot of these issues worse. So as far as some of the physiologic effects of exercise on the GI tract specifically, there is decreased splanchnic blood flow to the GI tract. There are changes in the permeability of the gut. Some of you may have heard of leaky gut. Again, there's mechanical forces that can alter GI tract flow, and there can be changes in the motility of the gut. And I'll talk about each one of these in a little bit more detail. So in regards to the blood flow to the GI tract, get my little pointer. So at rest, this is in general, cardiac output at rest can be 5 to 6 liters per minute, and almost equal between the muscles and the gut as far as how much of the flow is being distributed. And then the rest, of course, is broken down among the other organ systems. But then when exercise comes into play, the cardiac output can increase. This says 25 liters per minute, but that can further be broken down into even higher for a higher trained athlete versus a less conditioned athlete. But the flow obviously gets shunted away from the gut so that more of it can go towards the skeletal muscles. It quadruples or even more. And then for the splanchnic flow in particular, at rest in general, it can be around 1.5 liters per minute, but during exercise, it can drop down to 0.3 liters per minute. So a lot of blood is being shunted away from the GI tract in order to have that availability for the muscles. And you'll note that the flow to the heart, of course, doesn't change because that's important at all times. So as far as changes in the permeability of the gut is the home for our microbiome, the bacteria, the fungi, all of the organisms that contribute to our health, our immune system, things that are important for our protective intestinal barrier, hormone production, digestion, of course, and waste elimination. And so with exercise, it's been shown that moderate intensity exercise can have protective effects. It can decrease the permeability of that barrier, and it can decrease inflammation. And it's not well quantified, but it's been discussed that with higher intensity or higher duration exercise, you kind of get to the point of diminishing return where you have increased the permeability of the gut and things are leaking into the bloodstream that shouldn't, and more inflammation can occur. The bacteria can release endotoxins into the bloodstream, again, associated with higher or more intense exercise, and those things can have negative effects on the GI tract and other systemic effects. In regard to the mechanical forces during exercise and gut motility, if you imagine a runner, there's a lot of jostling and just a lot of movement or friction going on just with the movement required for exercise. And so this is a picture of just normal peristalsis, just the rhythmic contraction of the muscles that pass a bolus of food through our digestive system. And this process is going on, throughout the GI tract, esophagus, through the stomach, the small intestine, and then the large intestine at different times. But it can become a disrupted process if time too closely to exercise, or if there's a large bolus of food before exercise. And then in some sports, such as cycling or even weightlifting, where they're in a flexed position and there's more compression on the abdomen, there's more compression of the organs. With running, there's more stretching of the space between the diaphragm and the other organs with just the up and down foot strike that occurs. So it's almost like a pressure cooker. This normal process is trying to occur, but there's a lot of shaking and agitation going on during that time. And so gastric emptying can be affected by, again, the volume of food or fluid, the pressure that's directly applied to the abdomen, or the pressure that there's certain sports that increase abdominal pressure just with Valsalva and things like that. And so those things can affect motility. It's been disputed that you can train your gut or alter the true transit time that it takes for eliminations, even though this is, this has been suggested as ways to manage GI symptoms. There's been studies that don't show a change in the transit time in symptomatic versus asymptomatic individuals. So that one's a little bit up for discussion. And so as far as the issues that the younger athletes may experience, transient abdominal pain, diarrhea, reflux, and red S syndrome are the ones that I'll talk about today. So transient abdominal pain or side stitches are very common. Again, more seen with repetitive movement of the torso or trunk rotation, so running, swimming, cycling type of sports. There's the complaint is commonly on the lateral aspects of the abdomen. Sometimes it's been said that it occurs on the right more than the left, and that's thought to be due to the liver being on that side under the diaphragm. Some athletes will complain of shoulder tip pain if the diaphragm is innervated by the phrenic nerve that shares nerve root C3, C4, C5. So some of that pain can be referred to the shoulder, or the brain thinks the pain is coming from the shoulder when it's really coming from below the diaphragm. The peritoneal irritation that occurs with running, or the jostling movement, just the movement friction of the membrane in the abdomen against the organs in the abdomen, is thought to be an explanation for this. Of course, the change in the blood flow to this area, and also just stress on the ligaments with this activity. So in regard to trying to manage these symptoms, it can also be seen in less conditioned athletes. So proper just warm-up conditioning can be beneficial. The less hypertonic fluids, so less high salt or sugar fluids right before exercise, because those can correlate with increased side stitches. More isotonic fluids, which are more of the natural occurring fluid or electrolyte balance of the body. So whether it's electrolyte enhanced water or some of the energy drinks that don't have too high of a sugar content. Strengthening the core, just so, again, with the example of a runner, the heel strike that sends those forces up the body through the core to the organs. The core can function as a better shock absorber, hold the person in a better posture to just better tolerate the activity. Proper warming up and diaphragmatic breathing, so fully exhaling and inhaling and filling the abdomen versus shallow breathing or chest breathing, because that can cause the diaphragm to spasm more or get fatigued more. Rhythmic breathing, it depends on the cadence. Again, running specific, whether inhale for 2 seconds, exhale for 3, or vice versa, or even maybe a 1-to-2 ratio, just depending on the cadence or the speed, whether it's a distance runner or a sprinter. But just methods to try to control the breathing, to theoretically decrease the likelihood that the diaphragm is getting spasmed or strained or fatigued and causing symptoms. It's also thought that they, with the foot strike or with the running, with breathing, when you exhale, the diaphragm, of course, is coming up, the liver is dropping. So just more stretch between the ligament, stretch on the ligaments that connect these structures can contribute to these stitches. Stretching on the affected side or just putting pressure on the painful area is also thought to cause some symptomatic relief. So in regard to diarrhea, we all know what that is, but there's an increased stimulation of the mucosa that releases peptides, prostaglandins that increase the activity and the motility of the gut, pull more water into the gut and pass things through more quickly. It can correlate with the intensity of exercise, but there are also some food triggers or sensitivities that the athletes may have that predispose them to this. And so avoiding high caloric meals, again, meal timing is in certain food types are a recurrent thing here to consider when managing the GI symptoms, but avoiding fatty or high caloric meals. Again, the gut training theory is disputed. Identify if it's a diarrhea truly related to exercise, if this is like a physiologic response, or is the athlete having diarrhea outside of exercise and in non-training environments, which may clue you into whether it's an illness or whether there may be an underlying medical condition or medications that may be contributing, anything like that. Make sure they're well hydrated and hydrating with the right types of substances, because again, the osmotic content or the sugar or carb content can promote a diarrhea as well. Make sure they're not trying new gels or new substances, you know, at the time of performance. If they're not, if they're not tolerating them in every day, they may not tolerate them in competition, the time for competition. And so diarrhea can be more common in athletic or weight class sports where a certain image or weight is desired. So it's important to watch out for that athletes aren't taking on unhealthy methods to try to achieve a certain appearance or weight. And FODMAPs, which I have a diagram on the next slide, are getting more attention in regards to managing groups if they're not if they don't have celiac disease. And so instead of restricting certain breads, things like that. Disaccharides are the two sugar things that, like lactose is one of the common ones, a lot of dairy products. Monosaccharides can like just globally restricting certain food groups in a population that tends to already not have the ideal nutrition. This can that allows some backflow from the stomach into the esophagus that can cause some symptoms. Sometimes there's a structural abnormality such as a hiatal hernia where part of the stomach is slipping way is to do a pH monitoring. It can be anywhere from 24 to 96 hours, and it just measures the pH in the esophagus if it's significantly or just any other things that may help to identify what the cause of the reflux is. So for treatment, it can be an acids, it can be again, dietary medications, whether identify any sensitivities or the timing of the meals, hydration, all of those things. And so with managing reflux, I mentioned some of these already, some things that are known to obesity is a risk factor for reflux. So weight management in some of the heavier athletes, avoiding caffeine, carbonation, citrus, or can contribute products, even the garment that the athlete is wearing. So some garments, of course, are more compressive, not only compression garments they wear underneath, but just for their sport, some things, just making sure it's not too tight or too restrictive. That's going to put more pressure on the abdomen and limit blood flow or cause, put them at more risk for reflux. And then if it's been difficult to kind of identify what's going on, you could also have them do a food log or a symptom log to help try deficiency in sport. And I feel like it's important to talk about. It doesn't have GI only ramifications, but I think it can be very prevalent. It can culture these days, the pressure to perform, social media is an extra factor, just comparisons to these other expectations. Take and energy. Athletes, I think it's much higher. A lot of it goes unreported. The GI specific symptoms can be vomiting, hematemesis, decreased GI motility, constipation. Frequent or irregular or longer than they should be, or if they don't ever start menses, or explanation, any of those can be indicators. Again, it can affect just about every system. It's more common in the aesthetic sports, but it can have all of these issues over here since it can affect just about every system. And so some of the things that you may see are just, even with training, decreased performance or endurance, they may have more, decreased muscle strength, depression, irritability, inability to focus, increased injury risk, more stress fractures, more illness because their immune system is compromised. It can be pretty global, but like I said, the GI specific considerations were constipation or diarrhea, vomiting, and decreased gut motility. So when you're evaluating your athletes for any of these issues, you want to take into consideration their fluid intake. Again, are they hydrating with the right type of fluids? Are they timing it properly? Are they on any medications that can be contributing to GI upset? And it's not always something intentional like laxative abuse, but are they on antibiotics for an infection that's affected their normal bacteria in their gut that can cause a diarrhea? Or was their stimulant medication dose increased, which can cause some changes or some nausea or some GI upset when they start training at this higher dose? Has their intensity or frequency or their environment of training changed in any way? Consider the nature of the sport or the environment that they train in. Are they in a sport where, again, they're in a position that may increase their abdominal pressure or Valsalva removal maneuver? Are they an indoor and outdoor athlete, which is going to have different effects here in Houston? Is the location of the complaint upper GI, where you would think about perhaps the reflux, or something involving the stomach or the small intestine? Or is it lower GI, where you would think about the large intestine or the colon? As far as when to refer, because of course this is a lot to try to, keep track of with multiple athletes, with multiple things going on when you're trying to focus on the sport that you need them for. But if there's multiple systems involved, if this is a diarrhea that's associated with a rapid weight loss or fatigue or, things like that, any skin changes, hair loss, any chronic medical conditions that you know of with the athlete in the light of these recent GI changes. Any bleeding at all, of course, is not a normal physiologic response and needs to be evaluated. Any signs of an acute abdomen, which can be a medical emergency, a rigid guarding abdomen, pain out of proportion if you palpate it. Those are things to refer for more urgently or emergently. If you've tried some modifications, you've tried, identifying any sensitivities or altering their timing, resting them a little bit and nothing is responding. And then of course, when you refer, we can get a little bit more into the genetics, the predispositions that they may have, family history or personal history, medications they're on, any psychosocial stressors that may be contributing. And so, in general, just the GI issues can be very common, and it is important to have strategies to help minimize them. It could be just a normal response, but it could be something deeper that needs further evaluation. And again, the reasons to refer are if multiple systems involved, it's not responding to your interventions, or if they have complex medical conditions that can be complicating the picture. Any questions?
We have a couple of questions on Zoom. Oh, okay.
So a lot of it, you said how many of the patients that I see are the issues related to psychosocial. And I think that there's a large component of that in general with today's youth. I won't say that it's the number one reason. It's, we always want to eliminate any organic conditions that can be contributing. I would say that there's commonly a component of that, but a lot of the times, nutrition isn't optimized. They're not, it's more of a nutrition hydration issue. A lot of the athletes are well conditioned, but I wouldn't say it's the number one reason. So, yeah, I would say it's top 10.
One of the Zoom questions was for chronic non-emergent abdominal pain, would an ultrasound be sufficient to see what you need for a differential diagnosis, or would you like the patient to get an abdominal or pelvic CT?
So, well, if I'm getting imaging, if I'm getting something like a CT, I'm looking for something, whether I'm worried about a bleed or a mass effect or some of those other issues. That's further down the line of when I would do it timing wise. They said, would I do the CT or what was the other question? What was the other thing? Ultrasound?
An ultrasound.
I think that that's more of a place to start, or even with labs. I mean, there's just a lot of steps. We always want to start with the least invasive, most informative, but there can be a lot of steps before the CT in order to work something like that up. And again, even identifying all the things that I talked about. Are there any intolerances? Are medications contributing? You know, what's the nutrition, hydration, those types.
And also, if you are well-versed in polyvagal theory, do you have an opinion on the likelihood that this might be a pathway to consider for treatment of GI disorders?
Not well versed enough in that to. Okay, thank you.
All right, for my people that are in person, I've been made aware that there is a car in a handicap parking spot with the license plate 03H25 with the headlights on. If that is your car, you can go take care of that now. Again, the license plate number is 03H25. Okay, next up, we have Poole. She is a sports dietitian resident at Memorial Hermann Rocket Sports Medicine Institute. Received her BS from Ithaca College and MS from the University of Utah. She previously was a diabetic or did a diabetic internship with the University of Utah Athletic Department. She is a registered dietitian and currently providing nutrition education and counseling services to 4 high schools, U of H, Rush University, and physical therapy clinics. Poole will be presenting on planning and timing athlete nutrition.
Thank you. Hello. Hi. Hi, everyone. Thank you for coming. My name is Poole, and today I'm going to be talking about athlete planning and nutrition. So to begin, I want to kind of lay out the format of this presentation because it is a little bit of a broad title. essentially what I wanted to do was share some information that would be useful to all the people in this room. These are kind of some common questions and situations that I find athletes come to me with or other support staff. So I wanted to go over 3 different really common adolescent athlete situations and how I would approach each of the challenges and barriers that might come up. So to begin, I will talk about early morning resistance training or morning lift sessions. Then I'll do an evening game situation and then a long duration, high intensity exercise or game situation. And within each of these, I'm going to begin with a little overview of some literature, then some practical application and examples. All right. Okay. To begin, I want to just go over some of the basic fundamentals. This is something I go over with all athletes. It's kind of the foundation for a lot of the conversations I have. And this is performance plates. So this performance plate, as you can see, is made up of 3 components. It's going to be color, which is their fruits and vegetables, their protein, and their carbohydrates. This is a good visual for them because most of these things don't change. These 3 things always kind of stay the same within the meals. The component that really changes for them is going to be the moderation of each. So as we see on the right-hand side of this slide, as intensity, as duration increases, carbohydrate needs or energy needs are going to increase. So that's going to take up a larger amount of the plate, taking up a little of the space of the non-starchy fruits and vegetables. Okay, so now that we got that out of the way, we can go into some of the situations. So I'm going to begin with resistance training. Alrighty. So a few of the situations I'm going to talk about are going to discuss pre-exercise nutrition. I wanted to summarize some of my general goals with the pre-exercise period. So especially after an overnight fast sleeping, right, or a prior exercise session, the main priority is going to be restoration of liver and muscle glycogen. So athletes are going to begin with that topped off fuel tank, right? So the next thing we're going to be thinking about is preventing hunger and then also preventing an uncomfortable feeling of fullness. So we want that just right kind of feeling. And then the last thing is preventing any sort of GI discomfort. So through any of the controllable nutrition factors that we can implement / plan for. Okay. The first area I'm going to be touching on is this lift session, this morning lift period, which commonly I'm talking to athletes about because it can be really challenging, especially for those adolescent athletes, right? It can be really hard to plan for the early timing of this. And there are some nutrition factors that can help to maximize the benefits of this training session. So it is really important to talk about. Some of the benefits might be increasing the hypertrophy and the strength gains from this session from nutrition. So this lift does primarily rely on phosphocreatine as well as muscle glycogen as the source of fuel. And it is pretty unlikely that you'll totally deplete these stores within a lift session, right? Usually that's going to occur with greater than 40% depletion, that's going to start to cause performance declines. And a lift is usually only going to deplete glycogen between 25 to 40%. So glycogen isn't really going to be the main issue here. But there is going to be some glycogen depletion of the liver while they're sleeping. So there is a little bit, but not a ton from the muscle glycogen stores as they sleep. So if they've had a sufficient pre-bed meal or pre-bed snack, those glycogen stores should be pretty okay for this morning session. What actually is going to be more of a concern is an empty stomach. So they've found that training on an empty stomach in the morning with a feeling of hunger actually can have negative consequences for the training session. So I have one study cited here that found that there were actually decreased reps in the fasted versus the fed individuals. And they found decreased markers of muscle protein synthesis within the fed resistance training session versus the fasted session. Now I'm going to go over a little bit of research related to this as well that just further shows this point. So this randomized control trial I have here was super interesting because it looked at carb-based pre-lift breakfast versus a flavor and texture matched, but kind of low energy, low carb placebo. And then they also had a completely control water group as well. And they looked at all these subjects performing 4 sets of reps till failure after they'd warm up, 10 rep max of back squat and bench press. Within the results, they actually found that the back squat repetitions were significantly greater with the placebo as well as the carbohydrate compared with the water. Another study we found was looking at carbohydrate matched liquid versus semi-solid meals prior to a lift. And they found a similar increase in the back squat performance with this associated decrease in hunger with the semi-solid trial. So what this tells us is that hunger is potentially what is to blame with these early morning, shorter duration, maybe lower intensity sessions. It's not so much the glycogen, but rather just the physiological feeling of hunger. So for this practical application, we have an athlete, they have a morning weight session, and my focus for them would be to have something in their stomach rather than nothing. This can be a super common barrier for athletes. As we know, they don't always like eating in the morning. They don't like eating before working out, or they struggle to plan ahead, wake up early enough. Or some of them think caffeine or an energy drink is satisfactory replacement for a meal. So what I would approach them with and encourage is that even if they're having a quick on-the-go snack, just to tide them over, take away some of that hunger before their morning lift, that's going to be better than nothing for that hypertrophy and for that session. So these are some quick, easy options they could go for if they're looking for just a snack or a liquid, maybe like an applesauce, granola bar, smoothie. They could go more of an on-the-go cereal cup or maybe more of a low prep option. This might be something they have to work up to, practice a little bit, and that's okay. If at first all they're able to do is have a few bites of something, for me, that is a big win. That's a step forward and is going to be more beneficial than that totally empty stomach lift session. So this will set the athletes up for success. It's going to maximize their morning lift, but it's not going to necessarily be a replacement for a full breakfast. So that's still going to be needed later in the day to meet their overall energy needs. All right. So now we're going to get into our next scenario. This is going to be pre-fuel for the evening game. So the timing of pregame nutrition can be kind of challenging for our adolescent athletes. This could be because of their class schedule. This could be from the timing or period of their lunch periods. That's not always ideal for their pre-game meal. It might be super late in the day. There also may be concerns with GI issues, which we heard about before. Sometimes this can cause athletes to avoid pregame fueling. They might be nervous that they're going to cause GI issues for themselves. However, research does show that these problems are often linked to slower digesting foods, which are foods that are higher in fat, higher in protein, or higher in fiber. Having these foods too close to exercise really tends to correlate with GI symptoms because having these foods that are slower digesting, not going to the muscles picked up for glycogen storage, and sitting in your stomach while you're trying to exercise, that's going to cause these symptoms of GI distress. So, main thing to reduce this risk could be just properly timing the meal, having a lower fat, low fiber snacker meal with a leaner source of protein and about 1 to 4 grams per kilogram of carbohydrate in that 1 to 4 hour pre-activity that can really support digestion and glycogen storage for that activity. Okay. So there are some other pretty unique situations. We all know we need to fuel for a game situation. I wanted to talk about one of these more unique situations that we don't necessarily see all the time, but it is something to keep in mind as performance staff, right? So this is going to be exercise-induced hypoglycemia. So a majority of the research supports carbohydrate feeding pre-exercise. And this does correlate with a positive increase in performance, or if anything, no change at all. But there's usually not a negative impact on performance from having carbs prior. Except there was one study in the past that did cause some concern that athletes having carbohydrate foods or beverages immediately before the start of a game would see this increase in insulin and a sudden decline in blood glucose. And that would cause athletes to begin exercise in an hypoglycemic state, which could be medically concerning or just cause performance declines because they really don't feel good, right? So this is not a super common problem. It's not as common of a problem as one study made out to be initially, because usually the body is going to adjust to that increase in insulin and blood sugar with the commencement of exercise, usually within 20 minutes of exercise commencement. I did include a study here that observed athletes who were consuming carbohydrates 75 minutes before, and 5 individuals developed hypoglycemia. When ingested 45 minutes before, only 3, and when ingested 15 minutes before, only 2. So what is really interesting about this is that it showed that 2 subjects who developed hypoglycemia in the condition that resulted in the lowest prevalence also demonstrated hypoglycemia in the other conditions. What this tells us is that there are going to be some athletes who are just more prone to having this exercise-induced hypoglycemia. I'll also note that more of the individuals who developed hypoglycemia developed it when it was consuming carbohydrates further away from that exercise period. So keeping these things in mind, this might be helpful for us when we're trying to come up with interventions here. So like I said, some individuals are more prone to it. And having carbohydrates closer to exercise might be helpful in those athletes that would have had that hypoglycemia further away from exercise. So I'm going to go a little bit into some of the interventions for this in just a moment. Let's put the situation on the stage though. So the practical application here is our evening football game. Our goals here is to begin our athlete with sufficient pregame fuel to optimize performance and reduce risk of injury and cramping and bonking or hitting the wall, carbohydrate depletion. And some of the common barriers we might think about are pre-competition nerves and GI distress, which can be associated with fueling, can be associated with gut training, can be associated with stress, pre-exercise stress. There's lots of reasons that might contribute to that. Some athletes might not want to feel too full, or they might want to feel light because they want to feel faster during the game. It might be related to the timing of their school lunch period. Maybe they have a pretty late school lunch period, and that means they're not feeling too hungry right after school. Or there might just be a really short window after school where they're really not having an easy option for them before the game. And then, of course, there's travel. All new types of barriers and challenges pop up. Okay, so how I would approach this in the ideal situation. Usually we'd recommend the meal with the timing 3 to 4 hours pre-exercise that gives enough time to digest. It should be a focus on carbohydrate, that leaner source of protein, and then lower amounts of fat and fiber, as I mentioned before. Now, this meal is going to be especially important for those athletes that have, say, a really early lunch period, or maybe they haven't fueled sufficiently throughout the entire day. Now, for the athletes that maybe do have a later lunch period and aren't feeling too hungry, it's okay for them to maybe have a smaller meal / larger snack in this after school period pregame. And then I always recommend that final fueling window to be that pregame, potentially during the warm up, to have that carb snack that just tops off the glycogen stores right before exercise. For our more unique situation, some of this is going to be pretty similar. So with the rare athlete we are concerned about rebound hypoglycemia, maybe they're coming to you and presenting with symptoms kind of similar to dehydration, with that brain fog, just feeling really not good. And this is happening again and again and again, and we can't figure out what's going on. That might be this athlete. So one way to kind of plan for this is having a substantial pre-event snack or meal for them, having them warm up properly and have high intensity sprint work within that warm up and start to bring their system into utilizing the carbohydrates. And then having carbohydrates during that warm up and then during exercise as well. That's going to help maintain blood sugar levels as well. And then finally, choosing lower GI or lower glycemic index carb sources may also be helpful. So those are essentially carbs that are going to be a little higher in fiber. So that might help also reduce some of those blood sugar spikes and drops. So some of these are similar between both athletes and could easily be intervened and implemented with. Okay. Finally, we have our longer duration, higher intensity exercise bouts. So we're going to be discussing exercise that exceeds 1 hour. It's going to be high intensity and warranting fuel during that session in order to prevent glycogen depletion or fuel depletion. So the goal is not only to delay glycogen depletion, but also to avoid GI discomfort during exercise. Some athletes are not going to truly understand the importance of fueling during exercise for their sport, or just the intricacies of it, the carbohydrate dose, the carbohydrate timing, and that's why sports dietitian can be really helpful for them, figuring out that and creating a plan for them. Research does show that having frequent doses of carbohydrate throughout the session is going to be better at preserving glycogen stores during performance. And I will note that a lot of this research during exercise has been done in endurance sports, exercising, cycling, running modalities. But we'll look at one study that was done in a team sport scenario. So we know providing exogenous carbohydrate is going to aid exercise, and it's going to prolong performance and intensity. But there's not a ton of research done in adolescent athletes, and this is the main population we're working with. So I did want to look at one study that was looking at team sport situation with adolescent athletes. So I thought this was interesting because it was looking at 12 to 14-year-old athletes who were participating in club level team sports. So they were investigating whether carbohydrates, gel ingestion improved performance in this less well-studied population. So they were all playing soccer, rugby, or field hockey. And each of them completed a randomized double-blind placebo trial where they were looking at a carbohydrate gel versus a placebo. The protocol lasted 15 minutes with repeated blocks with the shuttle test. And then they did a run till exhaustion to emulate a team sport situation. So the carbohydrate gels were ingested at regular blocks with 15-minute intervals as recommended by the research. And they found that those having the carbohydrate gels had improved intermittent endurance capacity, with the participants running 21.1% longer with the carb trial compared to the placebo. And this confirms for me that even moderate carbohydrate ingestion, about 38 grams per hour, with these adolescent athletes saw a benefit. So it extended endurance in these athletes. I will note there was not as much of a significant improvement in their sprint times and sprint performance, but this still shows me the most important part of this is when they get to the end of the game and they have that last bout, and we don't want them depleted for that. So this fueling throughout actually is helping for that final kick, that final stretch at the end. So I wanted to have a graphic here that would kind of display this for a couple of durations of activity and then some practical examples for each. Now you'll notice at the bottom here, it does change up a little bit, and that's because once we hit 60 grams per hour, you've kind of reached the peak on our single transporter carbs. So you have to go towards more of a multiple transporter carb situation. And that's where it's really important for athletes in those long ultra endurance, long duration activities to really be working closely with a dietitian. And then we get to our practical application with our soccer game fueling. So this is an intra-fueling situation with a long duration, high intensity sport. Often the recommendation is about 30 to 60 grams per hour of easily digestible carbohydrates. So some common barriers I find with this sport is that they worry about feeling heavy or slow, potentially the availability to fuel and the timing of it. With this sport, it's hard to potentially fuel when they're on the field the whole time. And then there also could be competition anxiety as well. That could be a barrier for them. So how I would approach this might look something like this. Pretty simple, utilizing maybe liquid forms of carbohydrates as well, having them have something during the warm-up, and then utilizing something like a Gatorade that's gonna provide a lot of those carbohydrates during those periods where they're not coming off the field a lot. So anytime they're coming off the field for a timeout or sub or anything, that's when we should be pushing that Gatorade to especially high load players. And then halftime is gonna really be the main opportunity for fueling. So there should be some sort of fuel table, fuel box, fuel bin, fuel suitcase I've used to have that snack, right? Something solid that's a little different from the Gatorade they might prefer, or something along the lines of this. These are some more practical options I've used in the past. You'll see on the side here that you have a picture. This is a fuel bin I made for a soccer game. So just those easy options that are gonna tide them over and help to give that total amount of carbohydrates per hour that we're looking for. So with this example, I have total of 40 grams per hour. So that should be sufficient for most of the athletes. And it's a pretty simple intervention here, but truly really important for the duration of the game and the sport and the well-being of the athletes too. Okay, so that is all I have for you today. I'm happy to answer some questions, and feel free to email me if you have any other things you'd like to ask me. Thank you. I think she asked pre-bed nutrition and hypertrophy. Is that what I heard? Hypertrophy? Yeah, that's a great question. So pre-bed nutrition can be really important for a number of reasons. Obviously, having that dinner time meal is going to be important with those athlete plates, but there also is a lot of interesting research about pre-bed protein. So as athletes sleep, that's going to be the longest time they're going to go without eating. So having a pre-bed source of protein can be really helpful to continue to give those amino acids to the muscles overnight in that recovery sleep, right? There are some forms of protein that are slower digesting. So casein, for example, is one source that can be really useful as a pre-bed protein option. Then I always try to recommend having a carbohydrate source alongside protein because athletes need very high carbohydrate amounts overall. So including that as well in most snacks is also helpful to aid in glycogen restoration and recovery. Thank you. That was a great question. Awesome.
All right, everyone. For our last speaker, I'm going to keep the intro short and sweet. Can't say the same. He'll do it for the presentation. Last up is Bubba. If you know him, I am very sorry. If you don't, congratulations. And he'll be presenting on nerves and stuff.
So I gave her that to say, I said, that's all you got to say. You can keep it short. You don't got to do the whole bio. And then she throws me under the freaking bus. Oh, it's on now. All right. So if you've been to this over the last, say, 6 to 8 years, this is not typically something I talk about. That talk's coming tomorrow. Okay. So this is something I'm not going to say near and dear to my heart per se, but you'll figure it out as we go along. So I don't really have any true disclosures or conflict of interest. Well, maybe one. The patient, and this is my wife. Help me. Don't worry about her because you're not married to her. Okay. All mistakes are going to go to Steve Schroyer's friend Doug, who decided not to come in person today and is lounging at his house on Zoom. So I blame him for all of this. So it's not my fault. All right. I hate Bloom and I hate their taxonomy. Okay. But you're supposed to have some learning objectives. Here they are. Okay. But really, if you take a couple of pearls away from this talk, I've done my job. All right. It's going to talk about understanding the nerves of the brachial plexus and distribution. I don't give a crap. Okay. I really don't. If you can take some things, and there's some really cool things in this because I had to live with it 24/7, 365. So here we go. All right. In 2021, you never ask a woman's age. I'm not going to tell you her exact age. Okay. Because divorce is expensive. So over 50-year-old female office worker, she's in the mortgage industry. Primary complaints of bilateral numbness and tingling, upper extremities into the fingers. Right was greater than left. Okay. Me, evaluated her, and I thought she had thoracic outlet syndrome. He lost distal pulses, the whole 9 yards. All right. So in early 2022, she says, hey, I'm ready to go see the doctor. Who's married? Because if it ain't their idea, they ain't going to do it anyway. So you got to wait. All right. So we went to see one of our orthopedic surgeons, diagnosed her with thoracic outlet syndrome. I'm not as dumb as I look. Hey, all right, we're good. Okay. Initial treatment was let's be conservative. Let's do a home exercise program. Let's try some medications. He had a compounding pharmacy do some kind of lotion. I called it the cream and the clear for anybody that understands Balco from back in the day. All right. And we tried that to start with. Okay. The home exercise program and the meds did not help. So during that time, the orthopedic surgeon she saw went out on a medical issue. So I sent her to primary care sports medicine for further workup. That's Dr. Bhojani. And so we went with him. Once again, diagnosed again with thoracic outlet syndrome. Now we're 3-0. All right. Got to be something to this. So we started physical therapy for TOS. And he said, if it doesn't get better, we'll do some additional imaging. I'm standing up here. So guess what? It didn't get better. Okay. So it was interesting because the initial PT eval, she goes, you've got a cervical component going on with this evaluation besides just thoracic outlet. So no relief with PT. And in fact, at times it exacerbated her symptoms. So we said, screw this. We're done with that and ordered some imaging. Plain film x-rays were done, cervical and thoracic outlet views. MRIs were done. We had got a cervical MRI and we have to get 2 thoracic outlet MRIs, one with and one without contrast. Okay. What are the results? The TOS MRIs come back negative. So my wife, that's the first one that comes back. And so we all have a version of my chart. She's reading it and it's negative. And she goes, am I crazy? And I look at her, she goes, okay, don't answer that. Right. But it did have an incidental finding of a mass on her thyroid. Okay. So we biopsied that and nothing to worry about there. But her cervical MRI came back and she's got 2-level cervical stenosis, E5-6 and 6-7. So that kind of makes sense why she was having these TOS-like symptoms. That makes perfect sense to me, right? You're going to get your one anatomy picture here in the next slide. But I went, all right, that explains it. Here we go. So if we look at it, right, we know our distribution, all that. Hey, look, we just checked off one of our learning objective boxes by having this slide right here. So now the question is what? So, all right, we get the MRI results, C5, 6, 6, 7. So I'm lucky with what I do for a living. So I pick up my phone and I text Dr. Lowe and I said, my wife needs a spine surgeon. He said, give me her name and number and somebody will call her. 15 minutes later, my wife's calling me going, who is this doctor and why am I going to see them tomorrow? I said, oh, they're the spine guy. Thank Dr. Lowe for that. So the next day we're in to see the spine ortho. So we did that. He says, yeah, you got 2-level stenosis, but since you're not a car wreck, we're going to have to go through all the conservative treatment options first, right? Or insurance isn't going to pay for it. I'm an athletic trainer. I sure as hell don't have that kind of money to do that. So we're going to start the conservative treatment. So we went to PM&R to see if we could do an epidural and if it would give her any benefit. I'm up here talking, right? It didn't work. We tried chiropractic. Why not? She tried massage. Why not? Right? Nothing's working. Let's try everything. We threw the kitchen sink at this. Symptoms are still there. So it was interesting. We're in the spine ortho's office and I said, hey, the PM&R doc wants to do an EMG. And I asked the PM&R doc, I said, why do you want to do an EMG? He goes, I want to rule out carpal tunnel. Like our whole damn hand's numb. It's not carpal tunnel related. Damn if it wasn't. So we get the EMG and it's 70% carpal tunnel involvement. So we're at the ortho spine again. And I'm like, okay, she's got this carpal tunnel involvement. I'm going to get her a appointment with one of our hand guys. So again, I'm lucky. So I park in the parking lot, walk into the ortho office and tell them I'm bringing my wife tomorrow. And they said, okay. So we go see Dr. Mansour and he does a phenomenal, if you've seen him, he does a phenomenal eval. And so he diagnosed her with something known as a double crush injury. Who'd heard of that before today? It's going to be like 3 hands, right? I'm like, what is that? So she's got compression of the nerves at the C-spine, cubital and carpal tunnels bilaterally. All right. Oh crap. What are we going to do now? So I was like, what the hell is that? I don't know. So he's like, we'll work with this. All right. So in late October of 21, we go left arm first. We do cubital and carpal tunnel releases. That gave her some relief. 10 days later, we have a 2-level cervical fusion. Those are her pictures right there. Yes, I've got permission. Don't at me. Okay. So So in the PACU post-operatively, she was able to feel pinkies bilaterally. Hey, looky there, success. We're on the road to recovery, right? 6 weeks later, we do a right upper extremity carpal and cubital tonal release. Now, my wife is deathly afraid of anesthesia. Deathly afraid. She doesn't like heights either. She'd rather stand on the ship channel bridge than have anesthesia. And she said after the neck surgery, she goes, I'm going to do my right arm. It's the same person. So we did that. And she was doing well. And then 9 to 12 months later, dun, 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 complaints of loss of feeling in the left upper extremity at the fingers, mainly ring and pinky. Where's that? That's C8. Okay. We go back to that drawing. We also had a complaint of loss of strength. She had complaints of an ice pick stabbing her through about right here, upper chest, all the way through her shoulder blade. Like an ice pick just going right through. Like crap, here we go again. What are we going to do? Back to ortho spine. Now at this point, the original surgeon had left the practice. So we're with the new guy. I texted Dr. Lowen. I said, do we go and follow the old guy or stick with the new guy? And he goes, stick with the new guy. So we did. Dr. Kleinberg. He's last year before he was here. I don't know. All right. So he said, x-rays are fine. Let's get an MRI, a CT, and an EMG. They're all negative. So the good news is it's not her neck. We don't have to do another segment. We don't have to do a big revision surgery, anything like that. But the bad news is we don't have any answers. Well, one answer, it's not your neck, right? But what is it? So he said, well, we're not going to do surgery. So that's good. Let's go to PT. You never really had any PT after your neck surgery, so let's try that. So we go to PT and she gets no relief from that. And the funny thing, ironic, funny, weird, however you want to look at it, certain things that the PT would have her do that you think would relieve the symptoms exacerbated the symptoms. So he would do something, you go, that's weird. That shouldn't be happening. So he goes, well, let's go talk to PM&R again. Maybe they think an injection would work. So we go back to the PM&R doc and they do a thorough eval. It's very impressive and a lot of questions are asked. And he said, I don't think it's your neck. I don't think an injection would help. I think it's your shoulder. And I'm going, okay, look, if I'm evaluating a thrower, I need to clear for shoulder elbow pain, I need to clear C-spine. That makes sense. It's all downstream, right? Can it go upstream? It's not a salmon, but maybe it can. And at this point, we've met the deductible. What's another MRI? Okay. And he said, if it's your shoulder, especially if I think it's your rotator cuff, it's your rotator cuff, we're going to want to inject that. And I said, look, if it's a rotator cuff, you're fired. I'm going to take her to Conway. And he's like, what? And I said, you're out. I'll take her to Conway. He didn't understand what I did. Right. So we get the MRI and I look at it and I say, I don't see anything, but it's been a while since I've looked at one of these. I take it to Dr. Crumby, the original ortho. He doesn't see anything. And what should you never do? Believe the MRI report. Partial cuff tear. So my wife's like, what do I do? And I said, it's very simple. You're going to go see Dr. Conway. The whole time the PM&R doc's going, come on in, let's inject that. And I'm like, we're not going to inject that. So I call Dr. Conway. You need to see my wife. It's all right. So off we go again. What's another doctor's visit, right? So her shoulder evaluation was normal. All right. Everything was good. She's weak, but from a stability standpoint, structure standpoint, she's good. He looks at the MRI and says, you don't have a cuff tear. They're idiots. He didn't exactly say that. I'll paraphrase it. And I don't think that's your problem. So he starts messing with her neck on cervical exam. He was off the Christmas card list real quick with her. And I'll never forget this as long as I live. He says, and I quote, I think you have lower brachial plexus neurogenic thoracic outlet syndrome. And I know I'm on Zoom and I don't really care. My wife said, and I'll quote her, what in the hell? This is where we started. Did I do everything else I've done for nothing? And he said, I'm a shoulder elbow guy, but I could tell you your neck needed to get fixed. Thank God he walked her off the ledge. Okay. So he says, now I'm going to talk to Dr. Kleinberg, and we're going to see if maybe a C8 nerve root injection would help you. We're going to talk about that, but I want you to go get an EMG. Now, you can pick up TOS on EMG two ways. Normal way, you have to have a 50% change from involved to uninvolved side. What do you think my wife's percentage was? 40, right? Oh, you're kind of, it's almost like being a little bit pregnant. Either you are or you aren't. She's right there. But all right, so the doctor kind of laughed, she's 40%. So you can't clinically diagnose her on normal MRI. Now you can put them in this position and EMG it. It's probably going to show up positive for neurogenic TOS. But at that point, when we were doing this, that study had not been published. So, so the ortho and Dr. Conway decide, yeah, let's go do a nerve block. Okay, get the nerve block, no resolution. So now what are we going to do? So one of the things Dr. Conway had said in the office is if the nerve block, if you get it and it doesn't help, I'm going to send you to Dallas to see a specialist. And I said, not that I mind driving, but do we have a specialist in the Houston area? And he said, not that I know and not that I trust. Fine. I trust you explicitly. We'll go to Dallas if we need to. So we're sitting at dinner one night. My wife says, I want to go to Dallas. Okay. So I text Dr. Conway. He said, we'll send her packet up on Monday, the next day. On Tuesday, it goes up to their office. They call, and a year ago today, she was on the phone with a vascular surgeon out of Dallas on a telehealth call to become a patient of his. Oh, right. So this guy is a vascular surgeon, and all he specializes in is TOS. And it's in here somewhere, and I'll leave it and I'll talk about it in a minute. So we go up to see him, and we get an ultrasound guided injection into the scalenes and the pec minor. And the premise is if the symptoms resolve with these two injections, you're just doing a release, in essence, of the nerve in that tissue. If it resolves the symptoms, you are clinically positive for thoracic outlet. That's the gold standard test. You think about if we go back to the MRI, we did two different MRIs. That's really looking for vascular TOS. You can't really pick up the nerve very well on an MRI, right? Too many of them there, a lot of stuff, you just can't see it. So we get the injection. It was pretty cool to watch. I don't have any pictures of that. I wouldn't be able to tell you what the hell I was looking at anyway without the doctor being there. So I'm not smart enough, so I'm not putting them in. But it was really interesting to look at. You could see the striations of the muscle. He said, we're going to see some scarring. It looks like marbling on a steak. So they dry needle it in essence. They just beat it up with a needle and he goes, it'll come back. But her symptoms were gone for about 5 days. He said, this is short living. But it did work. So he's welcome to the club. You've got TOS. But not only did she have TOS, she's now what's known as a triple crush injury. There ain't no stats on Google about a triple crush injury. I've looked. So my wife's a unicorn in more ways than one on all this. Okay. So we went back in October to have a Botox injection. So they do the same thing. They're just adding Botox in it, but it can give you extended relief. They say up to 6 months. So with a lot of their overhead athletes, if they're still in season and trying to compete, they'll do Botox injections, and there's no limit to how many you can have until either they can no longer function or their season's over, then they have surgery. So we did that. We were going on a big trip for Christmas. It'd have been cheaper to buy presents for each other, but that's okay. And we scheduled her surgery for mid-January of this year. So just like I said, some interesting things on the doctor. He's phenomenal. Greg Pearl, he's one of 10 in the nation that specialize in thoracic outlet syndrome. He's got a TOS clinic. He's like I said, one of 10. Okay. One of the other docs is in his same practice. So they may be the only one with 2 specializing in TOS in one practice. So I just asked him, the day of surgery, I said, hey, how many of these you do a week? 8. And I'm like, what? He goes, yeah. And I said, well, wait a minute. He's an office worker. In our world, it's all overhead athletes, right? But what do we get these days? This all day long. And this little sucker right here, right? Everybody's on their phone. So now we're here. So guess what? Our scalenes are under tension. They hypertrophy a little bit. That nerve scars in. That makes sense to me. Okay. So I did ask him why the loss of pulse if it's neurogenic. And he says it can be inflammation, it can be positional. He goes, who knows? Doesn't matter. We're fixing it. So, all right, here we go. We go to surgery day. So this is interesting. They do a pre-op chest x-ray, okay, for 2 reasons. They're going to look at what the first ribs look like bilaterally. They're looking at the lungs, all that. He removes the first rib. All right. He takes the scalenes off. Because I asked him, I said, what, you take the first rib off, scalenes are attached. What do you do with scalenes? He goes, same incision. I just take them off. You don't need them. Okay. That's fine. He goes, I'm going to go over to the pec minor and probably do a full release on the pec minor. I said, well, what does it do? And he goes, it just slides down and scars to the chest wall. It's not a big deal. He said, again, you don't need your scalenes for this. They're part of the problem, 80, 90% of the problem. We can get rid of them and we can do fine. And then they wrap the nerve at both spots, the scalenes and the pec minor, with the biologic to keep it from scarring again into any other soft tissues. And they did a post-op chest x-ray. She did well, took about an hour and a half, okay? Wakes up, typical post-op pain, but she goes, I can feel my pinky. My fingers, I can feel them. They hurt, but I can feel them. So she was pretty happy. So the plan was to have her inpatient for 2 to 3 days. So we had surgery on Monday. My plan was we're coming home on Thursday. He's kind of a wimp on post-operative pain, so we're going to come home on Friday in my head. Okay. That was what she's going, we're going to come home on Wednesday. I'm like, no, it'll be Thursday, maybe Friday. So while she's in there, daily chest x-ray. What are they looking for now? They're looking at the lungs. What do they make you do if any surgery that you have, that inhalation exercise, right? So she's having to do those. So day 3, chest x-ray shows atelectasis. If you don't know what atelectasis is, it is Latin for your stay will be longer and your bill will be larger. Okay. Basically, in a nutshell, it's anesthesia-acquired partial lung collapse. So they wanted to do that inhalation treatment. We want to get those lungs inflating. And we don't always use 100% of our lung capacity anyway, typically, but they want them to inflate. Okay. So that's what these daily chest x-rays are looking for. Okay. Now, she had this because of A, surgery, B, area, the proximity. So we're intubated and we're cutting right here, one of our 2 incisions. Oh, and guess what? Let's have a third issue with that. She's asthmatic. Yay me. Okay. So day 4, they look at her x-ray again, increase of the collapse. So she's not getting better, she's getting worse. They go, oh, let's go get a CT. We go get a CT. About an hour later, anybody want to hazard a guess on what happens? You'll be wrong, probably. Chest tube at bedside. That chest tube, over the life of the time it was in her, pulled 100 cc's of fluid. Okay. She was not happy about this chest tube. She said it's the worst thing she's ever dealt with, and she's had kidney stones in childbirth. So I'll take her word for it. All right. So day 5 on is kind of Groundhog Day with a little bit of a few exceptions. It's the same thing over and over. So day 5 is Friday. Guess what I'm out of? Medication and clothes. So I have to go make a Target run and buy socks, underwear, t-shirts, call my daughter meet her on Saturday, because we're not getting out of the hospital anytime soon, meet her on Saturday in Fairfield to get medication for myself and my wife. And my wife wanted another pair of sweatpants, even though I'd bought her a pair of sweatpants at Target when I was there. We didn't have coats because we were planning on coming home and it's going to freaking snow. So we're dealing with all of that. Day 7, so that Sunday, they do some testing on the fluid out of the chest tube and any sputum that she had coughed up. They looked at that. And guess what we get? Incidental finding of flu A and rhinovirus. Yeah. So we get to win the door decorating contest on the hall. So all of that, the signs, you got to wear a mask, you got to wear a gown, you got to do all this. And of course the surgeon walks in, he goes, I don't give a crap. You probably got it during the surgery or you came in with it, but it doesn't matter. I'm not going to get it from you, so I don't care. But it was interesting. I'm sleeping in the room every night, which turned out to be a godsend because that'd have been a big bill if I'd have had a hospital room. And I walked up and down the hall and never had to put on a mask. I don't know what they were panicking about. But we're still in the hospital. Day 8. I had to argue with pulmonology on Sunday because they were kind of slow rolling some things. And then on day 8, the nurse comes in with another chest tube tray and says, you're getting another one. And my wife says, the hell I am. I'm not doing this at bedside. So luckily I was able to gripe a little bit. I was relatively polite about it for those of you that know me. And they said, okay, we'll take you to interventional radiology. Now she's inpatient. We're not going anytime soon, right? So we were the last case of the day at about 5 o'clock. So they go in and do a needle aspiration under guidance. They pull an additional 500 cc's of fluid off her chest wall. And they put a second chest tube in position lower from the first. We get another 100 cc's of fluid off of that. We're 700 cc's of fluid when it's all said and done off her lung, pulmonary cavity. Okay. Again, Groundhog Day. They have a little cafe, little gift shop thing where you can buy some food and stuff. I'd been there so long, the lady's giving me an employee discount when I walked in every morning to get my Diet Dr. Peppers. And the nurses were telling me good places that I could DoorDash food. My wife was sick of hospital food. So day 9, hey, improvement. Our lungs looking better. Okay, thank God. All right. Day 10, more improvement. So that's this by now, if you're doing the math, that's Wednesday, the 2nd week. So they come in and say, we're going to take the first chest tube out. And if you look good tomorrow, you get to go home. I don't know. We'll see. She looked better. That 6 o'clock in the morning x-ray, I got pretty good at looking at those before they would remove the image off the little portable x-ray unit. Nurse practitioner comes in. At this point, our surgeon is gone. He's in St. Bart's giving a talk. Poor guy. A really crappy place to have to go for a workshop. But the nurse practitioner comes in and takes the remaining chest tube out. And at 2 o'clock that afternoon on Thursday, we got to come home. We're not done. Okay. So she begins physical therapy for range of motion, strength, and endurance. Range of motion was pretty good, but strength and endurance, I could have just marked a line through that because it didn't exist, right? But we're 2 years, 3 years of compression at this point. It's not coming back quick for all of that. So we also hired an ergonomic specialist to look at both her home office and her true office where she goes at her workstations to make sure that we didn't have any issues that needed to be addressed there. Again, if she's this way, why are we going to let her stay up here and just, hey, let's have a 15% incidence on the other side of happening and let's go through this again. No, we're not going to do it. So it was worth the money to pay for that. She still had a primary complaint every now and then of difficulty with trying to get a deep breath. All right, no problem. But I decided, we're about a month in at this point. I said, let's just go see Dr. Bhojani and get a chest x-ray and just let's look at it where it is. Is it she's worried that the lung is not doing well, or is there something going on? So we get that and look at the lung. The lung looks really good. He was not worried about it. Okay. Yeah, I'm still up here talking. There's more. So she continued to have complaints of that deep breath issue, but also pain with coughing, sneezing, and the hiccups. And probably the hiccups, she said, are the worst. So it's like, all right, let's go back to Dr. Bhojani. We get another chest x-ray. We're about 8 to 10 weeks post-op at this point. Damn if it doesn't show a costochondral fracture from one of the chest tubes. You can see it. So he's like, all right, what are we going to do? So he said, let's try some medication. Medication irritated her and wasn't working. So he said, all right, let's do a pain management consult for a possible focal injection in that spot. So he sends the information over. They call and say, oh, we can't see you until August. No, not happening. So she now goes tomorrow. So yeah, and that was last week when they called. So thank God, I do not quote me on this. And my coworkers, thank God for Dr. Bhojani. I'll never say that again, but yeah. So one of the things we have to talk about, I'm really almost done. Not a bunch of slides, but I think it's pretty important. One of the things we got to talk about is kind of what are the takeaways or the practice gaps? There's a whole lot of practice gaps and takeaways from this presentation. And I am going to end early and none of you are going to be upset about that. Okay. In our orbits, we don't know about a double crush injury, much less a triple crush injury or triple crush syndrome. What's that? Right. Our double crush in our world is a football quarterback getting high load, right? That's about it. And so, and we kind of tend to focus on that single compression site, right? It's low hanging fruit. Why are we not going to latch onto that if we're honest? And so, we've got to kind of branch out our thinking a little bit with that. I think, not all diagnostic tests are made the same. Again, that MRI with and without contrast for TOS, and it can only look at the vascular side. That EMG done the normal way, unless you get 50% change, is not going to say it's clinically positive for TOS. Okay. So if she'd have gone up here and it said you're clinically positive for TOS, that's fine, because guess what? We're still going to Dallas and we're still going to get the injection to verify that. Doesn't change anything. It's just another piece of the puzzle. Okay. You can have, this is one of my important ones right here. You can have multiple issues going on at the same time. I can't use a knee analogy of saying you got a triad, but it's still one freaking knee, right? But look at that. Hey, I think it's TOS. Ortho, I think it's TOS. Primary care, I think it's TOS. Guess what? Ultimately, it was TOS plus these other things. None of them were wrong. All of them were right? We're peeling an onion at this point. So, so I think one of the other things to remember is these type of issues, to get to a resolution or even maybe even a partial answer it's not a sprint. It's not a quarter mile. It's not even a marathon. Hell, this thing's like an ultra marathon to get to this point. And it's not even over, right? Because she's going to have a pain management consult tomorrow. Thank God my daughter's going to take notes, because my wife will go, I don't know what they said. She's as bad as some of the athletes. But it's still ongoing. And nobody had atelectasis on their bingo card. I never heard of it, right? And so, again, knowing when you've got this, I think the other takeaway that's not on here is it's okay to say no. I don't know is a perfectly acceptable answer. Dr. Kleinberg said, not your neck. I don't know what it is, but we're going to do this and this and this to peel that onion and find out. We're going to go to pain management. Pain management says shoulder, you're fired. Conway, it's not your shoulder. If it's not your neck and it's not your shoulder, we meet in the middle and what do we got? TOS, right? He's like, that's about the only thing it can be, because if it's not that, you're one hell of a case study on some other stuff going on. And so, psychiatric, but, so yeah. So, and I think one last takeaway, and I'll give you a little story on this. Don't overlook the mental and psychological toll that these take on the patient. And even me, I mean, but I'm mental to begin with. I'll just beat you to it. Okay. But one of the things that was interesting is we're sitting at the house one night having dinner, and she said, I get it. And I said, what do you mean you get it? She goes, I understand how people in chronic pain kill themselves. And I look at her, she goes, I'm not there. She goes, but I now understand it. She goes, this sucks. I can't get any relief. She goes, I used to get not mad at him and not understand him. She goes, I understand. She goes, I fully understand it now because she's living it. I'm just, having to listen to her whine and drive her to doctor's appointments because she can't navigate the medical center. So it's not a great picture, but it's my one good TOS picture. This is the little offending SOB that caused these problems. They gave it to us. It's in the refrigerator. I'm thinking of drying it out and putting it in a shadow box and hanging it over the fireplace. But we'll see what happens. Oh, thank you. I don't have answers, but if you got a question, I'll take it.
We got
All-
one on Zoom, but
All right.
do you happen to know where the other 8 TOS specialists are or how to find them?
No, I don't really care because I got one of the best that I can go see. I thought, all joking aside, I thought about looking that up, but I think the way you do it is you could Google vascular surgeon specializing in TOS. If they want to put what part of the world they live in, just write it down for me. I can actually try to, and with their contact info, I can try to contact that doctor's office and ask them if they know of one in that area. There can't be that many. He had a patient coming in from Idaho, if that tells you anything, to see him. And at one point, when my wife was walking the halls, I started counting the number of patients that were his. It was like 5. And then it dwindled down to just us, and so, but yeah. That was fun. She's walking the hall and I'm carrying her blood container from her chest tube, cruising along beside Miss Daisy. So, all right. If no other questions, we are officially done for day 1. Thank you for staying. We should add some door prizes right now. Maybe I give away the first rib. Everybody be safe going home. Same bat time, same bat channel tomorrow. Thank you.